Okay. Uh, Sir, now program on live in YouTube.
Okay.
Sir, audio is not clear, sir. Audio is not coming.
For quite a long time, we don't have much teaching the CMEs and symposiums in our department. They use the instrumental to restart this course. Then I welcome our respected professors, our assistant professors, dear PGs, and I thank our all the speakers who have accepted our request to on these topics. Thank you.
Morning, every one of you. The all so for the 1,000, I came to know the 1,200 orthopedicians are watching this program. Now I'm inviting Dr. Gopi to start the general knee examination, more specifically for the sports injury aspect.
So good morning to all. I welcome all the postgraduates and professors, those who are watching Zoom also. So my topic is examination of the knee joint. So why to examine the joint? So the ligamentous injury is not like a skeletal injury. So in the skeletal injury, we can go directly to the operation theater and do the surgery by knowing the diagnosis by seeing the X-ray. There is no miscorrelation between the diagnosis and clinical findings. For example, if there is a fracture in the both bone forearm, the X-ray shows the fracture, and also clinically there is a clinical findings correlate with the fractures. But it is not like in the ligamentous injuries. For example, the patient had a ligamentous injury. The patient suffer, there is more symptoms, but the MRI shows or radiological finding shows no abnormalities. And like vice versa, the MRI shows nothing, but patient suffers a lot. So you have to examine the patient and also see the radiological findings and correlate between these to approach our diagnosis and treatment. So to avoid the miscorrelation between clinical and radiological findings, you have to examine the patient thoroughly. Next. Then when to examine? Normally the patient present US in the acute stage or chronic stage. In acute stage, it is the injury less than 2 weeks. The chronic stage is patient present US more than 2 weeks. So in the acute stage, the patient presents with swelling, effusions, lot of pains, tenderness, restriction of movements. See, in that situations, we can't examine thoroughly the patient, and also the radiological features may give the false positive. Inflammation process is going on. So we have to wait for the more than a week or 2 weeks to settle down the inflammation process, and ask the patient to come after 2 weeks and thoroughly examine the patient. Before that, in the acute stage, you have to take the X-ray, CT to rule out any bony injuries. So ask the patient come after 2 or 3 weeks and examine the patient thoroughly. Sorry for the interruption. Sorry for the interruption. Then after then what are the points to the exam? What to exam? See, after the injury, don't directly go to the knee joint and examine the knee joint by doing the special test, all like that. Before that, the patient presents you as in the chronic stage as history of giving way sensations, history of locking, the history of fall or audible clicks in the movement of the knee joint. So our aim is to examine thoroughly and conclude whether the patient needs surgery or not, and if so, to do the surgery to give a good results for the patients. So for that, you have to see the attitude of the limb pain and muscle wasting, particularly quadriceps and hamstring muscles wasting. This is mainly for the post-operative protocol. Post-operative rehab is very much important when if there is a quadriceps and hamstring muscles in the normal contour. Next. Then as a routine inspection, have to see the swelling or effusion in the knee joint, and is there any particular deformities present or not. Then next. Palpation. After seeing the warmth, you have to see the tenderness in the particular region. For example, in the suprapatellar region, and the infrapatellar region, and sites where the collateral ligament insertion sites and all the posterior aspect. This gives the clue to clinically how to diagnose any ligamentous injury and also to avoid the how to see the avulsion injury of the ligament. So suprapatellar, patellar, infrapatellar, and medial and lateral joint lengths to rule out the meniscus injury and collateral insertion sites and palpating of the posterior aspect. Next. Then effusion, do the patellar tap test and palpation of the all bony prominences, both femoral condyles, medial condyle, tibial condyles, and head of fibula and posterior aspect. And also see the mobility of the patella, whether it's abnormal, normally or not. Then coming to the movements. As a routine, you do the active movements by asking the patient to do full flexion and extension. And then you have to check it whether it is passively attaining the full movements or not. Then you have to see the patella tracking. The patella is tracking normally or not. The abnormal tracking of the patella is called as inverted J sign. So this is the normally in a J sign, if the patella moves laterally and then comes medially, then inferiorly. This is the inverted J sign. Then after that, you have to look for the extents or lag. Ask the patient to extend from the full flexion. The final degree of 10 to 20 degree of extension is lag. It shows there is a weakness in the quadriceps or there is any evidence of the fracture in the patella. Next. Then coming to the measurements. So routine the longitudinal measurements as the true and apparent measurements. Then circumferential measurements to rule out the muscle weakness in the mid thigh and mid calf circumference. Then after doing all the clinical examination, you confirm by your diagnosis by doing the special test. This test for to rule out the instability in the single plane or double plane or triple plane, that is combined instability. The single plane instability is made either in the coronal or sagittal, that is medial, lateral, anterior, posterior. The rotating instability is in the anteromedial or anterolateral, posteromedial or posterolateral, both sagittal and coronal instability. Then combined is both in 3 plane, two either coronal or sagittal or two sagittal or one coronal plane. This is the combined instability. Next. So coming to the coronal instability. So either in the medial or lateral side, if the injury is in the middle side, the ligamentous get injured is MCL, posterior oblique ligament, posterior part of medial capsule, and ACL. So ACL is not only gives the stability to the anterior posterior direction, it also gives stability to the coronal direction, valgus and varus. So to find out the medial injury, you have to do the valgus test. Valgus is nothing but ask the patient to keep the knee in 30 degree flexion, because In extension, as I already mentioned, the cruciate will give the stability. It will become taut. To relax that cruciate, maintain the knee in 30-degree flexion, and gives the valgus force. If it opens in the middle side, it shows the positive test. Maintain this 30-degree flexion. Hello, hello. So valgus sound. Hello, hello. Say. So one plane instability, either in the coronal or sagittal. We are going to see the coronal instability, the injury of the middle side. For that, you have to do the valgus test. So to relax the cruciate ligaments, ask the patient to flex, keep the knee in 30-degree flexion. If you're not able to maintain this flexion, ask the patient to come in the lateral side. Okay. So you keep the ask the patient to come in the lateral side in the couch and maintain this in the 30-degree flexion and give the valgus thrust. So if you give the valgus thrust, if the joint is open in the middle side, it denotes the valgus instability. The lateral injury is also vice versa. You give the varus test to find out the opening in the lateral side of the joint. So this is valgus and varus test to rule out the coronal plane instability in the medial and lateral side. Other test is figure of 4 test. Figure of 4 test is for the lateral injury, that is a lateral collateral ligament injury. Ask the patient to keep in the figure of 4 position and give a thrust towards the not injured. You can feel the tautness. If it is insufficiency of the lateral collateral ligament, you can't able to feel the tautness of the lateral collateral ligament. This is the figure of 4 test. So valgus test, varus test, and figure of 4 test for the coronal plane instability. Next. Then anterior instability, that is sagittal plane instability. For that, hello, hello. Yes. So for anterior instability, the ligaments get injuries, anterior cruciate ligament. For that, you have to do the anterior diet test. You all know about the anterior diet test. Before doing the anterior diet test, we have to look for the posterior sag. Posterior sag is nothing but there is a posterior sagging of the proximal tibia. So how to look? Normally, if the patient had a silhouette of the anterior cruciate is start from the normal silhouette is maintained in the normal side. If there is normally the inferior pole of patella, slight concavity of the patellar ligament and the prominence of the tibial tuberosity. This is the normal silhouette of the normal side. If there is a sag, the tibial tuberosity is translated posteriorly. So there is no prominence of the tibial tuberosity. So this is the posterior sag. If the sag is present, you should not do the anterior draw test. This gives a false misinterpretation. That is, you have to diagnose ACL injury instead of the PCL injury. So to avoid that misinterpretation, you have to look for the posterior sag before doing the anterior draw test. So to rule out the posterior sag, then ask the patient to hip in 45-degree flexion, knee in 90-degree flexion, and you sit over the dorsum of the foot of the patient. So you hold the proximal tibia in both lateral and medial condyles by your thumb, and grasp the popliteal fossa by other fingers, and do the anterior translations. See, this is the normal side. This is not translated anteriorly. So by translation, say this is the abnormal side. You can look for anterior translation, right? So by doing the translation, you have to find 3 points. One is how whether it is translated normally or not. Then also you have to look for the audible click or not, or feeling of the click or not. Then how the translate ends, whether it is end soft or hard. So these 3 points you have to look for. How do you know that is translated abnormally or not? For that you have to know the normal translation. Normally, that as mentioned, the various figures are mentioned in various books. I took it from the Campbell. So normal translation is 6 to 8 mm from the tibial along the femoral and tibial condyles. So you palpate in the normal side and find out the normal translation. To keep in mind, ask the do the test in the injured side. That is the abnormal translation, and also find out the click. Whether it is while doing the anterior draw test, if there is a click, there is a chance of the meniscal injury. If the meniscus get injured, we can able to feel the click, and also the end point. How the translation is finally end up in the soft or hard. If it end is in soft, it denotes the cruciate ligament injury. If it end up in the hard point, that is sudden obstacle of the translation, it denotes the hard end point. So if it ends in the hard end point, there is no insufficiency of the cruciate ligament. So these things are noted in the anterior draw test. Then the another test is Lachman test. Lachman test is most sensitive test than the anterior draw test. The criteria for this are keep the knee in 15-degree or 15-20-degree flexion. So hold the proximal tibia of the left hand and lower end of the femur in the right hand, and give the anterior translations. So it is very easy in the lean patient. But if the patient is obese, it is difficult to do the Lachman test by this method. So there is a modification. So what to do is, you keep the patient's thigh over your thigh, the examined thigh, maintain this 15 to 20 degree of knee flexion. Then hold the lower end of the femur by one hand and the upper end of the tibia of the other hand. Give the translations. See, you have to very well appreciated by doing this side, this method. This is the modification of the Lachman test, right? Another test is, another modification to do the Lachman test is prone test. The edging வாங்க. நல்ல கீழே இந்த சைடு தானே, இங்க நல்லா இறங்கி வாங்க. So ask the patient to in prone and maintain the 90-degree flexion, and grasp the proximal of the tibia by your both hands and do the test. You can feel the anterior translation. Usually in obese patient, usually is not very much appreciated, but you can feel the anterior translation of the proximal tibia. This can also be done in the prone position. So why you have to maintain this by doing the Lachman test in 15 to 20 degree? Can anybody know why you have to maintain this 15 to 20 degree of the knee flexion while doing the Lachman test? Yeah, dorsal effect. See, if you do in the 90-degree flexion, there is not enough space of both femoral and tibial condyles. If the meniscus get injured, it's get trapped into that limited space, so not able to translate easily. To avoid that, you have to maintain the adequate space in the keeping the 15 or 20 degree flexion. So if if there is a meniscal injury, it's not get trapped into that. Effect is called as doorstop effect. To avoid that, you are doing this test in the 15 to 20 degree of knee flexion. Right. Next. Another test for anterior instability is Lilly's test. Lellis, Lilly's test is nothing but you have to keep the fist over the posterior aspect of the leg calf muscle and press the lower end of the femur anteriorly. If the intact cruciate, the lower end of the leg and ankle slide anteriorly, is get away from the couch. But if the patient had injured, if the patient had injured, there is not that much translation of the lower end of the leg and ankle. So that test is another test is called as Lilly's test. Then posterior sagittal instability, that is posterior cruciate ligament associated with posterior oblique ligament and arcuate ligament complexes. To find out the posterior instability, you have to do the posterior diet test. As you know, already know, the as the same like anterior diet test, we can do in the keeping the hip 45 degree and knee 90 degree of flexion. Before that, how do you know that already if there is insufficiency, already the posterior tibial condyle translated posteriorly? How do you know whether it is coming normal or abnormal? For that, you have to feel the normal position of the tibial condyle. Normally, the tibial condyle translated 4 or 3 to 4 mm anteriorly compared to the femoral condyle. You can feel both condyles, femoral and tibial condyles. There is a mild translation, 3 to 4 mm mild translation normally present in the proximal tibia. So you have to maintain that position. You have to see that normal side and also maintain that abnormal injured side in that position. Then you have to give the posterior diet test. See, if you without knowing that, without keeping the normal normal tibial condyle in the normal position, then you have misinterpretation of the findings. That is the posterior diet test, right? Then quadriceps active test. The quadriceps active test nothing but hold the ankle to prevent the extension. So ask the patient try to extend the knee joint. Again, so yes, this anterior translation shows the insufficiency of the PCL, right? Then next slide. Then it's a rotatory instability. As we saw one plane, that is sagittal or coronal plane instability. Now we are going to look for the two plane, either in sagittal with coronal plane instability. The 4 types of instabilities. One is anteromedial, anterolateral, posteromedial, posterolateral. So anteromedial is anterior and medial structures. Anterior structures and medial structures. So anterior structure is anterior cruciate ligament, then MCL and posterior oblique ligament. For this, we have to do the Slocum test. Slocum test is nothing but anterior rotation dryer test. So anterior instability and also rotation instability. So in this test, ask the patient to maintain the hip and knee in 45-90 degree of flexion and do the test in neutral side. If there is anterior insufficiency, the translation is very much appreciated. Along with that, if there is a medial instability, you axle rotate the. So normally, this is the normal anterior dryer test. The Slocum test is nothing but you have to maintain, you have to see whether the instability is in the anterior side and also in the posterior side. For that, allow the medial joint open. For that, ask the patient they make the leg in the external rotation. So external rotation, and then give the anterior dryer test. So this patient is having the anterior, posterior, and lateral instability. This anterolateral, the posterolateral instability is present. But this test is for seeing the anteromedial instability, anterior and medial instability. So ask the patient maintain the leg in the external rotation and do the anterior dryer test. So there is no anterior translation. Even though if the anterior dryer is positive, the anteromedial instability is not present in this patient, right? So and to check, for example, if there is if there is a translation more in doing the anterior translation, to counter check, if it is subsides, if it is disappears in the neutral, then it if it is disappears in the internal rotation, that shows there is an anterior medial instability. Are you clear? The patient having the both anterior and medial instability. So anterior instability, you check by the anterior droid test, right? Along with that, you have to look for, is there any instability in the medial side or not? So for medial side, you have to open the joint by doing external rotations. So by doing the external rotation of the leg and doing the anterior droid test, if the test is more accentuated, more than the anterior droid test, that it denotes the anterior medial instability. So if it is disappears in the internal rotation, there is no anterior medial instability. So, right, this is the Slocum test for looking anterior and medial structures. Then anterolateral instability is same like that. Do the tibia in the internal rotation. For anteromedial, keep the tibia in the external rotation. For the anterolateral instability, you're doing these tests to find the tibial in the internal rotation. There is two tests. One is jerk test of Angston, and another test is lateral pivot shift test. For jerk test of Angston is starts the test from the flexion to the extension, right? So they keep in the internal rotation, mild valgus, and slowly extend the knee joint. So what is the inference is, while doing the flexion, due to the IT band, the IT band falls posteriorly. So along with that, the tibia subluxes posteriorly. So the tibia in the subluxes posteriorly in the initial stage of flexion, while extending the knee joint at 20 or 30 degrees of extension, the tibia reduces towards anterior side. So that denotes the that appreciated by the jerk movement. That is the jerk test of Angston. In lateral pivot shift test, it starts from the extension to the flexion. The same like make the tibia is interrotated and keep your hand over the proximal tibia. So it is another patient. We can appreciate the patient very well, but this patient can't able to appreciate that much. So giving the anterior thrust, the left hand, my left hand giving the anterior pressure for in the 20 to 30 degree of flexion, there is a jerk, sudden subluxation. In the extension, the tibia subluxed anteriorly. So while doing the flexion, it subluxes posteriorly. That is the lateral pivot shift test. The two tests, one is jerk test of Angston, doing from flexion to the extension. Another test is lateral pivot shift test, do from the extension to flexion to rule out the anterolateral instability, right? And next, then coming to the posterolateral instability. Posterolateral instability is posterior structures and lateral structures. So this patient having the posterolateral instability. So posterior instability and also combined with the lateral structures. What are the structures? PCL and the arcade ligament complex. Arcade ligament complex, nothing but popliteus tendon, biceps tendon, then lateral collateral ligaments and popliteofibular ligament and arcade ligament. So, but the four tests are there. One is external rotation recurvatum test, reverse pivot shift test, then dial test, then posterolateral draw test. So, in reverse pivot shift test, it's same as like a pivot shift test, but in this test, we can do in the external rotation. So, external rotation. So, if normally the vertical axis, normally in the vertical axis lies posteriorly and அந்த இதை நவுத்த முடியுமா? இந்த மேல ஒரு இது இருக்காது, நவுத்த முடியாதா? அந்த சைடு நவுத்த முடியலையா? சரி பரவாயில்ல விடுமா. Front slide. Yes, that is a normal axis, normal position of the knee joint without any rotation. So in the posterolateral instability, see, this is normal lateral medial side. So if there is the instability in the posterior side, this is the medial, this is lateral. The vertical, this is a vertical axis. The axis lies in the posterior direction, and also in the medial direction. If it is in the lateral instability, the axis lies in the medial and posterior direction. To test, you have to maintain the, you have to open this joint. So for that, you have to maintain the external rotation. So making the ligament start, posterior cruciate ligament start in doing the external rotation. So to keep in the taut position, you have to check whether it is sufficient or not. For that purpose, you have to external rotate the tibia and check for the any instabilities. For that, reverse pivot shifter. Reverse pivot shifters by keeping the leg in the external rotation position and start from the flexion to extension. Same like as the Slocum test, right? Another test. Next. Another is external rotation recurvatum test. So what we are seeing is posterior structures and lateral structures involvement. So if we ask the patient, if we lift the patient leg by holding the greater toe, if there is a posterior structure, there is a hyperextension of the knee joint. If the posterior structures involvement is there, and also if there is a lateral structures involvement, the tibia get externally rotated, and also due to insufficiency of the lateral side, the knee joint goes into varus. The three things you have to observe. One is hyperextension, then varus, and then is external rotation of the tibia. You have to see the 3 points while doing the external rotation recurvatum test, right? Another test is dial test. So for this test, ask the patient lie in the prone position and grasp the foot like this, and external rotation, do the external rotation in 30 degree and 90 degree. So if you do the external rotation in 30 degree, in the side in the side, left side. So make the external rotation. So while comparing the external rotation on normal side, if it is more in the 30 degree of flexion, it denotes the posterolateral complex injury. Posterolateral complex injuries. Mainly lateral injuries, lateral structures. If it is increased in the 90 degree of flexion, then it also denotes the lateral injuries and also the posterior cruciate ligament. So I have to do the two tests in the 2 degree of flexion. One is at the initial stage 30 degree of flexion, you compare the external rotation of the foot with the normal side. If it is more, it denotes that the lateral structures involvement. If it is accentuated, that is more in the 90 degrees of flexion, it also indicates that in addition to the lateral complex, the posterior structure, that is posterior cruciate ligament, also get injured. Are you clear? That is a dial test. Next. Another test for posterolateral instability is posterolateral dry test. Anterolateral dry test, Slocum test for anteromedial instability. This test is for posterolateral instability. Then nothing but posterolateral dry test. For the posterior structures, you have to maintain the joint in the external rotation. So external rotation and mild valgus. Mild valgus. Mild valgus. Give the posterior thrust. Are you able to appreciate? This is the posterior dry test. Posterior structures, to find out the posterior structures and also the lateral structures. So in the external rotation position, the joint gets open more because of the insufficiency of the lateral structures, and do the posterior dry test. If it is more translation posteriorly, then it denotes the posterolateral instability. This test is called as posterolateral dry test. Next. Posteromedial instability is not that much common, that you can slip it. Then combined instability. Combined instability is 3 instabilities. One is either 2 sagittal on 1 coronal, or 2 coronal, 1 sagittal. So the most common is anterolateral and anteromedial. Anterior structures, then lateral and medial structures. So ACL or lateral, collateral, or medial collateral. For that, already we discussed anterior dry test for anterior structures, sagittal plane for varus and valgus test. Right. Then another combined instability is anterolateral and posterolateral. So anterolateral, anteromedial, then anterolateral or posterolateral. Anterolateral structures and posterolateral structures. 2 structures are involved. For that, as I mentioned, external rotation recurvatum test and pivot shift test and varus test. So external rotation recurvatum test for posterior structures. The lateral pivot shift for anterior structures. Then varus test for lateral structures, right? Then another combined instability is anteromedial and posteromedial. So anteromedial and posteromedial. Anterior structures, posterior structures with medial structures. Three instabilities are there. So for anterior structures, we can do this Slocum test, anteromedial instability. For posterior test, we can do the posterior dry test, right? Very clear? So the combined instability, the three plane instability, right? Two varus, two sagittal or one coronal, or two coronal, one sagittal plane instability. Next. So this is the extra ligamentous, that is the cruciate ligamentous injury. Then we can go for the meniscal injury. As you know, the medial meniscus is more common injury than lateral side. And also there are various tears are there, bucket and tear, radial tear, parapic tear. But among that, longitudinal tear is more common, that too in the posterior horn of the medial meniscus than the lateral meniscus, right? So the patient presents us with clicks, history of clicks, snaps, locking sensation, history of fall. These are all the indication of the meniscal injury. Next. How do you test meniscal injury? The one test, as all you know, the McMurray test. McMurray test is ask the patient keep the knee in the full flexion of the knee joint. Hold like this. Full flexion, mild external rotation, valgus. You hold the knee joint in the proximal end and slowly extend. If the patient had a meniscal injury, you have to check whether it is pain in the initiation of the flexion or mid flexion or in the extension. So if there is a initial pain in the initial flexion, it denotes the posterior horn. If the patient have pain in the mid flexion, it is denotes the body of the meniscus. In the extension side, that is the anterior horn. So how do you know whether it is medial side or lateral side? So if you external rotate, it denotes the medial side. If the internal rotate, it denotes the lateral side, right? Then next. Another test is Thessali test and squat test. So Thessali test is ask the patient to hold the body with the support of our arm, palm. In the left தானே லெஃப்ட் காலை மடிச்சு ஒரு 20 டிகிரி லெஃப்ட் கால் கொஞ்சம் வளைச்சிங்க உள் சைடு திரும்புங்க வெளி சைடு திரும்புங்க ஏத்துல வலிக்குது பெயினா இருக்கு so see ask the patient to rotate internally and externally. If the patient is having pain in the internal rotation, there is a chance of injury in the lateral side. If the patient has had pain in the external rotation, there is a chance of injury in the medial side. This is the Thessali test. Then squat test is the same like the Thessali test. Ask the patient to squat with the internal and external rotation of the foot. பண்ணுப்பா இல்ல இப்படி வச்சுட்டு உட்காருங்க போதும் எந்திரிங்க இப்படி வச்சுட்டு உட்காருங்க வலிக்குது. So patient having pain in the while doing the internal rotation. So there is the lateral ligamentous injury, lateral meniscus. Right. This is the squat test, Thessali test and squat test. Then next. Applis grinding test. மேல போடுங்க. The Applis discovered two tests. One is grinding, compression, distraction test. Compression test is called as grinding test. குப்புரைக்கு போடுங்க. குப்புரைக்க. இந்த காலா சரி. Make them prone and flex the knee in 90 degree of flexion. And the compress the leg towards the femur and internal rotate and external rotate the leg. If the pain is if the patient appreciate pain in the internal rotation, it denotes the lateral structures. The pain appreciated in the external rotation denotes the medial structures. That is the Applis grinding test. Then Applis distraction test is distract the joint and rotate the leg. That denotes the collateral ligament injury, as you know very well. Then I think I covered. I think I covered some of the examination regarding this knee sports injury. Can you anybody tell who is the father of modern orthoscopy? So because this is a sports injury symposium. Sir, right. Next slide. The Masaki Watanabe is the modern of arthroscopy. He is the Japanese surgeon, introduced the arthroscopy since the 1970s. Thank you.
Next presentation, I invite Dr. Jai Vignesh to present the topic on X-ray in knee injuries.
Morning, sir. Morning to one and all present here. Hereby present here to present the topic on X-rays in sports injuries. Myself, Dr. David H, final postgraduate, author for Professor M.A.V. Introduction. The major role of X-rays in sports injuries is in acute sports injuries, as sir said in the before presentation, which is less than 2 weeks, to rule out any fractures and dislocations. In chronic set of sports injuries, to rule out any osseous abnormalities, if any is present, and the skeletal abnormalities and malalignments which is predisposing to ligament injuries can be identified with the radiograph. Radiographic views, the standard radiographic views which we used to take in any is anteroposterior view and lateral views. Further, on clinical examination, the supplemental views and special views are taken, warranting any clinical correlation. Anteroposterior view, the patient pushing, the patient in supine position with the hip, leg, and knee extended, and knee and ankle is joined to the contact of table, and the center of beam, which is focused to 1.3 centimeter inferior to the patellar apex, with 5-degree deflectal. Normal anteroposterior view, the normal structures and the gross femorotibial alignment is evaluated. Lateral tibial plateau structures. The lateral tibial plateau structures are wider than the medial side, and the patella, which should be located in the center of the distal femur, and the lateral aspect of tibia, which is partially superimposing the fibula, head of fibula, the normal alignment of the antero. The anteroposterior, the medial and lateral margins of the femoral condyles and opposing tibial condyles alignment is assessed, and the patella should lie centrally over the distal femur, and the fibula head partially overlapping the tibial condyle. Clinically, if we want to see any varus or valgus abnormality, we have to take anteroposterior scanogram of the lower limb. Specialized projections in anteroposterior view, we have weight bearing view, Rosenberg's view, Tunnel's view, varus valgus stress views, and internal external oblique views. Weight bearing view, patient is in upright position, where knee in anterior aspect, patellar or apex facing the beam raise, and ensure that there is no knee tibial intorsion or extorsion, and a single knee full weight bearing on the affected side is done. And weight bearing view is always preferred whenever possible to identify any joint space narrowing or tibial malalignment. This is the difference between the non-weight bearing anteroposterior view and the weight bearing anteroposterior. Gross difference in the joint space narrowing is present. So always prefer weight bearing view whenever it is possible in chronic settings. In acute settings, we cannot take weight bearing view. Next is a tunnel view. Tunnel view, the patient positioning is a patient in supine position with the knee in 45-degree flexion, and the beam which is perpendicular, the beam should be projected perpendicular to the tibial alignment. The view is to mainly is to main advantage of tunnel view is to view the posterior aspect of the intercondyle notch and the inner posterior aspects of the medial and the lateral femoral condyles, which is this tunnel's view is ideal for the suspected osteochondrous dissecants. Suspected osteochondrous dissecants, which occurs more posterior. Case of normal antero tunnels view, where the posterior intercondylar notch is viewed much more, and the posterior aspect of the medial and lateral femoral condyles are viewed better than the anteroposterior conventional anteroposterior view. That is the case of osteochondrous dissecans, which is occurring on the medial femoral condyle of the posterior aspect, which is seen on the tunnel view, which is missed on the conventional anteroposterior view. Next is a Rosenberg's view. Rosenberg's view is a modification of the tunnel view. Next is the Rosenberg.
I think it's need to rotate the camera, sir.
Rosenberg view, modification of a tunnel. a Rosenberg view, which is a modification of a tunnel view. It is a flexed posterior anterior weight bearing view, in which knee flexion of up to 45 degrees is done. 10-degree Kepler tilt the beam, for which it is the tunnel's view, weight bearing is not done. In Rosenberg's view, weight bearing is done for a proper measuring of the femorotibial malalignment, and joint space pathology is present in me. The better appreciation of joint space and the posterior aspect of the femorotibial joint assessed in Rosenberg's better accuracy than the conventional weight bearing view, as well as the tunnel view. Here, the conventional weight bearing view, where left side there is a joint space narrowing, annual joint space narrowing, and right side there is no joint space narrowing, or there is no joint space approximately. In Rosenberg's view, viewing the posterior aspect of the condyles, better apposition of the joint space narrowing is present. Further, we are seeing the abnormal radiography in the anteroposterior views for few pathologies. Articular cartilage injuries in osteochondritis dissections. The tunnel's view is the most ideal. You can see normal anteroposterior view. We can see the lesion of osteochondritis. The tunnel's view is the medial aspect of the posterior condyle. The lesion is present. We discuss in the next posterolateral corner injuries. The avulsion flux of the proximal fibula at the height of insertion of the arcuate ligament complex, also called as arcuate sign, equally associated with cruciate ligament. Discuss this. This is a case of anterocruciate ligament injury. The tibial spine avulsion fracture is present. The anteroposterior. Avulsion in the anterocruciate ligament, tibial spine artery, femoral spine avulsion fractures can be diagnosed in this case. Case of Sigon's, this is a case of anterocruciate ligament injury where there is a avulsion of the lateral tibial rim is present, also called as Sigon's fracture, associated with 75 to 100% of. Case of discoid meniscus, where any patient, any pediatric patient, lateral joint line pain, X-ray which is seen as a widening of the lateral joint space, firing of the lateral femoral condyle, and the cupping of the lateral tibial plateau. Normally, the convex or flat surface of the plateau is lost, and there's an increase in concavity. Cupping indicates the discoid lateral meniscus may be present in it. So, anterocruciate views, some pathology. Lateral view, patient positioning in lateral ligament position and flex the knee to 10-degree Kepler tube. Lateral view, what all we should see is the Blumenschart's line is representing the roof of the intercondylar notch, plus the facial scar. The patella positioning should be between the facial scar and the Blumenschart's line. Any lateral radiograph where the screening for patella posturing, any alta or patella halter is a superior dislocation or patella vasa in superior dislocation, we can see from this. Located between the two lines and the suprapatellar bursa, the proximal extension of the joint space. It is a 1 to 2 mm thickness vertically oriented between the anterior. It is 1 to 2 mm thickness space. This one, which is vertically oriented, located between the margins of the distal super and the posterior margins of the proximal diagram. We discuss in the later. Trochlea. What are the things we should see in a normal lateral X-ray? In a normal knee, the Blumenschart's line is continued anteriorly to the trochlear groove. It should stay posteriorly to the femoral condyle. It's a normal thing. It's the trochlear groove line. It's a Blumenschart's line. Blumenschart's line continues anteriorly as the trochlear groove line. This trochlear groove line should stay posterior to the anterior femoral condyle or anterior facet. Crossing signs indicate the crossing over of the trochlear groove line over the femoral anterior aspect of the femoral condyle indicates cross sign, for which trochlear dysplasia should be evaluated. Presence of trochlear dysplasia, the reason we are seeing for this is the presence of trochlear dysplasia predisposes to patella dislocation and more prone for sports injury. This is another method to elicit trochlear groove, trochlear dysplasia. The line X is drawn in the anterior femoral cortex line, and this is the Blumenschart's line, and the trochlear groove line continues. This trochlear groove line normally stay posterior normally it should stay posterior to the trochlear groove line, should stay posterior to the anterior femoral cortex line. If it crosses beyond the anterior femoral cortex, it should be 0.8 mm posterior to the anterior femoral cortex line. 3.2 mm anterior indicates dysplasia. This is another X-ray for a trochlear dysplasia, where first posterior femoral cortex line is drawn, and at the level of the roof on the trochlear sulcus roof, perpendicular to this line, posterior femoral line, a perpendicular line is drawn, and a 15-degree angle to this reference line is taken, and this depth of A to B distance of trochlear sulcus is evaluated.
Sir, there is no audio, sir.
To make the points A and B. How do you find that is the point A? Then one more point B. You are connecting and extrapolating the line and cutting that perpendicular line. Okay.
The first posterior femoral cortex line
Cortical line
is drawn, sir.
then perpendicular line.
To that line, another line is drawn, sir.
You are
For
making
that line, 15-degree subtending angle is drawn. The line crossing the trochlear groove line is 0.3, sir, and the line crossing anterior femoral condyle is 0.8. It's another case of trochlear dysplasia. The distance of more than 3.2 mm increase in decrease in distance indicates a decrease in the trochlear sulcus, and trochlear dysplasia to be evaluated in further. Another case of trochlear dysplasia, which is a type E, where supratrochlear sulcus, there is a crossing line which is present, as well as supratrochlear spur will also be present in case of further stages of trochlear dysplasia type E. I think first trochlea is evaluated, after that patellar shape is evaluated. Patellar shape correlates with the tilt and morphology of the patella. Normally, the most posterior part visible is the medial longitudinal ridge, and the lateral facet is slightly anterior to it. In the tilted patella, the patellar relations are lost. The dislocated patella, where the patella appears, one finding is that the patella, whenever the patella appears larger than the normal lateral X-ray, we should evaluate for further tilt or further patellar height. The insult salivity ratio is measured. The ratio between the patellar tendon length to the longest in the longest to the longest diameter of the patella. Normal ratio is 1, sir. Ratio greater than 1.2 is patella alta. Ratio smaller than 0.8 is patella alta. Cat Dexon's ratio, the ratio between the distance from the lower edge of patellar articulating surface to the anterosuperior angle of the tibia to the length of patella articulating surface. Value greater than 1.2 is patella alta, and smaller than 0.6. Next, the Blackburn field index ratio. The ratio between the length of the perpendicular line drawn from the tangent of the field plateau to the inferior pole of the articular surface of the patella to the length of the articular surface. Normal is 0.8, and the value smaller than 0.5 is patella baja, and value greater than 1 is patella alta. All the three indexes, we usually calculate insult salivity, but it is not a good size. It's the presence of Osgood scatter disease, where there is a fragmentation of the field plateau, and we could not measure. cat and Deschamps seems easy to use for surgical planning. Next, few pathologies we can see in lateral radiography. Anterocruciate ligament, you can see a deep femoral sulcus sign, but the infection due to the cortical infection and deepen uh, during the mode of injury in hyperextension injury. This sulcus more than 2 mm indicates deep femoral sulcus sign. If present, we should evaluate for anterocruciate ligament. And normally, posterior tibial angle should range from 5.2 to 6.3. The posterior tibial slope is calculated on the posterior tibial cortex line and the line along the tibial plateau. The angle subtending this is a posterior tibial slope angle. Normally, the ratio is 5.3 to 6.3. Angle more than 10 is a potential risk for anterocruciate. Further graph read here also it's potential risk. Next, in posterior cruciate ligament injury, normal anterior as said, normally there is a 6 to 8 mm of anterior translation. Here there is a normal anterior step off is lost and the posterior sagging present in the lateral view. Also, we should look for a tibial spine avulsion fracture as well in the lateral X-ray or posterior cruciate ligament. The case of osteoarthritis disease, where the apophysis of a tibial tubercle due to repeated microtrauma in adolescent cases, in chronic catalytic, but the X-ray finding may take like bony fragmentation. It takes up to 3 to 4 weeks after onset. So initial diagnosis of osteoarthritis should not be made with X-ray, but clinical diagnosis. Next, in acute setting, in acute trauma, we cannot put the patient in 30-degree flexion, as well as we cannot turn the patient. So cross-table lateral view is taken, where the patient lies in supine position, and the cassette is placed medial to the plane, and the beam is projected from the lateral aspect. In the cases of joint effusion and suspected intra-articular fracture, where we could not flex the knee or we could not manipulate the joint, we can take. Case of knee joint effusion, this is a 1 to 2 mm thickened suprapatellar joint space synovial line. Anterior to that is a anterior suprapatellar padafer. Posterior to that is a posterior suprapatellar padafer. This is the case of moderate effusion, where the increase in thickness, the two arrows pointing the fluid levels. Increase in thickness indicates the moderate effusion. They can calculate in the lateral X-ray as well as the fat pads will be separated away from the joint effusion. Patient with the intra-articular fracture or tibial spine avulsion fractures in anterior posterior injury, fat from the marrow will be seeping out and will be present in the joint. Lateral radiograph, there is a fat fluid level. The line usually the fat will be above and the blood and the water will be below. So the fat fluid level which is present for this X-ray, 5 minutes of resting should be required for proper separation of fluid and the fat. Next is the axial view, which is in patellofemoral pathology. Axial view of choice, more view you take is a superior inferior view of patella, where a patient is going position and knee in 45 degree position. X-ray it is seen 30 degree from horizontal. Normal Merchant's view. Merchant's view 2 angle we should calculate. Sulcus angle and congruence angle. Sulcus angle will keep the shape of the trochlear groove and trochlear is present between. And greater normally there's a normal sulcus angle. Average is 138 degrees, but both same in male and as well as if more than 150 degrees is abnormal, should evaluate for trochlear dysplasia. Congruence angle calculated the angle, sir, the lateral facet and the medial facet, and the reference line is drawn bisecting the line O, it is a reference line drawn bisecting the sulcus angle, and another line is drawn from the point A to the patellar apex. That the angle between the two should be calculated. Normally, the angle should be in negative state. The patellar apex line should be in the negative phase. That is in the median. That is on the medial side. Positive. The reference, the patellar apex line staying on the positive side should be evaluated. Skyline Lauren view is the inferior superior view of the patella, where the patient is sitting or recumbent position, knee in 20-degree flexion or 20-degree inflection, and inferior superior view of the patella. But in Lawrence view, we should calculate two angles. This is the lateral patellar femoral angle. Lateral patellar femoral angle, one line is a horizontal line drawn connecting the medial superior point of the medial lateral superior point of the medial facet, and the line joined parallel to the lateral articulating surface. This should be opening laterally and should be closing medially. Any derange from that is closing laterally or not closing medially should be evaluated. The patellar femoral index is the ratio between the thickness in the medial joint space and the lateral joint space. Be 1.6 or lesser. Any change in this could be evaluated for patellar femoral derangement or morphology or dystocia. Next is the sunrise view. Sunrise view, the patient is prone position with 150. The main disadvantage is that once the patient flexes more than 90 degree or up to 150 degree, the patellofemoral joint, the patellar articulating surface is present, but the femoral articulating surface will not be seen in this. So, prefer Skyline view or Merchant's view compared to sunrise. Next are the stress views. Stress views are taken if there is a first patient comes, we will examine the case, and if warranty clinical correlation, we will take steps. For example, if medial collateral ligament or lateral collateral. First, the rarest step radiography. Patient in the 20-degree inflection in neutral tibial rotation. Case of demonstration of neutral tibial rotation. Now, the opening of more than 2.7 mm difference, both sides are taken. Difference in more than 2.7 mm indicates that's a possible injury in the collateral ligament. More than 4 mm difference indicates possibility of posterolateral corner injury. Valgus test view, similarly taken, sir, with the patient in supine position and 20-degree flexion with the valgus test view given. Difference of more than 3.2 mm is significant for superficial medial collateral ligament, and more than 9.8 mm indicates associated ligament injuries as well. Next is the posterior stress, measuring the posterior translation distance. The posterior translation distance is measured since the posterior tibial cortical line. The line is drawn from the tibial cortical line to the Blumenschart's line, posterior point in the Blumenschart's line. The distance between the two is measured. Normally, 0 to there is a clinically there is a lost articular stress of, and to 0 to 7 mm we can translation percent we can suspect for partial posterior cruciate ligament. 8 to 11 mm posterior translation, possibility of complete posterior cruciate ligament. More than 12 mm is associated posterolateral corner.
Very good and excellent elaborative presentation. Skeletal radiology of the sports injury.
I would like to invite Dr. Jay Ganesh, Assistant Professor, to give a talk on MRI and sports injuries.
Raising arthroscopic start. Going to Jay Ganesh, going to present MRI. The raising are there. Professor Palani and Karpasamy. Rising star, most welcome to present MRI. Sports area.
MRI sports.
MRI.
Morning. Thanks for the opportunity. I'm presenting MRI of the knee. Initially, I just wanted to give you a brief introduction about how a normal knee MRI looks. So this is okay. Fine. Laptop login. So this is a sagittal view showing we are starting from the lateral. Initially, you can see the fibular head over here, and over the fibular head, the biceps femoris is getting attached, and from there, the fibular collateral ligament is seen here. Usually, fibular collateral ligament is not very well seen in the sagittal image. As we proceed laterally, we'll be able to see the meniscus. So it is important to establish the equality of the anterior horn and the posterior horn in the lateral sagittal image and the connection between the anterior and posterior horn, which is the body. So as we proceed medially, you'll be able to see the anterior horn and posterior horn separately. And in a sagittal image, it's one of the ideal images to see the anterior cruciate ligament and posterior cruciate ligament. And sagittal oblique view is very good for anterior cruciate ligament. So what you're going to see in a normal anterior cruciate ligament anatomy is, MRI anatomy is, the tautness of the anterior cruciate ligament and whether the fibers are parallel to each other, and the fibers are steep and parallel to the Blumensatz's line, and it is in continuity with the fibers from arising from the tibia. And further to that, we can see the posterior cruciate ligament arising from the posterior aspect of the tibia and getting attached to the lateral aspect of the medial femoral corner. And as we proceed medially, sometimes they misinterpret this thing as a tear. There is actually a connection between meniscus, which is the intermeniscal ligament, and we proceed medially. We are going to see the medial meniscus. Okay, this is the medial meniscus, and again you'll have to see the equality between the anterior and posterior horns and the body of the medial meniscus. So this is a this is the axial view. And axial view, what are the important things that we're going to see is the articular cartilage behind the patella and the long lateral facet, the short medial facet. And this is how we identify medial and lateral. Okay, that is the lateral facet is long, the medial facet is short, and you'll have to also see the continuity of the medial patellofemoral ligament and lateral patellofemoral. The other things that you need to establish here is near the joint, whether you are able to see any Baker's cyst or popliteal cyst. This usually is present in this region, which is between the semimembranosus and the midlet of the gastrocnemius. So this is the coronal view. Okay, the coronal view. What are the important things to establish whether it is medial side or lateral side? The first thing that we are going to see here is the medial collateral ligament, thick band with low signal extending from the medial epicondyle to the tibia. So then you'll see the anterior cruciate ligament, and in this slide we are not able to see. We can see the iliotibial tract as well. Okay. So as we proceed laterally, we can see in the lateral femoral condyle, the shape is almost that of a face having a neck. This contour is very typical of the lateral femoral condyle. That is also helpful in establishing the lateral femoral. As we go more posterior, it becomes more obvious that we are able to see the fibula. So that is the lateral side, and you can see the fibular collateral ligament getting attached here, and also the biceps femoris. The popliteus is not so obvious, but it is visible here. Now we can go to the PowerPoint presentation. So we'll just discuss the most important topics, not the entire MRI. So how to read MRI? These are the most important steps. Know where to look for which structure. So for that, you need to know how a normal MRI looks. So for that, just like how you read a normal X-ray, you need to see and look for each and every MRI, all the sequences. Even if it is a normal MRI, keep on seeing the normal MRI. That's how you'll be able to spot what is abnormal. So always correlate clinically. So clinical examination is very important. You find out something abnormal, you look in the spot in the MRI, that's how you diagnose. So arthroscopic diagnosis is always final. So there are a lot of sequences in all the MRIs, but the most important thing for us is you'll be able to see all the tendons and ligaments are in all the sequences. If there is some hyperintensity, there is some. Okay. And in T2 images, you all know that is fluid is bright. This is the two most important things that you need to do as an orthopedist and MRI. So we'll discuss according to these topics. The first one, I'll take the difficult one, that is meniscus. So how do you see the medial meniscus, the equality of anterior and posterior on, and in medial meniscus, in medial. So you'll have to see the medial aspect of the tibia. The medial aspect of the tibia looks like a good T. It's not convex, it's concave. Okay. So when you go laterally, it becomes more convex. That's how it differentiates in the sagittal image medially and laterally. And you can see this thin dot connecting both anterior and posterior, medial and lateral meniscus. That is the intermeniscal ligament. In the coronal image, you will be able to see the equality of this triangles, two small triangles on the medial and lateral aspect, and they are contained within the tibia. There is no meniscal extrusion. So what you see on the far sagittal image is two small triangles getting connected by a dot. This is a classical appearance of a bow tie. Okay, this is how a normal MRI looks. So whenever we get an MRI report, we get all kinds of grading according to the radiologist. We are getting confused with grade 1, grade 2A, grade 2B, 2C. So most important things regarding the grading is whether the tear is extending into the articular surface or not. If the tear is extending into the articular surface in one image, one sequence, that is not important. Whether it is getting extended in 3 or more images, that is important. And the third grade is the most important part, that extends into the articular surface. That is a definitive tear. Okay, this is what you should be aware about. Okay, so these are the various types of meniscal tears: horizontal flap tear, vertical longitudinal tear, horizontal tear, bucket handle tear, but we'll see the common appearances of the meniscal tear. The horizontal tear, this is how it looks. The horizontal tear in the arthroscopic image, and you can see in the sagittal image the tear that is extending along the line of the fibers and into the articular surface. In the far coronal image, you can also see the horizontal tear extending. And longitudinal tear, that is the vertical tear, you can see the vertical tear in the sagittal image in the posterior arm of meniscus. So radial tear is one of the difficult tears to repair and also diagnose. So you can see the bow tie appearance getting disrupted here. So bucket handle tear, one of the very interesting meniscal tear. So this is the area that the meniscus has displaced, gotten into the joint. So these are the various types of meniscal bucket handle tears that you should be aware about. One with closer to the anterior root, and one which is between the junction of anterior and middle third, one with the intact anterior range and a disrupted posterior range, and one with the intact posterior range and a disrupted anterior range. Okay, so this is how a 3D animation looks and how the bow tie appearance is maintained in a normal MRI. But the in bucket handle tear, the bow tie appearance is disrupted as you go medially. So another finding that you find in a bucket handle tear is a double PCL sign. In the section where you see a PCL, you are able to see there is another So here you can see the red arrow mark showing the flip bucket handle component of the meniscus, which is parallel to the posterior cruciate ligament. It is very common with the bucket handle tear of the medial meniscus. So flipped meniscus sign, here you are seeing that A is the anterior horn of the meniscus. This almost looks like a normal meniscus, but this is the flipped meniscal component that is inside the joint that is behind the anterior horn of the medial meniscus. So double anterior horn sign is almost known as the fast forward sign, where the anterior horn of medial meniscus is there and the flip component is there right next to each other, looks like a fast forward sign. So in coronal image, you are able to see the flipped component of the bucket handle component, which is visible next to the anterior cruciate ligament. So this is another important thing, which is where you have a bucket handle component of both medial meniscus and lateral meniscus. Here ACL tear is also there. This one is ACL, two is PCL, 3 and 4 are medial and lateral. So this is how an orthoscopic image of the bucket handle component is present. Come inside the joint next to the ACL. So next thing is the root tear. Root tear you are able to see in the coronal image. As you go more posteriorly, you'll be able to see deficiency in the posterior aspect of the posterior horn of medial meniscus and the posterior root at the junction. And you'll also be the subtle changes. You'll be also be able to see the meniscal extrusion in the coronal image. So this is another example of a root tear. You are seeing in the axial image there is a hyperintensity near the junction of posterior horn of medial meniscus and the posterior root. And in the coronal image, you're able to see near the insertion, and here as well in the sagittal image. Next, we'll go to the important ones, the ACL and PCL. Normal anterior cruciate ligament, as I told earlier, is taut, is continuous, is parallel to the Blumen's line, and it's steep. Okay, it's not lax. So this is an example of torn ACL. So again, the radiologist gives you two types of grading when the MRI comes. That is grade 1, grade 2, grade 3, and also high grade tear, moderate grade, medium grade tear, or a low grade tear. So low grade is actually less than 10%, medium grade is actually less than 10 to 50%, and high grade is more than 50%, and we are more worried about this high grade tear. And as well as in grading, grade 3 is a complete rupture that we are more worried about. So this is a normal example of an acute ACL tear where you can see it is edematous and there is a tear in the intrasubstance area. And this is an example of a chronic ACL tear where the ACL is completely not visualized. This is another example of ACL tear where the ACL has become edematous and you are not able to visualize the
high grade partial tear.
high grade is more than 50%. near complete grade 2 வரும்.
Then அது near
Near complete வந்து more than high grade தான் வரும். Clinically, we'll have to decide it clinically, sir. Yes, sir. So again in the coronal image, you're able to see the empty notch, okay, where the ACL is not occupying the intercondylar notch. In partial ACL tear, the fibers are still present, but they are not perfectly parallel to each other, and you can see the laxity that is there in the partial ACL tear. So this is another example of an ACL avulsion injury where the tibial spine is avulsed and the fibers are a little bit lax. So what are the other indirect signs by which if you are able to find out if the ACL tear is present or not? You'll be able a patellar buckling sign in the sagittal image where it is not, where there is a buckling present in the ACL, and there is another thing known as lateral femoral notch sign here, where a deep depression in the middle of the lateral femoral condyle because of condylopatellar sulcus depression. If it's more than 2 mm depression, is known as a lateral femoral notch sign. So another thing in the sagittal image, in the mid-sagittal image of the lateral femoral condyle, you're putting a line along the lateral femoral cortex and the posterior femoral condyle. And if the translation is more than 7 mm, it's positive for anterior cruciate ligament tear. And you can also see this part of the lateral meniscus which is uncovered, which is typical of the anterior translation, indicating that it's a anterior cruciate ligament tear. So you're able to see PCL buckling, which is recently found out to be not very specific for ACL tear, but still when you're able to see this amount of buckling, which is also an indirect sign of ACL tear, and PCL line sign, you will draw a line along the posterior aspect of the posterior cruciate ligament, and if it doesn't intersect within the distal 5 centimeter of the posterior cortex of the femoral condyle, it is indicative that it is positive sign for PCL line sign, which is present in ACL tear. So there is also evidence of sharing of the infrapatellar fat pad because PCL line sign is you draw a line along the posterior border of the posterior cruciate ligament, sir. This line usually intersects within the 5 centimeter, distal 5 centimeter of the femur. If it doesn't intersect, it goes above, it means PCL line sign is positive, indicative of ACL tear. So sharing of infrapatellar fat pad, we can see the white fluid extending all the way along the suprapatellar fossa. And bone bruises, especially the valgus and internal rotation injury, you are able to see in the posterolateral aspect of the tibia and in the middle aspect of the lateral femoral condyle. It is very common for radiologists to report bone bruises, which is present in ACL tear. The next is PCL tear. PCL is best visualized in sagittal image. You're able to see the PCL, which is in good consistency here, and also in the sagittal image. So this is an example of a partial tear of the PCL with a hyperintensity near its femoral insertion. And this is a tibial side partial avulsion injury. And this is a complete tear along the femoral insertion. For collaterals, MCL and LCL. Collaterals grading is 3 types, 3 grades. And again, the grade 3 is the complete disruption of the ligament. This is how a normal MCL looks. Grade 1, there is a mild sprain which is with no tear. Grade 2 with a partial tear, and grade 3 with a complete tear seen in the coronal image. So proximal tear is where you see the winding up of this medial collateral ligament near the femoral origin. And this is an example of an osseous avulsion. In X-rays, you can see something over a chronic period, you are able to see some ossification here, that is not Pellegrini speed adhesion. So distal avulsion, you are able to see here the medial collateral ligament getting torn and getting rolled up near the femur. So lateral collateral ligament, it's very difficult for you to see the lateral collateral ligament in one slice. You'll have to progressively see it. But if you are seeing lateral collateral ligament in one slice, it is indicative of ACL tear. So you are able to see the lateral collateral ligament tracking from the femur, going along the joint and getting inserted into the fibula. So posterolateral corner, you know, the fibular collateral ligament, popliteus tendon, and the popliteal fibular ligament make up the posterolateral corner. In the posterolateral injury, this is an example of post-collateral injury. You can see almost everything is torn. The biceps tendon, popliteal fibular ligament, popliteus tendon, and the fibula collateral ligament, everything is torn. So another thing in this axial image that you are going to look for is the medial patellofemoral ligament. So this is an example of medial patellofemoral ligament. As I told you earlier, the long part is the lateral facet. The middle part is short, and you track along the middle aspect, and you are able to see the tear from the femoral side. And also, this is an example of a medial patellofemoral ligament tear from the tibial side. So the last one is a Baker's cyst. This is the popliteal cyst, which is usually present between the semimembranosus and the medial of the gastrocnemius. The sagittal image, you can see it is getting extended with the valve near the joint.
Very good presentation,
Thank you, sir.
Jagnesh. Excellent. And regarding that ACL tear, what are the subtle signs of ACL tear?
Subtle signs means indirect signs.
Indirect.
Those are the things I told, sir. Deep lateral femoral notch sign. Actually, you can divide it into radiological and X-ray and MRI. X-ray, you'll be able to see Seagon's fracture, which is an avulsion fracture of anterolateral ligament. And in MRI, you are able to see the lateral femoral notch sign. You will be able to see the complete visualization of lateral collateral ligament in one coronal image. And you'll be able to see the posterior cruciate ligament in one sequence, which is very rare in normal.
Most of the time, we got difficulty in identifying cystic degeneration of ACL. And
So actually, I didn't bring it up because it's sports injury. It's typical ciliary stalk appearance is present in mucoid degeneration. You'll be able to visualize that in sagittal image, especially if you ask the radiologist to take a sagittal oblique image, which is parallel to the ACL, you'll be able to visualize. If you're taking normal sagittal, it won't be that clear. Indirect signs, these are the patellar buckling sign, lateral femoral notch sign, anterior tibial translation, uncovering the portion of lateral meniscus, PCL buckling, PCL line sign. But none of these is actually very specific for ACL tear. It can always be correlated with the clinical signs.
clinical. Excellent presentation. Thank you.
I would like to invite Dr. Satish Kumar, Assistant Professor, to give a talk on arthroscopic setup.
Morning to one and all present here and the viewers from the other side. And today my topic is a knee arthroscopy setup. I'll be talking about the basic arthroscopy setup. As far as knee arthroscopy is concerned, it is one of the most commonly performed orthopedics procedures. Just been published worldwide. And but through consistency, the complications are minimized and operative times are decreased. It should be possible with the proper setup. All the more, the preoperative marking is important in arthroscopy surgery because 25% chance of wrong side surgery was published in many articles. That is why in the early 2000, there was a sign your site campaign. The sign has to be done by the operative surgeon, which should be done with the indelible ink, which should be visible even after preparation and scraping. And it has been extended to a timeout procedure where in the operating room the OT nurse will be shouting out the name and name of the procedure and the site and all the equipments whether ready or not. Followed by the most important thing after giving anesthesia is the knee has to be examined for the evaluation of the effusion and for the range of motion and all the mobility and stability, the petallar, and a special test as discussed by the previous examiner. And it has to be compared with the opposite side always. The first thing is to apply a well-padded tourniquet, whether it is needed or not. It is up to the surgeon. But tourniquet application is mandatory right now with all the gadgets. So it has to be applied in a position that it should not obscure the operative site. The advantages are definitely increased visibility. There are quite a few disadvantages where the blanching of the synovium and there is a possibility of ischemic damage if the time exceeds. And there are a few contraindications to tourniquet application, which are thrombophlebitis and peripheral vascular disease. And there are two ways of patient positioning, which is either the patient limb will be on the table or it has to be hanged down. It also depends on the surgeon. But if the patient is the leg is on the table, the padded tourniquet after applying the post, whether it is lateral post, which has to be applied at least 5 centimeters from the superior pole of patella. And it should be applied in such a way that even after a knee flexion, the knee should be mobile. The knee should be stable. And after preparation and draping, it has to remain at the same position. That is why if you can look at the arthroscopy cables and everything on a single table there, which will be much more confusing when you do the surgery. So if the patient is positioned in a way that the leg is hanged down, the leg holder must be used. If the patient leg is hanged down, same 4 finger width above the superior pole of the patella, and the tourniquet has to be inflated if at all if a leg holder is used, because leg holder gives you a venous tourniquet effect. And the leg has to be tightened with the leg in internal rotation. Usually the leg will be externally rotated by natural tendency. And the contralateral leg should be very well padded. This is how the 4 finger widths above the patella, and the opposite leg should be the contralateral leg should be well padded, and the leg has to be fixed in a quite of internal rotation. And if the leg is hanged down with the lateral post, it has to be in this way, where the varus and valgus tests should be done by the arthroscopic surgeon itself, where the assistant is not needed. And coming to preparation and draping, it is a standard draping with the chlorhexidine and povidone iodine combined with isopropyl alcohol gives the best preparation and draping. The sterile drape with the impervious sheets as well as collecting bag is recommended to prevent liquid seepage. Coming to instrumentation, where arthroscope forms the key in the arthroscopy surgery. There are two degrees of arthroscope which are mostly used in knee arthroscopy, 30 and 70 degrees, followed by fiber optic cables, light source, and other accessory instruments we are going to discuss today. And this is a proper monitor set will be available with the camera box, light source, shaver console, and the recording devices. The arthroscopic equipment assembly is not a difficult one because the power gives from the power source, TV monitor and light source are connected, and it goes to camera as well as light source. Followed, it will be connected by arthroscope. Whereas in the cannula, there will be a irrigation fluid connected inlet, and there will be a fluid outlet. And for the comfortness and to prevent the entangling of the wires, we need to connect light source with camera in a single one, and with suction tube and micro shaver in a single way, with the irrigation tube from the saline, which has to be let in a separate way. And this is how the camera head with the arthroscope will be attached. And the light source will give us the rotation of the arthroscope. And as I mentioned, there is a 30-degree, 25 to 30-degree arthroscopes are most commonly used in most of the knee arthroscopy. There are 70 and 90-degree arthroscopes are also useful in around seeing the corners and the posterior compartments of the knee. The concept of the degrees is the straight view, which means 0 degree, will give us only few idea about the knee arthroscopy, which is not recommended. At least 30 is the 30-degree arthroscope, which increases the field of vision by 3 times. By just rotating the arthroscope, we can increase the field of vision by 3 times. For special regions, which is postural corner as well as posterior compartments, 70-degree arthroscope also will be used, but there will be a blind spot in the middle where that area can never be visualized with a 70-degree arthroscope. So this is the concept of 30-degree arthroscope, where you increase your field of vision by 3 times. The same with a 70-degree arthroscope, your field of vision will be much more increased, but with a blind area in between. And coming to probe, it is an extension of an arthroscopist's finger, because the probe is used to examine whatever the joint we need to examine with our fingers, like the condition of the meniscus, condition of the cruciate ligaments, and the osteochondral defects can be examined much better with the probe. And the arthroscopic scissors has a jaw which holds the tissues, which helps in cutting of the tissues, which will prevent slippage of the tissues. And there are 2 types of forceps, which is a basket forceps, which has a biting end at the open base. What is the advantage of basket forceps is it can crush the tissue to live inside the joint. No need to remove it every once and again to take it out. It can be finally taken out with the suction. And the grasping forceps, it will grasp the tissues around, but it needs another instrument to cut it. With the motorized shaving systems, with a 300 to 3000 rotation per minute, is used as per needed by the surgeons. As far as electrosurgical laser and radio frequency instruments, the electrocautery, the actual length should be about 6.5, so that we can use it in the deeper regions. The care or sterilization of the instruments. The arthroscopy instruments that are heat stable can be autoclaved. The other instruments has to be autoclaved, which has to be sterilized with a low temperature hydrogen peroxide gas plasma. And the irrigation systems, there are 2 types of irrigation systems. One, the system which we use is a gravity assisted. There are other system is pump inflow system, where the pump will be connected to a machine where it will give us in a proper pressure. The next topic is portals. The portal is one of the most crucial steps in an arthroscopy setup. I will be talking to you about it. And which is the most crucial step. The major portal which we use is anterolateral as well as anteromedial portal. The accessory portals are posteromedial, posterolateral, and inflow portals. How do you put an anterolateral portal, which is a primary viewing portal? It will be put in the drop-off side, which is just lateral to the patellar tendon from the lateral femoral condyle. From the lateral femoral condyle, you will be seeing a drop-off, which is just lateral to the patellar tendon from the proximal to lateral tibial plateau. And incision can be horizontal or vertical, but horizontal is better for cosmetic purpose. And the blade should be aimed away from the patellar tendon to prevent the iatrogenic injury. Or if at all the incision is going to be vertical, the blade has to be pointed away from the lateral tibial plateau to prevent injury to the anterior horn of lateral meniscus. And the trocar should always be aimed towards the intercondylar notch. This is how you make a drop-off site from the patellar tendon in between the lateral femoral condyle, just proximal to the lateral tibial plateau. You just make an incision, and your trocar should point towards the intercondylar notch. And the trocar should be directed in the same position as the incision is made. And the knee has to be extended immediately, and the trocar should be inserted between trochlea and patella. So you keep your knee in extended position. And the first thing is to visualize the undersurface of the patella following the suprapatellar pouch. And then you need to withdraw it in such a way that you need to be ready to examine the other areas, and you have to be ready to make the anteromedial portal, which is the primary instrumentation portal, which is done under direct visualization. And the trajectory has to be made towards the posterior horn of medial meniscus. You keep your arthroscope in such a way that your needle entry point from the medial side just points towards the posterior horn of medial meniscus, and you make similar skin incision, and your trocar will be inserted. And it has to be inserted in a proper appropriate way. If it is inserted too high, it will be difficult to visualize the posterior horn of the medial meniscus. Or if it is inserted in a more low fashion, you may injure the meniscus, and it will be difficult to move around with the scope. And you're just rotating the arthroscope by 30 degrees. You can visualize almost all the components of the knee joint. Now comes the mm, accessory portals, posteromedial as well as posterolateral portals. The accessory portals which are used for doing synovectomies or to retrieve foreign body or to repair posterior cruciate ligaments. And one of the most used portal is the posteromedial portal, which also done under direct visualization. Posteromedial portal is made just posterior to the medial femoral condyle, wherein you keep your arthroscope through the anterolateral portal, and it has to go in between uh, posterior cruciate ligament and medial femoral condyle. That is known as the Gilchrist interval, and you will be visualizing the entry of the needle from the posteromedial side, where it will be done under direct visualization. And there is a risk of injury to the saphenous nerve and vein, which can be prevented by just incising the skin alone and using the blunt dissection to make the portal. Same, the posterolateral portal also should be done under direct visualization. This time, the arthroscope should be passed via the anteromedial portal in such a way that the arthroscope should go in between the anterior cruciate ligament and the lateral femoral condyle. Thereby, the posterolateral portal should be made from the posterior to the lateral femoral condyle in such a way that it is posterior to the lateral collateral ligament and anterior to the biceps femoris. In such a way, the common peroneal nerve will not be injured. The similar way, the skin incision should only be made along with the blunt dissection. And there are two inflow portals which are not used nowadays, but it can be much more useful in the obese patients where the anatomy cannot be visualized that easily. So in those cases where you apply supromedial as well as suprolateral, whichever needed. Supromedial portal is made at a point where you draw a line from the superior pole of patella and you draw a line from the medial pole of patella. Where it intersects, you make a supromedial portal. Similar to the horizontal line drawn from the superior surface of the patella and a vertical line from the lateral border of the patella. You get to the intersection point, you will make a supralateral portal. And the portal has to be made in a position where the knee is extended. Under the it has to be directed as far as parallel to the floor, the knee in extension, so that the synovium or condyle will not be injured. And while making a supromedial portal, you need to be aware of vastus medialis obliquus muscle, which may be inadvertently cut. And what are the pearls of making a good portal? Is you need to draw out perfect anatomy, and such a way you can you can make an anterolateral portal and then place the knee in a position to see the posterior horn of medial meniscus. That way you can make the medial portal. And in morbidly obese patients, only patella can only be visible or it can be made out. The other tissues will be obscured by the fatty tissues. So in those morbidly obese patients, to make use of the supralateral or supromedial portal, preferably supromedial portal, so that you can make the anterolateral portal itself under direct vision. So you don't make a mistake, because when you put a portal in a different position, it will be difficult to complete the surgery. You need to make an accessory portal also. And these are my references. Thank you.
Really, you have delivered pearls for the beginners. I think tomorrow the delegates will start with this setup. They have to mark. They have to mark and start the cadaver session.
Thank you.
Next, graph harvesting preparation by Dr. Sharaf.
So, good morning to one and all present here. I am Dr. Sharath, Assistant Professor, Institute of Orthopedics, Madras Medical College. So, thanks to my previous speakers who have given an excellent introduction about the base arthroscopy and regarding the imaging as well. So, diving into my topic today, which is graft options, harvesting, and preparation. So, what is an ideal graft? So an ideal graft should have the following properties. It should have structural features similar to that of native ligament. A good biological incorporation should be present. The graft should have a secure fixation and there should be minimal donor site morbidity. So as we all know, the grafts can be broadly classified into all these criteria, which is the autograft, which is taken from the same patient, the allograft, which is usually harvested from a cadaver, the isograft, which is usually taken from an identical twin, or a xenograft, which is taken from a different species. So my topic today will be based on discussions pertaining to these autografts, which are most commonly used in ligament reconstruction surgeries, which include the bone patella tendon bone graft, the hamstrings, the quadriceps, and the peroneus longus graft. So coming to the BTB graft, this is considered as a gold standard for primary ACL reconstructions. The indications would be young and active patients aged 18 to 35 years, and especially who fall in the criteria of professional athletes. So as this gives an advantage of good osteointegration, which we find because we take the graft along with the bone plug. So coming to the graft harvest technique, the position is as described by my previous speaker. The patient is positioned supine on the operating table under strict aseptic precautions. The tourniquet is tied high up in the ipsilateral limb, and the limb is prepped and draped. What we use is called the mobile window technique, where we use an oblique incision starting from the inferior pole of the patella to somewhat distal to the tip, just medial to the tip of the tibial tuberosity. So the skin, the superficial fascia, and the subcutaneous tissue is incised, and the patellar tendon is reached. And now we just mark the tibial and the patellar bone plugs. The patellar bone is usually marked about 25 mm, and the tibia is usually marked to a length of about 20 mm. And the central third of the patellar tendon is usually chosen to a thickness of 10 mm.
Two markings.
So this is the mobile window technique, sir. Actually, here we use an oblique incision, sir, instead of a standard straight incision. So in this incision, after replacing an oblique incision, we can convert this into a rectangular window also. So that's why this is called a mobile incision, sir. The advantage is there is minimal chances of injury to the nerve as well, sir. So after marking the tibia and the patella bone plugs, the 2 mm K wire is used, and it's pre-drilled in the tibia as well as the patella. About 3 holes are made in the tibia and the 2 holes are made in the patella. Some advocate raising the tibial bone plug first and then going on to the patella bone plug. But with experience, they found that it is better to take the patella first and then come on to the tibial bone plug, because once you raise the tibia, it is use an oscillating saw. When you reach the patella, the oscillations produced by the saw creates a little bit of difficulty in harvesting the patella bone plug. So it is generally, for as a surgeon advances the study, it's better to go for patella first and then come for the tibia. So the graft is harvested and then transferred to a side table where it is prepared. Number 2, T-bond sutures are passed through the holes made in the tibia and the patella bone plug, and the graft is tensioned. Any excess bone debris is removed using a nibbler, and any excess fat or anything is just trimmed. And the graft is tubularized. So coming to the pearls and pitfalls of this technique, since there is only a small oblique incision which avoids morbid knee pain, and the incision can also be used to make the tibial tunnel, and the technique is also easily reproducible. So any technique will carry its own disadvantages as well. These include donor site morbidity, which includes anterior knee pain, which is more on kneeling, less functional muscle strength, which usually improves by about, say, 6 months, bone plug fracture. Sometimes due to an improper technique, when we tend to fracture the bone plug, we can use certain bailout techniques such as the piggy bank technique, where if the fractured fragment is you have a good chunk of fractured fragment, we can use suture to hold the fragment. Or if the fractured fragment is very small, if there is piecemeal of the fractured fragment, you can remove that and convert that into a tissue graft, sir. And sometimes there might be a tunnel length mismatch as well. So this can be overcome by certain techniques like creating a trough in the trachea or advancing the patella bone plug and fixing it with a bio screw or a metal screw, twisting the graft on itself, which will reduce the effective length of the graft, or clipping the bone plug, the tibial bone plug onto the tendon, which reduces the length and helps aid in tendon length mismatch. So coming to the next most commonly harvested tendons, which are the hamstring tendons, of which the gracilis and the semity are being increasingly used nowadays. So before harvest, we need to consider the anatomical considerations in order to have a good and effective harvest of the graft. So we all know the hamstring tendons, namely the sartorius, gracilis, and the semity, have what is called as the pes anserinus insertion, the anteromedial aspect of the proximal tibia. The gracilis originates from the inferior rami of the pubis. The semity originates from the ischial tuberosity, both of which join together to form a conjoined tendon and have insertion at the pes. So we need to be wary of these anatomies before placing our incision. So coming to the accessory facial bands, so these facial bands need to be viewed. According to certain studies, they found that there are few accessory facial bands between the grafts, that is semity and gracilis itself, and also bands which connect these tendons to the posterior gastrocnemius. So these facial bands need to be divided properly before placing our graft retrievers in order to prevent premature amputation of the graft. And also we have the saphenous nerve, especially the infrapatellar branch of the saphenous nerve, which gives two branches below the patella, which is at risk of injury during harvest of the hamstring tendons. So here we have the technique of harvest for the hamstring tendon. In a study by Friedman et al., he suggested that a vertical incision placed 1 inch just medial to the tibial tuberosity and 3 finger breadth below the medial joint line is the exact position of the pes. But it was slightly modified by Brown et al., where there's an oblique incision which is made along the skin crease, which gives a much cosmetic appearance, as well as it lies in line with the insertion of the pes, and also gives us a good window for harvest of the hamstring tendons. So the skin, the subcutaneous fascia, as well as everything is dissected after prepping and draping the patient. And the hamstring tendons, namely the semity and gracilis, lies between layers 1 and 2. 1 includes the sartorius fascia, and tendons lie in the layer 2, and layer 3 is the deep layer where the MCL, superficial MCL, sits. So we should be very careful not to damage the superficial MCL. So once the graft is harvested, after releasing all the facial bands, this is how it looks. And after which the graft is transferred to a side table where we have a separate graft preparation board. For example, graft masters in case of Smith and Nephew. First, the graft is measured in length. And for an ideal single bundle ACL reconstruction, we need a 4 or a 5 strand hamstring graft. The gracilis can be folded into 2 strands, and the hamstring and the semity can be folded, tripled or quadrupled as well. So while using the standard endo button loop, say for example, 15 size endo button loop, we usually use a 5 strand graft so that we bring about a thickness of say 8 mm minimum in order to avoid a failed ACL reconstruction. So coming to the pearls and pitfalls of hamstring grafts. So as we all know that this is one of the most commonest grafts nowadays we are using. So there is a less graft site mobility. The technique is very easier to reproduce and to learn, and higher structural properties when tripled and quadrupled. So coming to the drawbacks. So improper technique, for example, what I told, like failure to release the facial bands might result in premature graft amputation. The donor site there might be a little pain in the donor site. And as previously told, the superficial MCL lies in the deep layer, and inadvertent injury to the MCL is always a risk while harvesting the hamstring tendons. And sometimes there is reduced hamstring strength as well. But usually what they say is the reduced hamstring strength usually recovers by about say 6 months, because the hamstrings usually have a good property to regenerate and somewhat insert much distally to the site of origin. And as mentioned previously, the infrapatellar branch of the saphenous nerve is also at risk of injury. So coming to the quartz tendon. So initially there was a lot of gray area regarding quartz tendon, but nowadays there is a lot of usage of this tendon as well. It was first described by Marshall et al. In 1979, now gaining popularity. So this has an advantage of being taken as a soft tissue graft as well as along with a bone block taken from the superior patella. So it can be taken either as a full thickness graft or a partial thickness graft. So how do we decide whether to take a full thickness or a partial thickness graft is to do a preoperative study on the patient where an MRI is done and thickness of the graft. The quartz graft is measured 3 mm proximal to the superior pole of the patella. If the thickness is more than 7 mm, it is ideal to take a partial thickness graft. If it is less than 6 mm, it is better to take a full thickness graft. So the problem again in a full thickness graft is you should be very careful not to violate the suprapatellar pouch, or else there will be extravasation of fluid in the subsequent arthroscopic procedure. So this is the patient positioning. The knee is flexed to about 30 degrees, following which the landmarks are marked: the superior pole of the patella, the medial border of the vastus medialis obliquus, and the lateral border of the quadriceps tendon. So the incision is made, dissected in layers. The quadriceps tendon is reached. So we can see the trilaminar configuration of the quadriceps tendon, after which the graft needs excision using a specialized instrument which is called as the quartz tendon harvest blade, and the graft and the quartz tendon retriever and the cutter. So usually the thickness is ideal thickness would be about say 10 mm, which is chosen accordingly to the blade size given, and it is placed in advanced proximally. Following which, after the desired length is achieved, the retriever is used and the quartz tendon is cut and excised. So following which it is prepared like any other soft tissue graft, but in quartz we can prepare it with a whip stitch at the end, or using also a suture rope as well. So following which it is closed. So coming to the pearls and pitfalls as far as quartz tendon is concerned, as we all know, the size is predictable. There is less anterior knee pain, no residual cramping. Since it has a denser matrix and 20% more collagen favorable structural properties, there is less load to failure. But again, it always comes because it is technically demanding, requires specialized instruments, and only one bone block is available. And the length is also limited, restricting it to only particular procedures. So my last graft today is the peroneus longus tendon graft. So nowadays, this is gaining a lot of interest, especially in revision ACL and PCL and multi-ligament reconstructions, or it can also be used as an augment for inadequate hamstring graft. Sometimes the hamstring graft thickness is unpredictable in certain patients where you don't get the desirable thickness of the graft. In such cases, you can augment the hamstring graft with a peroneus longus tendon graft. Rarely it is used as a primary, especially in cases of short, stout females. So this is the anatomy of the peroneus longus and brevis. The peroneus longus usually originates from the upper 2/3 of the fibula, passes down behind the tip of the medial lateral malleolus, goes on to insert in the base of the first metatarsal and the medial cuneiform. The peroneus brevis somewhat lies behind the peroneus longus, passes through the superior peroneal retinaculum, then through the inferior peroneal retinaculum, goes on to insert into the base of the fifth metatarsal. So again, the harvesting technique is the same for other as I mentioned earlier. So here you placed a bump on the ipsilateral gluteal region to keep the limb in somewhat an internal rotation, and you tilt the tables slightly somewhat towards the opposite side to improve the surgical view. So a curved 4 cm incision is placed behind the tip of the medial lateral malleolus, and you dissect it in layers. After incising the superficial peroneal fascia, you come to view the peroneus longus tendon and the brevis tendon. So first step is to separate the fascia from these tendons, and the next step is to take suture bites on both these tendons before dividing the peroneus longus. Because once you divide the peroneus longus, it is difficult to suture the stump back to the peroneus brevis. So it is ideal to suture the tendon first before dividing the peroneus longus tendon. So after suturing, you just the harvesting is the same like any soft tissue graft. You harvest from a distal to proximal direction, and you just keep it on the graft preparation table and prepare it like any other soft tissue graft by doing whip stitches on both sides. So again, this techniques has got some advantages and disadvantages. We know this peroneus longus has got a very good length, so it can be tripled, quadrupled accordingly. Since the scar is hidden behind the medial malleolus, osmosis is also not an issue. Gait pattern is also not altered, and patient satisfaction is very good. Hyposthesia and numbness is because of injury to the sural nerve, which lies very close to the site of incision. So that should be very off when we are making this incision. There might be a transient weakness and eversion up to 6 months, but following which the brevis steps up to compensate for the peroneus longus muscle relief. So the allografts are not that much used still, but it's still under development because it has got a lot of other factors, such as you have there is a risk of it's especially it's very costly to procure these grafts. Again, it has advantages like no graft site morbidity, available off shelf life, and in multiligamentous injury where we run out of grafts from the individual, we usually go for allograft from cadavers. Again, it carries risk of disease transmission. It is a weak graft, there is delayed incorporation and not universally available, and it is expensive as well. So it's a small recap of all the four tendon grafts which I told now. It's just a short video of harvest of Sorry for the interruption. This is a quick short videos of the graphs that I told. Play பண்ணலாம்.
வருது இதுதான் பட்டது வரணும்ல. போன் நல்லா வரும்.
Video problem. Post பண்ணிடலாம். நான் குரூப்ல போட்டுலாம். Just you finish your talk, complete your talk. இத மட்டும் தனியா குரூப்ல போட்டு. We have to thank the department for giving the opportunity to present the talk. Thank you. Some nice and stylish presentation from our faculty, Sarath Kumar. Thanks for your presentation, sir. I'd like to invite Dr. Karasan, sir, assistant professor, to give a talk on infra.
Very good morning to all.
The presentation will be about the implants and repair techniques used in arthroscopic procedures. So, first we will see about some suture materials used in sports injury surgery. Polyethylene material, so commercially available fiber wire, orthocord, available in size of 20, number 2 and number 5. Number 5, polyethylene suture have the tensile and load to failure strength equal to SSY. So it's available in white color, blue color, or in combination of white, blue, white, black, white and purple. So polyethylene tapes are also available. They're having the less cut through. Used in with stitching to prepare the graft and suture anchors and pulling material in endo button, and it can be used in meniscal repair, ligament repair, and augmentation, and it can be used in fracture surgeries, tension band wearing, and avulsion fracture. So next is polyester suture, commercially available as commonly we call ethibond. So either it is used in dyed or undyed. Dyed is green color, available in various sizes. So commonly we will use in number 2 and number 5. So uses same as such of polyethylene, but because of the bigger size, we cannot use it as a shuttling suture, and we cannot insert into suture pattern. So number 2 is have the strength of equal to number 1 vicryl. The other suture material you can use polydiaxonal, but it is just monofilament, so stiff, but needs multiple dots. So it can be, if you place it superficially. So next we'll move on to the meniscal repair technique. So this is the outside in technique. So we'll use a long hollow needle with stillet. We can use loops to retrieve the sutures. So needles will be inserted from outside through a stab wound. So many configurations you can make: vertical, horizontal mattress, like that. So knot will be placed outside the capsule. So here we use a double needle using the Prolene for shuttling. So this is commercially available outside in kit. It's disposable. Next is the inside out. So for inside out, we will use a solid but thin needle, long needle, one end attached with the suture material. So usually it will be by polyethylene suture. So with the aid of cannula, will insert from inside. The tip of the needle will come outside. Okay. So various cannulas we can use it for the various zones of menisci, anterior, body, and posterior. Separate cannula we can use it for right and left. Okay. So this is a commercially available gun. So pushing the needle, it will be easier with the gun. So since it is coming, so we are inserting from inside, we should know the safe zone. Otherwise, you will injure the posterior neurovascular bundle and common peroneal nerve. So with the spoon or spatula, we can retrieve the tip of the needle. Okay. This is all inside meniscal device. So you don't need any stab wound or incision outside. Through the portal itself, we can insert this repair. So now all other techniques, you cannot use it in posterior horn tab. So this is the only option for a posterior horn. So here you are having the polyethylene wire attached with a peak material bottom. So that peak material will be delivered outside the capsule. So nowadays instead of peak, so we are having the suture material. This is the polyester. So it has irritation will be lesser. So this is how we will insert. So while inserting, it will go in straight. So after that, it will come horizontal. So avulsion fractures, anti-horn or post-horn, you can use pull-through technique, which stitch made at the post-horn or anti-horn, brought to the anterior proximal tibial cortex through a bone tunnel fixed with a button or suture post. So ACL bone avulsion, tibial avulsion can be fixed with same pull-through technique or our routine cannulated cancellous screw or suture anchor. So same way PCL avulsion also can fix pull-through or screw fixation. Collateral ligaments. So for example, this is a tibial avulsion of MCL. We can make a whip stitch and with the aid of suture anchors, we can fix it in 2 points. Near the joint, one anchor, another anchor will be distal. So the common surgery is done for ACL tear is ACL reconstruction, in the graft and reconstructing. But the initial attempts repairing the torn ACL, everything went on failure. But with the new advent of surgical techniques and anchors emerging, in selected cases we can do. So here, the proximal avulsion, soft tissue avulsion of ACL, we can do repair. It comes in less than 3 weeks time. Here we can make whip stitch. Proximal is described there, but distal we can do. Distal soft tissue is very rare. Distally bone avulsion is very common. So whip stitch made at the proximal ACL and with the use of suture anchor fixed with lateral femoral condyle. The same way pull-through technique also we can use fixed with the endo button, and this is the augmentation tape. So this illustration shows the ACL repair. Here you can see the empty lateral notch, the ACL separated from the lateral femoral condyle, which stitch made using the suture scorpion, and it's reattached. Here it is reattached, and this is tunnel made for augmentation. This is the augmentation tape. This is picture shows the repaired ACL. So repairing the ACL is far better than reconstruction. So whip stitch is the workhorse of any ligament reconstruction. So we'll use polyethylene or polyester suture material. This will help in pulling the graft into the tunnel and tensioning the graft, and it will somehow withstand the interference screw friction. Fixing the ligament reconstruction, we'll use either interference screw or suspensory fixation. First, we'll see about the interference screw fixation. So here the screw will fix the graft inside the tunnel. We'll use the cannulated screws. Most commonly, we'll use titanium or biocomposite screw. SS screw in previous days they will use because of the MRI incompatibility. Nowadays we are not using. So titanium peak means is a polyethyl ether ketone. Bioscrew is made up of PLLA or PLDLA, and Combination with bioscrew, calcium phosphate added mix, it will become a biocomposite. So screws will have the advantage of having the aperture fixation. So for the graft healing, graft will heal in and around the inner aspect of the tunnel. Disadvantage is synovial fluid will seep through the cannulation. And in posterior blowout conditions, you cannot use the interference screw, and screws can get migrated in or out. Okay. So this is how the interference screw be fixed. They are round cannulated interference screw with the hexagonal socket for a screwdriver insertion. So there are two types of metal interference screws. One will have the sharp threads, another one is soft thread. Soft thread will be used for soft tissue graft, sharp thread for the bone flex. So you should not use the sharp thread for the soft tissue graft. Otherwise, it will cut through the graft. So biocomposite screw, it will take about 3 to 5 years to get resolved. But it is having less strength. It may break while insert. Usually, you use one size above the size of the bone tunnel. So bioabsorbable screw, even less commonly will use. So it have the disadvantage of producing sterile sinus. So peak is not the patient wants a radiolucent implant, you can use peak screw. Next, we'll see about the suspensory fixation. First is metal staples. With the help of staple impactor, you can insert into the bone. So this is how the hold the stapler. Next is post screw. Post screw, either the head of the screw will be broadened, or you can use a regular particle or cancellous screw with the washer as pipe washer also available. So this is how we'll attach the graft with the post. And suture disc. So at the outer end of the tunnel, we can fix the disc, and slip stitch will be tied over the suture. So these are all the various methods you can use it for femoral tunnel graft fixation. The first one is interfront screw. Next one is the endo button fixation. This is cross pin fixation. This is staple. So these are all the various methods. So nowadays we are not using this transfix. It's having a complicated thick system. The graft will be looped around this pin for the femoral fixation. So this is endo button. Endo button means titanium button with hole. Two types of endo buttons. One is fixed loop, another is adjustable. Fixed loop, you will have the loop made up of polyurethane. Here. So with this loop only we will attach the graft. This is the fixed length. So commonly available sizes are 15 mm, 20 mm, 25 mm. We'll use according to the length of the femoral condyle. So even some companies they are giving 10 mm also. These two threads are, one is for pulling the graft inside the tunnel, and once it has come out of the outer femoral contact, it will flip. This will be used to flip. And this is the adjustable endo button. This loop is made up of same polyethylene switches. The length of the loop will be adjustable. So commercially, it is about the maximum of 50 mm it will be there. So you can adjust. So even after fixing the button, you can adjust the length. So while inserting inside the tunnel, the graft will be in line with the bone tunnel. Once it has come out with the flipping suture material, it will be seated outside the femoral cortex. Okay. This will be pulled in this direction. Once it has come out of the outer cortex with the flipping suture, we made a horizontal. So these are the different types of endo buttons showing the graft inside the tunnel. But if you are using a fixed loop, you'll have minimum of 7 mm gap inside the tunnel. Okay, this is the socket to accommodate for the graft, and this is the tunnel made for the passage of endo button. Here, since it is the loop is adjustable, there is no gap inside the tunnel. And so this is a calculation you have to use it for the fixed loop, not for the adjustable loop. The amount of socket you have to ream depends upon the length of the femoral condyle, the length of the loop we are going to use, and the amount of graft we are aiming to keep inside the tunnel. And suspensory fixations will have these unwanted effects. One is windshield and bungee effect. So windshield is the horizontal movement of the tunnel, and bungee is the vertical movement of the graft inside the tunnel. So this will predispose the tunnel widening, impair the graft healing, and lead on to graft failure. So we'll see some special instruments. We'll use it for the sports surgery. Suture passes. These are all long, hollow needle with curved tip. So 0 degree, 25 degree, 45 degree, angle right and left available. So this is how you can make bite in the menisci. So this is a suture passer with a gun. This is a self-retrieving device. So we load the suture metal in the lower jaw. So once you press the lever, the needle will take the thread through the tissue, then it will come out of the upper jaw. This upper jaw will hold the thread, not the needle. And the flip cutter, I will use it for all inside ACL tear. So this will avoid the through and through tunnel. Same like femoral tunnel, we can make it in the tibial side also. So this is how the flip cutter will work. While inserting, the cutting blade will be in straight. So while reaming, we can make it horizontal. After reaming, it will insert the inside, then make it straight, then retrieve it out. So in some techniques used in osteochondral injuries, so you can use the conventional screws, cantilever screw with cantilever screw or a Herbert screw. So head of the screw, tip of the screw to be deeply buried to avoid the tibial opposite cartilage damage. So you can use the biocomposite screws and biocomposite pins. This is the biocomposite material designed as dots. So just set and cut it at the surface. And we can use the suture anchors also. So using bridge technique, you can fix the osteochondral fracture. Thank you.
It's a very good presentation, Dr. Prabhuswamy. Elaborated everything about the options of the plants and all those things. Yeah, thank you.
Next figure. Due to the unavoidable reasons, Professor Arulmozhi Rajan so we'll have meniscal repair after a few more talks. So next, Professor Palli sir will present AC review.
Morning to all. First, I thank Professor Tulkapian sir and Professor Anthony Malraj sir for giving me this opportunity to talk about ACL and to share my experience and my small knowledge about ACL with all. First ACL repair was done by Arthur Mayo Robson in 1895, way back to 1 century ago. And Riccardo Galeazzi is a pioneer of ACL reconstruction with the hamstring in 1934. And now Watanabe, father of modern arthroscopy, is the one who designed that scope. This is the first endoscope he designed. Now we are using a very sophisticated 4 mm 30 degree and 70 degree scope. It's already my previous persons elaborated about that anatomy. And, regarding ACL, it has the wide attachment in the tibia. It's a wide attachment from anterior to past middle. It will be there. And regarding the attachment in the femur, the length of the ACL varies with the flexion and extension. There are two bundles, anteromedial and posterolateral. The bundle concept, there is some controversy in the bundle concept, but anyhow, we are now using the anteromedial and posterolateral bundle. This one is the, anteromedial, and this one is the posterolateral. While the knee in flexion, the posteriormost part will be the anteromedial bundle and the antermost part will be the posterolateral bundle. But the attachment of the anteromedial bundle will be more anterior and in the tibia, and the attachment of the posterolateral bundle will be posterior in the tibia. While extension, this anteromedial bundle will come anterior and posterolateral bundle will go posterior. We'll see in the next slide. This is the femoral footprint, and that is the tibial footprint. In extension, the anteromedial bundle will come anterior. In flexion, it will go posterior. The posterolateral will be in the converse. The ACL should be, the length will be approximately, 32 mm with 10 mm. It is the primary restraint to anterior tibial translation. And it is a secondary restraint to tibial rotation and weight bearing, like this. How ACL is torn? There are two types of, we broadly classify into two types of mechanism of force acting on the ACL. It's the non-contact pivot and contact mechanism. There are two broad classifications. In non-contact injuries, the reason for non-contact injuries are changing the direction abruptly and stopping suddenly and slowing down while running, landing from a jump incorrectly. These are all the mechanism described under non-contact injuries. Now you can see one non-contact injury. Contact
Sir,
injury.
sir, sorry for the interruption. Sir, your screen is not at share, sir. Your presentation is not at come.
Are you able to see the screen now, sir?
Yes, sir. Yes. Yes, sir.
Yeah. Hello. Yeah, regarding that non-contact injury, these are all the reason changing direction abruptly and stopping suddenly, slowing down while running and landing incorrectly. Here is the classical example of non-contact injury, non-contact pivoting injury, where ACL will be strained and ACL tear will occur. So contact injury, on the otherwise, will a direct contact or collision, such as here. Here, the dynamic valgus force will act and the tibia will rotate internally and the femur will rotate externally. That's the valgus and rotational stress will be there. Here you can see the mechanism of ACL tear, the rotation and hyperextension. And coming to the clinical findings, I will rush up with the clinical findings because already it was taken by our previous speakers. It's anterior drawer and the latchman is the one. Conrad Callan B is one who described about latchman. Lackman was his professor's name. Lackman is due to this doorstop effect of the medial meniscus. In flexion, the medial meniscus will act as a doorstop, and in extension, it will give way. And this one is the pivot shift, as you all know. So valgus stress at the knee joint and the internal rotation of the tibia from extension to flexion. In 30 degree of flexion, the tibia will subluxate anteriorly, and with the full flexion, it will relocate. The converse is the jerk test. It will be from flexion to extension. Internal rotation of the tibia with forward flexion and forward push on the head of fibula and internal rotation, and valgus stress will subluxate the tibia, and while continuing the extension, it will relocate. This is the jerk test. And the exact to observe the exact translation, anterior translation, we have to use that KT 1000 and KT 2000 orthometers. Regarding X-ray, it's a classical femoral notch sign. We should look for femoral notch sign and widen the intercondylar notch. We have to see that. And in MRI, it's ACL. It's a normal ACL. It should be parallel to the Blue-Mansart line, and it should be around a 45-degree angle. So here there is a tear, and sometimes there may be some abnormal orientation of the ACL. It need not be exactly parallel to the Blue-Mansart line. And here is the classical PCL buckling. The PCL angle should be more than 105 degree. If it is less than 105 degree, it is called buckling of PCL, which is the hallmark of ACL tear. And here is the empty notch sign. And, regarding reconstruction, there are some extra-articular reconstruction of ACL, McIntosh, Lewis, and Andrews. We are now concerned about the intra-articular. Here, a few words about the graft options and the bone patellar tendon and hamstring. And this one is peroneus and quadriceps. And among all these things, hamstring is better option because there is the functional performance and power restoration of the hamstring is better after 2 years. There is a study, and also it is cosmetically appealing, and there are wider fixation options for hamstring tendons. Various techniques, we will see one by one quickly. So, broadly, we can classify into single bundle ACL and double bundle ACL. And single bundle, previously we were using transtibial, that is drilling first making the tibial tunnel, and then we'll put the guide wire where it aims towards the femur. It's a transtibial. It will be a high femoral tunnel, and inside out, that is anteromedial. That is, we have to go by anteromedial portal. It's a transportal approach. And one more is outside in. Here we have to use special jig. With that, we can still more accurately place that femoral footprint, address the femoral footprint. And one is all inside. We will see one by one. These are the various portals, as you all know. Previously, they have taught you. And this is the evolution of femoral tunnel. It's femoral 1980s, and transtibial, it will be more high, and double bundle It's the anatomic double bundle and the anatomic single bundle and anatomic double bundle. Recently, we are following. And coming to the femoral tunnel, which is very important in ACL, it won't forgive if you misplace the femoral tunnel. The femoral tunnel should be in the 9:30 or 10 o'clock position on the right knee. Here you should first identify the lateral intercondylar ridge, and bifurcation ridge. This bifurcation ridge will separate between the anteromedial and posterolateral bundle. Here you can see the lateral intercondylar ridge. This will be the anterior most border for the ACL. Your ACL should not come anterior to this lateral intercondylar ridge. Here there is a bifurcation ridge, and here the anteromedial and posterolateral. Your ideal ACL graft should be at the junction of the lateral intercondylar and bifurcation ridge over there. It should be like here. Here you can see very nicely about the lateral intercondylar ridge and the bifurcation ridge. In that also you can see the lateral intercondylar ridge. It should be the anterior border of the ACL. Here you can see the ideal position for the femoral tunnel. It should not be high, anterior high. Here you can see that it's the isometric, it's the eccentric here, and here and here it's the low tension, it's the direct. But the ideal position will be there at the junction of the lateral intercondylar and the bifurcation ridge, little bit erring on the posterior aspect. This is very important. And this one is the oldest technique, transtibial. Your femoral tunnel will be guided by the tibial tunnel. And one more technique is outside in. Here we can use that jig, and using this flip cutter we can make that this thing, this femoral tunnel. In that you can use this all to fix that jig. First you should view from the anterolateral portal. After putting that entry point, you have to confirm your entry point with the anteromedial portal. If you want to change anything, you can change now itself. After that, you have to make that, you have to fix that femoral jig, outside in jig. Like this. Like this. And you can drill this thing with the flip cutter. This is called outside in technique. But most of us are in nowadays we are using this transportal technique, that is anteromedial. But by using this sort of offset, what we call it as femoral offset, it will come around from 5, 6 mm, 7 mm, and all those things. We routinely use 7 mm offset. Why we are using 7 mm offset is, if the tunnel, if the graft length, graft thickness is around 8 or 9, if you are using 7 mm offset, you will be drilling that bead pin at middle of the 7 mm. So the 7 mm will accommodate 3.5 mm of the graft that can be accommodated on either side of your bead pin drill. So better to use 7 mm offset always, not lesser offset. This one is transtibial. It will be a high femoral portal. This is an anteromedial portal, that is transportal. It will be a lower one. It's more anatomical. Here you can see that thing. The transtibial is the anteromedial. In the femoral tunnel preparation, you have to first, you should, after making that bead pin, you have to measure the tunnel of the femur, and by measuring the tunnel length, by after putting the bead pin, you have to do a 4.5 reamer, putting a tunnel with that. And then after measuring it, if suppose it is 40 and you are planning to put the graft up to 20, you have to ream it extra, 7 to 10 mm extra. As Dr. Karpusamy told, you have to ream it extra, so that the extra reaming is mainly for your button to flip. Normally it will be 7 mm button will be there. So you should ream it extra 7 mm for the button to flip. Endo button, if it is the total of 40 mm tunnel, if you are planning your graft in the tunnel as 20 mm, you can use that 20 mm endo button. If the femoral tunnel is less than 40, you should always use 15 mm button if you are using a fixed loop. So your intraosseous tendon will be at least 25 mm. You should not use, if the femoral tunnel is, say for example, it is 30, 35 or something like that. If you are using 20 mm endo button, your graft length inside the bone will be only 15 mm. It should be ideally 20 mm or more than 20. In order to get a lengthier femoral tunnel, you have to hyperflex the knee before drilling that femoral tunnel. It will be like this after putting a tunnel, femoral tunnel. And coming to tibia, so tibial, the anteroposterior attachment of the ACL in the tibia will be around 17 to 18, and mediolateral will be 10 mm. So it will have a wider attachment than we think about that. It will be very thick and a wide attachment in the tibia ACL. So always try to use the exact landmark, and thickness of the graft matters a lot. By choosing the landmark, always you should, if there is any remnant of ACL, use the center of the footprint. Otherwise, if you are not able to see that, you can choose that posterior border of the anterior horn of lateral meniscus. Just behind the anterior border of the lateral meniscus, you can put it. Or else another tip is just put the tibial jig next to the tibial spine. In between the medial and lateral tibial spine, you can place that jig, tibial jig. It should be 55 degree. Normally it should be placed at a 55 degree and 30 degree in the medial to mid sagittal axis. In this axis should be 30 degree from the midline, from the shin of the tibia, and this one will be 55 degree normally. There are two aimers, tibial jig, that is the elbow and tip aimer. If there is no ACL footprint, you can use this elbow reamer, and it can be placed either 7 mm from the PCL or in the anterior border of the, and just posterior to the anterior border of the lateral meniscus, or in between the tibial spine, next to the tibial spine. If there is ACL footprint, you can directly use this tip aimer. The difference between the tip and the elbow aimer is, if you are using the tip aimer, your guide pin will come exactly where you place that tibial jig. If you are using the elbow aimer, if you are planning your bead pin should come here, you should place that elbow aimer little bit posterior. You can see whether it is where it is coming, and you can adjust accordingly. Always better to use elbow aimer in the initial period. That will be better, because you can see in your eyeball technique whether your bead pin is coming out, where it is coming, you can change it. If you are using tip aimer, sometimes if your bead pin getting bent, or if it is all tracking, you cannot access, you cannot know where it is going, and some mall tracking may occur. After putting that bead pin, tibial tunnel, according to the size of the graft, you have to ream it. There are two types. Here also there is some all inside technique will be there. You can use that same flip cutter. In this, the difference between the through and through and the all inside technique is, you can use this bone, conserve this bone, part of the bone in the tibia. whatever graft length is required, you can put that, and you have to use that suspensory ligament if you are using all inside technique. You cannot use a screw, interferential screw. This is the difference. This is the conventional technique. Here you can use it. This one is the 4.5 and this one is the appropriate. For example, 8 mm reamer. Your button will flip here, and this one is the standard tibial reaming. There will be a bone defect here. You will be putting that screw over there. But in the all inside technique, the same will be in the femur side, and in the tibia side, you can use that bead pin, and by using the flip cutter, you can assess and you can conserve this amount of bone. But you have to use that suspensory fixation, not a screw. And one more advantage in the all inside technique is you And coming to the fixation options, as Dr. Karpusamy told, there are various options. That is a fixed loop and adjustable, and on the femoral side, even screw fixation on the femur side can be used in case of if it is a bone tendon bone graft. And this is the extendo button and hybrid fixation also. The difference between fixed and adjustable loop is, in the adjustable loop, you can the major advantage is you can tension the graft even after flipping. What Dr. Karpusamy told, it's a major advantage. And one more advantage is there won't be any sawing phenomenon.
Good afternoon, everyone. When the enable job of suffering during lunchtime. So the knee can live even without the ACL, but not without the PCL. Okay? PCL is important. So this is one of the most commonest doubts, which is the most important bundle, ACL and PCL. The anterolateral bundle, the posterior cruciate ligament consists of the anterolateral bundle, the posteromedial bundle. This is named based on the femoral attachment. The anterolateral bundle is the larger and stronger ones, and obviously this is the one bundle which we are replacing in the PCL reconstruction. The other parts of the posterior cruciate ligaments are the discofemoral ligament, anterior humphrey and the posterior Risberg. These are nothing but facial condensation attaching the lateral meniscus with the medial femoral condyle. You would have done for undergraduate orthopedics. That's why the lateral meniscus escapes the injury. The ligaments prevent the meniscus from getting caught between the two condyles. And the posterior cruciate ligament is 1.5 times thicker than the anterior ligament. Interarticular, that is, it is within the joint, but it's extra synovial. It's covered on all sides with the synovium. So these are the ligaments of Humphrey and Risberg. Why this is important? Because once we approach the posterior cruciate ligament from the anterior, the orientation of the fibers of the ligaments of Humphrey will be in a different direction. It will be like the posterior cruciate will be like vertical, whereas the Humphrey will go little horizontal. And we go posteriorly also, can visualize the Risberg ligaments. The ligaments serve as one more notifying point for between the anterolateral and the posteromedial bundle. How important is the PCL? It is a primary structure. Posterior tibial translation of the femur. The anterolateral bundle between 70 and 5 degrees. The posteromedial between 0 and 15 degrees. And it's a secondary stabilizer in external rotation and varus stress. Always, whenever you read about PCL, always think about the ACL. It always goes the other. And this facilitates femoral rollback during flexion. That is a very important role. In terminal flexion, the knee doesn't roll. It slides on the femur slides on the tibia. That is because of the posterior cruciate ligament function. So the mechanism of injury is, the commonest injury is dashboard injury, where the anterior force on the tibia cause the PCL to rupture either with substance or an avulsion injury, or actually direct blow to the anterior tibia, or fall on the knee with the foot in plantar flexion. Foot is neutral or dorsiflexion, the foot is deeper, whereas the vector actually acts on the anterior tibia when the foot is plantar flex. What are the critical signs or clinical signs in PCL injury? One is the posterior traction Clancy sign. There are different named signs, but all are the same. Clancy sign is where the anteromedial tibia. The anteromedial tibia, that is the left knee, which is prominent. This will be the loss of prominence of the anteromedial tibia on the affected side is Clancy sign. Whereas the same thing when we stabilize when it is gravity assisted, the patient keeps the foot on the couch on the examination table and we support the ankle. There is no active muscle contraction. When it is gravity assisted, it is called a posterior sac sign or a Godfrey. The other is the posterior Dwyer test, where you can see at 90 degrees of flexion, you can see the amount of posterior translation of the tibia on the femur, and it is graded accordingly, less than 5 mm, 5 to 10 mm, and more than 10 mm. Always compare the opposite knee. The patient's native ligamentous laxity is very, very important. Not all knees are the same. Just because a patient has a posterior Dwyer doesn't mean he is PCL deficient. It is always what his opposite knee says. And this is the quadriceps active test. It was already previously explained that when you contract the quadriceps, the knee moves forward in a PCL deficient knee. And what does this infer? In Gopi said 90 degrees, you can see increased external rotation. I mean, there is no increased external rotation, whereas at 30 degrees, there is more of external rotation. So it is the posterolateral corner injury. Okay, when it happens at both at 90 and 30, it is both posterior cruciate and posterolateral corner injury. And plain radiographs, you can see the avulsion fractures. You can see what is this? Second sign. To do a stress radiography, again already previously explained by the previous speakers, when there is more than 8 to 11 mm of translation, it indicates isolated post-acute ligament injury. A translation of more than 12 millimeter indicates a combined post-acute ligament and the posterolateral corner injury. And the MRI part has been previously very well explained. The low intensity and the ACL. Whereas you can see the loss of continuity in the PCL, the picture. So how do you manage post-acute ligament? You have diagnosed the injury. How are you going to manage? So there is a scope for non-operative management in post-acute ligament injury. In this place, avulsion features, isolated grade 1 and grade 2 post-acute ligament injuries, the patient can be managed conservatively, but it should be isolated. It's not in the case of multi-ligamentous injuries. You start with the RICE therapy, rest, immobilization, compression, and immobilization in extension with posterior tibial support. Put a tube strap with the posterior tibial support, or there are commercially available PCL braces for the chain. And the period of rest will complete immobilizing for 4 weeks. And at 4 weeks, you can change for gradually increase the strengthening exercises. And 6 to 8 weeks, the patient can start mobilizing. So operative management. Before going to the operative management, what are the most important points when we approach the post-acute ligament? These are the multiple terminologies we need to remember. Sulcus terminalis, trochlea point, medial arch point, and posterior point. In arthroscopic anatomy, there's no anterior, there's no posterior. Shallow, deep, high, and low. So these points are named based on the cartilage point, where the femoral cartilage ends. The sulcus terminalis is on the lateral femoral condyle, and when it curves on the intercondylar arch and it curves towards inside, this is the trochlea point. It is a constant point. Okay. The inferior point is the posterior. So between these points, the entire insertion on the femoral condyle, the medial femoral condyle. The medial arch point is a horizontal ridge on the medial femoral condyle, which separates between the anterior ankle and the posteromedial bundle, and this is the ligament of. How to identify that? What is the relationship to? So this is the convexity of the sulcus terminalis here, and when you can see that this point is the trochlea point, and you can see the anterolateral bundle ending over there. The medial arch point is the point between the anterolateral and the posteromedial bundle, and this is the posterior point. The femoral attachment of the PCL is a wide area, 20 millimeters square insertion, so you can play around a larger area other than ligament. Again, in a sectioned knee, you see the trochlea point above on the medial femoral condyle, the anterolateral bundle. This is the complete ligament, posteromedial and the posterior point, the posteromedial bundle behind. The anterolateral, the Humphrey and Risberg adapt the lateral meniscus. So once we remove out this, you can see the area of insertion of the anterolateral bundle. So in a single bundle reconstruction, which we primarily practice in our own institute, this is the point we are going to target over there. But in a high performance individuals, you may need a double bundle reconstruction. Posterior bundle is also required, and the medial intercondylar is between there. We started the trochlea point. This is how we are going to see the medial femoral condyle from your anterolateral condyle. From here, you will be seeing the interlateral bundle and the posteromedial bundle. So this was the older phase. Before we understood the anterolateral posteromedial bundle, the clockwise technique, that is between 7 and 11 o'clock for the left knee, from 5 to 1 o'clock for the right knee, was practice for the PCL insertion.
Dr. Shanal Sundaram talk to present on multi-ligamentous knee injury.
Good afternoon. Good afternoon. So my topic is multiligamentous knee injury. This is an X-ray cross showing the multiligamentous knee injury. This seems a little bit scary, very complex, and very confusing. So in this presentation, so I'm going to tell each one by one. For you all. Definition of a multiligamentous, but two or more, the four major ligaments of this. So what are the So good afternoon. So multiligamentous knee injury. So this is an post-op X-ray multiligamentous knee injury with the multiple interference screws. It's very scary and it's very complex and confusing to everyone when seeing this. So in this presentation, I make it. I wanted to make it as much as easy possible. So definition of multiligamentous knee injury is a tear of two or more ligaments. The four major ligaments of the knee. One is the anterior cruciate ligament, posterior cruciate ligament. Third one is the posteromedial corner. Fourth one is the posterolateral corner. So earlier we have discussed ACL and PCL. So in this presentation, we'll concentrate more on the posteromedial corner and posterolateral corner. So the mechanism of injury, the high velocity injury, mainly motor vehicle accident, accounts for 50% of the multiligamentous injury, followed by sport-related injuries and very low velocity injury in peace patients. So these are is associated with meniscal injuries of 55% and frontal injuries of 48%, and vascular injury, particularly popliteal artery, so which is 23 to 32%, so which is very devastating complication. So whenever there is a multiligamentous injury, always the post corner injury, more chance of getting a counter injury. Coming to shrink classification is for knee dislocation. It's classified into 5 types. So KD3, KD1 to KD5. So KD3 are further classified into KD3M and KDL. This like both ACL and PCL with KD3L means PCL with lateral ligament injury. It is further classified into KD3 and N if there is associated arterial neural injury. So it is broadly classified into 2 types. So acute and chronic injury. So our concern in acute chronic ligamentous injury is in the order of for the vascular. There is any vascular injury, it should be given priority, followed by the
bony avulsion injuries or bony fracture, then followed by the ligamentous. So this is a flow chart. If there is any knee dislocation or multi-ligamentous injury, first reduce the joint, then assess for the distal pulse and assess for the antebrachial index. The distal pulse is symmetrical and the ABI is more than 0.9. So then for the 24 hours and check for the serial pulse, distal pulse. There is asymmetry or ABI is less than 0.9, then you have to do a CT angiogram. If there is absent distal pulse or the signs of any limb ischemia is present, then emergency vascular intervention is needed. So if the ischemia time is less than 8 hours, the chance of amputation is 11% 1 week. If it exceeds more than 8 hours, chances amputation is 86%. Think of the time available as much as possible. You have to so this is the ankle brachial index. So we have to measure the ankle blood pressure. If the ratio of systolic BP, lower limb to the upper limb. So it should be less than 0.9. What to do with CTN? So if there is any multi-ligamentous, with the normal X-ray, so remember there is chances of previous spontaneously reduced knee dislocation. So keep in mind, let's check for the distal pulses. So there are some conditions that have a role of external fixator in the multi-ligamentous knee. If there is any associated vascular injury, there is any open fracture dislocation, there is any reducible dislocation, or if the reduced dislocation is unstable, or if there is any compartment syndrome. Coming to proper presentation, posterolateral corner. So what is posterolateral corner? So it is very important to know what are the structures in the posterolateral corner, then only you will further understand the presentation. So we have three important ligaments on the posterolateral aspect. One is lateral collateral ligament and a popliteus tendon, followed by the popliteofibular ligament. So these three are very important. If there is any tear in these three, each three needs special attention and how to reconstruct individually all the three ligaments. Followed by the dynamic stabilizers in the posterolateral corner. So biceps femoris, a lateral head of the gastrocnemius tendon, and iliotibial band. This is a bony landmark of LCL. Is the lateral aspect of the femur. So first we have to identify the lateral epicondyle, which is a prominence in the lateral aspect of the femur. So next, the LCL attachment, the femoral attachment of the LCL is just proximal and posterior to the lateral epicondyle. So remember in this slide, so the LCL is not attached on the lateral epicondyle, it is just above and posterior to the lateral epicondyle. So in the fibula, it is attached in the lateral aspect and anterior aspect of the fibula head. Coming to popliteus tendon, its primary action is the prevents the external rotation of the tibia relative to the femur. So its femoral attachment is just 18.5 mm anterior and distal to the LCL attachment. So tibial attachment is on the posterior aspect of the proximal tibia, just above the folial line. So coming to popliteofibular ligament, it also acts as an external rotation restraint and secondary stabilizer of varus. So its femoral attachment is originates from the myotendinous junction of the popliteus and inserts on the fibula styloid process, which is posterior and proximal most part. Coming to biomechanics, the varus stabilizer, the primary varus stabilizer is the LCL, everyone knows, followed by PCL. So external tibial rotation stabilizer is by in the early knee flexion is by LCL, followed by popliteus tendon and popliteofibular ligament, and the posterior tibial cancellation is by PCL, followed by PLC. So this is a clinical test, varus test, dial test, followed by US pivot shift, external rotation recurvatum test, and postlateral drawer test, which is all discussed in the morning session itself. So I skipped. So in the varus test, there is you have to do in the 0 degree and 30 degree. If it is in a 0 degree, so consider severe LCL, PLC, and associated push ligament insufficiency. If it is in 30 degree, consider only LCL tear. The dial test. So grading based on the varus instability. So grade 3 is which is more than 10 mm of opening on the varus.
which is associated with dial stress classified by the combined classification. Coming to stress X-ray, so we have to take a stress X-ray. So if it is more than 2.7 mm, consider only LCL tear in the lateral in the X-ray. If it is more than 4 mm, consider associated ligaments also, that is PLC corner injury. So MRI is very important to assess all the soft tissues as discussed in detail earlier. So coming to treatment, so if there is any grade 1 and grade 2 injuries, can be treated conservatively. So importance is for the grade 3 injury, which is an operative management. So conservative point of view, we have to give a hinge knee brace for the first 6 weeks. It should be locked in extension. So gradually you have to start the range of movement, weight bearing and strengthening exercise. We have to assess after the 6 weeks if there is any residual instability. Coming to operative management, the debate still is there for repair or reconstruction. So there are a lot of controversies around this. So early repair is possible within 3 weeks because the soft tissue planes will be preserved without any scarring and retraction. So consider the repair is possible in less than 3 weeks. With more than 3 weeks, consider the reconstruction. But in longer studies, repair is reported to have high failure rate than the reconstruction. So return to sports is also higher with reconstruction than the repair. So overall, reconstruction has much higher functional outcome than the repair. Coming to reconstruction, there are many techniques for reconstruction of PLC, of which 2 important techniques, modified Lawson technique and Lapret's technique. So the modified Lawson's technique, any graft you can choose, either it means hamstring graft or anything. So you have to make 2 tunnels. You have to make 2 tunnels in the femur. First tunnel is for the popliteus tendon and second one is for the LCL femoral tunnel. Then you have to make a tunnel in the fibular head. The from anterior to posterior. So anterior part signifies the attachment of the LCL and posterior one signifies the popliteofibular attachment. So we have to use the endo button. You have to fix the popliteus tunnel first, then it takes it out and fix it with the interference screw. Then it is looped into between the behind the iliotibial band and biceps femoris and fixed in the LCL femoral tunnel. So this technique offers good reconstruction. Still, it is not an non-anatomical reconstruction. So Lapret's comes into play. It is the anatomical reconstruction of the PLC. So here, 2 tunnels are made exactly on the footprint of the LCL and popliteus. Popliteus insertion. So it is the insertion of the popliteus which is anterior and distal to the LCL insertion. This is the lateral epicondyle. So we have to take a long graft. Then we have to take 2 grafts here. Need 2 grafts here. So one is for the LCL, another one is for the popliteus. We have to fix the femoral side first. Then on the other ends of the femoral, we have to insert. We have to make a tunnel in the fibular head. So we have to transfer the graft from anterior to posterior. So this graft is right beneath the LCL graft. Then we have to make a unite this graft and make a tie here. And we have to make these 2 grafts as one. And we have to drill the tibial tunnel just distal and medial to the Gerdy's tubercle and with the help of jig. And you have to make a tunnel here and you have to fix it with the tibial side. So this technique replaces all the 3 structures of the PLC here. Coming to posterior corner. So posterior corner includes superficial MCL, deep MCL, and posterior oblique ligament and medial patellofemoral ligament. So along with that, oblique popliteal ligament and semimembranous tendon. So it's the medial aspect of the knee. So here we need to know 3 bony landmarks, which is very, very important. So first one is the medial epicondyle, followed by the adductor tubercle. Adductor tubercle is just proximal and posterior to the medial epicondyle, and followed by the gastrocnemius tubercle. Gastrocnemius tubercle is also proximal and posterior to the medial epicondyle. So here the adductor tubercle acts as the lighthouse of the medial knee because it has attachment of the adductor magnus tendon. So we have to trace the adductor magnus and the prominence, that will be the adductor tubercle tendon. Coming to bony landmarks of MCL. So MCL is a primary valgus stabilizer. So it has two components. Everyone knows superficial MCL and deep MCL. So superficial MCL has one femoral attachment and two tibial attachment. So femoral attachment is just 3.2 mm proximal and 4 mm distal to the posterior to the medial epicondyle. And the tibial attachment, two tibial attachments. One is 12 mm distal to the joint line, another one is 6 cm distal to the joint line. And the posterior oblique ligament. So it acts as the internal rotation and valgus stabilizer along with the MCL in 0 and 30 degree of flexion. It has three components, of which central component is very important. It arises from the distal aspect of the semimembranous tendon blend with the postomedial complex. So this is a special test for the postomedial corner test, valgus test. With the valgus test X-ray, if there is more than 3.2 mm opening when compared to the opposite side, we consider it as the MCL tear. If it is more than 9.0 mm, consider the postomedial structures are torn. So treatment algorithm, if there is grade 1 and grade 2 injury for MCL is conservative management. Grade 3 isolated tear is based, if there is isolated grade 3 MCL tear, it is based on the site of the tear, whether it is femoral attachment avulsion or tibial attachment avulsion or mid-substance tear. If there is acute femoral attachment or mid-substance tibial attachment avulsion, it can be repaired. Mid-substance tear, we can treat conservatively. It is isolated. If it is associated multiligamentous injury, it needs to be reconstructed. So coming to the timing of surgery, so delaying surgery will always reduce the swelling and interval healing of the capsule and potentially the collateral ligaments and increase the range of motion. However, extensive scarring and anatomic loss of anatomic play will lead to not able to repair the ligaments and will lead to reconstruction. So in general, the delaying surgery for 10 to 14 days is the opt time to repair or reconstruct the ligaments in multiligamentous knee injury. So repair of the MCL can be repaired using suture anchors or augment with the fiber tapes. Coming to reconstruction technique, there are n number of techniques. So there are some name techniques: Kim's technique, Standards techniques, Flint's technique, Borden's technique, Danish, modified Danish, and Weave technique. So in Kim's technique, the hamstring semi-continuous graft is harvested. The tibial attachment of the graft is preserved. The insertion is preserved, and it should be. And then we have to find the isometric point in the femur by putting a K wire or any pin. Then we have to loop around that K wire, and then we have to look for the movements, knee movements, and find the isometric point. Then it can be fixed in the distal tibia, again in the distal tibia. Based on the fixation methods, it is tied to the semimembranosus. It is tied to the semimembranosus. It is called Kim's technique. So it signifies the MCL as well as the posterior oblique ligament. If it is wind around the semimembranous tendon and again stitch back to the same semity insertion, it is Standard's method. Link's method, so we have to make a tunnel exactly as the posterior oblique ligament insertion and fix it with the interference screw. Coming to Weave technique, it is also same. The semitendinosus is harvested and preserving the insertion at the tibial site, and you have to make a sleeve in the distal attachment of the MCL. So like this, we have to make a sleeve and you have to insert the semimembranous into this. So this previous techniques we have already taken a semimembranous from the attachment side. This is not exactly the anatomical reconstruction of the MCL, but in the Weave's method, so we are taking a loop here and this is the fixation point here. So it will be similar like an anatomical reconstruction. So from here, we have to identify the isometric point and fix it there, and then bring back to the tibia and fix it at the posterior oblique ligament. This is the isometric point how to find. So coming to sequence of fixation in the multiligamentous knee injury. So first thing that need to be fixed is the PCL, followed by posterolateral corner injury. Why? Because if you fix ACL before the posterolateral corner injury,
there are chances of tibia is going for external rotation. So after fixing ACL and PCL, if you do a reconstruction, there is posterolateral stability will be there, followed by ACL and followed by posterior corner fixation. So always remember the principle, always put a tunnel which is posterior and then come anterior. That will be deep. And always fix the tunnels in the femur first, followed by the tibia. So avoiding tunnel convergence, if you do a multiple ligamentous reconstruction, there are chances of tunnel convergence and chances of complication and failure. So we have to keep two things keep in mind while doing LCL tunnel and PCL ACL reconstruction. So you have to be making a tunnel in the lateral condyle of the femur for LCL as well as the ACL. So at that time for LCL, we have to direct our tunnel should be anterior and proximal to avoid the convergence with the ACL. At the same time, if you do a PCL and MCL or posterior corner tunnels, there is chances of convergence. So always MCL tunnel should be directed anterior and proximal. So by avoiding the convergence of the tunnel. So some post-operative rehabilitation, the first 2 weeks should be strict non-weight bearing. At least actually it is 6 weeks. So from 2 weeks to 6 weeks, initial period, we have to start a passive mobilization. Don't give active flexion. The quadriceps should not be activated at any point of time so that prevent the posterior tibial translation. From 6 weeks to 12 weeks, we can discontinue the brace and started the weight bearing. From 12 weeks to 24 weeks, there's no restriction in the range of movement. Full range of movement can be advised, followed by muscle strengthening exercise can be started. From the 6th month, patient can start doing the muscle endurance activity and slow jogging can be started. So after a year, patient can return to us. So to conclude, so graft choice is purely based on the availability and surgeon's preference. Associated injuries like meniscal or vascular injury to be addressed. If there is failure to identify or treat all the ligaments, so there are chances of failure and poor functional outcome. So anatomical tunnel placement, adequate graft tensioning, and proper rehabilitation is the key for this good functional outcome.
Topic in the post-lunch session. You have your sequential and methodological presentation. We have, I think, thank you for the presentation.
Good afternoon, sir. Today my topic presentation is avulsion injuries of knee. Introduction. Ligament avulsion injuries means a ligament or tendon attached to the bone. Knee joint is pulled away from the bone. It is often usually accompanied with the bone also. It is common in pediatric age groups. This type of injury typically occurs due to sudden trauma just during sports or falls. The initial presentation is pain, swelling, and instability of the knees. This is a case scenario. An 8-year-old male playing a competitive soccer match when he jumped to hit the ball and landed upwardly on his right leg. Immediately upon landing, he felt a sharp pain in his knee and he had a pop sound. He was unable to continue playing and he had to assist the field. His knee began to swell rapidly in the first hour. On examination, swelling was in the right knee. Tenderness for the anterior aspect of the knee. Range of motions restricted due to pain and swelling, particularly during extension flexion. Lactant was positive. And anterior is positive. What is next? First case is ideas. What's to be the next? Anyone? X-ray. These are X-ray and MRI findings. The finalists can answer X-rays and MRI findings. The tibial spine avulsion can see in the X-rays and MRI. These are anti-cruciate ligament tibial avulsions. Common of anti-cruciate ligament avulsion, tibial side avulsion is the most common. It's hyperextension coming with rotational injuries seen in ACL injuries. It's in extremely debilitating conditions with limiting daily activities. And if not addressed adequately, it leads to joint laxity, constant pain and fracture non-union and loss of range of movements. Hence, it should be addressed early. This incident is most common seen in pediatric age group. Which is associated with 15% displaced avulsion have a concomitant meniscal and condyle ligament injuries. Other associated ligament injuries are present. This is a Mayer and McNeil classification for ACL tibial avulsion. So this is type 1 is non-displaced fracture. Type 2 is minimal displaced with the anterior displacement with the posterior act as a hinge. Type 3 and type 3 is there is a displacement with there will be a small displacement and type 4 will be there is a commuter fracture. You see, since this is an X-ray finding with the tibial spine avulsion seen here, and there is an anterior hem arthrosis will be seen most of the patients. Others, we can also CT will demonstrate the comminution and what is the level of comminutions and fragment size. The MRI is the investigation size. It will also explain about the soft tissue entrapments. Our goal is to anatomic reduction of displaced fragment and continuity of the ACL fibers due to adequate rigid fixation and eliminate the extension block and impingement due to displaced fragments. Is a management. You should type 1 avulsions are managed with the long leg casting mobilization for 4 to 6 weeks. It is the extension is typically an extension. How to done X-rays 2 weeks once to until 6 weeks for fracture healing. For type 2, the management is controversial. Initially, then aspiration is done, sir, followed by close reduction in extension cast. If fragment is not reduced in loss of extension, loss of reduction in lateral X-ray, then we'll go for open reduction and fixation or with arthroscopy. Type 3 or type 4 injuries initially planned for conservative management, and they also trained if not reduced properly, then go with open reduction and internal fixation, also arthroscopic. The methods of fixation are retrograde wires, screws, anterograde screws and sutures, suture anchors, suture bridge and cable, and tension band wiring. These are various methods of fixation with screws and anchors, and the suture anchors. The most common pull-out screw fixation canals are made so the medial and lateral portal. And after this, there is a pass of a 90-degree suture lasso to pass the fibers in the medial lateral portals. After that, the suture ends are existing through the lasso through fiber loops, and they are taken out to the medial lateral portals of tibial tunnels. And finally, after sutures are brought out of both the tibial tunnels, and the final tightening is done, and the sutures are laid over the bridge or suture wheel can be used. There is a comparative study. The study shows that screw fixation versus suture fixation, and the fiber fixation is significantly stronger than screw fixations. So now another study that the unique fixation strength in response to a cyclic tensile load, anti-glutes fixation is most effective than other techniques. It's a post-op protocol, sir. It's similar to anti-glutes reconstruction. The complication residual laxity. This is mainly due to the countersinking of the fragment. How to because to prevent it, countersinking the fragment to decrease the residual laxity. For arthroplasty, how to do aggressive rehab protocol. While doing arthroscopic reduction and internal fixation, there should be rolled out notch impingements. Where implant prominence, in case of implant is symptomatic, how to go for removal of the implants. If in growth deformity in pediatric patients, it is spicer sparing fixation methods can be used. It's another case in collision. Her knee was struck on dashboard posterior during the impact, and she felt intense pain in the left knee. She was unable to bear weight on the knee, and the knee was quickly swelled after the accident. On examination, there is initially swelling It was tenderness over the posterior aspect of the knee. Range of movements are limited during presentation, especially in flexion. Posterior dart was positive. Sac sign is positive. Next, this is the X-ray images showing. Can anyone explain what is the X-ray images showing in the X-ray and MRI? The bony fragment in the posterior, so this is the PCL avulsion. And we are appreciated in the MRI also. PCL avulsion this is extremely rare variant. It's most commonly is intersections here, other than the femoral and tibial avulsion patterns. Instead, the general PCL is between 3 and 38%. It's an etiology, it's a mechanism of injury similar to the intersections PCL tear. Most commonly in motor vehicle accidents, since the posterior forces apply to the proximal tibia when the knee is flexed. Other conditions include sports is hyperextension injury. Tibial sided PCL avulsions are most common. And in case of pediatric patients, osteochondral avulsions are seen. Among pediatric patients, femoral sided avulsions are more common. Imaging, AP lateral views in the early reduction is displaced fragment is improved, so those improved rate of union. This is seen the X-rays, you can say focal discontinuity of the PCL facet, the posterior aspect of the tibia. And since PCL inserts about 10 mm distal to the joint line, it cannot be visualized, less than 10 mm fragments cannot be visualized in the X-rays. So if a fragment is displaced more than 10 mm, we can be easily visualized in the X-rays. If avulsion suspected but not visualized on the radiograph, then we can go for MRI. With the size of the fragments and the combination of the fractures can be detected by CT scans. Management, displaced avulsion fragments should be reduced and fixed to preserve the joint and prevent non-unions. In case of Zago et al., since a non-operative treatment fractures displaced less than 5 mm, here go for non-operative fixation. This non-operative management in the restoration of chemical relationship achieved with immobilization, and then go for physical rehabilitation. Sir. In case of non-operative, non-displaced and minimally displaced PCL avulsion is less than 5 mm. Multiple ligament injury means that requires yearly fixation of other structures. Then treat the fractures non-operatively. I mean, how to fix the other fractures and this treat the PCL avulsion fractures non-operatively. PCL brace has to be applied. Knee locked in full extension for 3 weeks and avoid active hamstring contractions. After 3 weeks, range of motions protocol begin and discontinue the PCL brace. 6 points. After 3 months post-operatively, return to sports protocols. Isolated PCL fracture fixation, return to sports by 4 to 6 months after the injury. Case of rehabilitation for non-operative conditions, for first 6 weeks, face immobilization, limited weight bearing, to apply cylindrical cast in 15-degree of flexion or with posterior support. Quadriceps strengthening and hamstring such exercises begin. Second phase is initially with full weight bearing, and 12 weeks, the third phase return to pre-injury athletic activities. In case of operative fixation, any displaced PCL fractures, tibial facet fractures are fixed with arthroscopic assisted versus open fixation. In case of open reduction internal fixation, Buxton scaffolds approach is a post-medial approach that involves the plane between the median of the gastrocnemius and semimembranaceous. Can be used with single forearm cannulated screw fixation or through pull-through suture techniques, or the 2 screws can be used for rotations. Arthroscopic techniques, pull-through suture technique, suture fixation. 2 tibial tunnels are made 4.5 mm from the antecortex of the tibia to the inframedial infralateral border of the tibial PCL fossa using a PCL tibial gate. Then after this, the PCL ligaments are coming to the 1 or 2 strands of non-double sutures, and the ethibond fiber can be used for the divergent suture bridges, and often fixed with the antecortex. In case of isolated displaced PCL tibial bony avulsions, coexisting meniscal condyle pathology, intra-articular free osteochondral fragments, then arthroscopic approach is best when compared to open reduction intervention. If in case of absence of coexisting intra-articular pathology, we can go for open approach. Post-op protocol is same as PCL fractures. Delay presentation. In case of if untreated, malunion or non-union instability can occur. This can be if delayed presentation, if it's non-union fracture or malunion fracture can be also treated with open reduction. This is also be same result with acute injury also, sir. Some methods of fixation of PCA levels. Single screws or double screws can be used. In case of pediatric patient, it's a very rare in pediatric populations. The non-operative treatment is 7 mm or displacement. It can be easily missed because of non-physics. Acute PCL is a large fragment of open reduction fixation. Small fragment is post-tibial abscess. Tibial translation is less than 10 mm, go for quadriceps rehabilitation, or posterior tibial translation greater than 10 mm, go for PCL reconstruction. Transaction scenario: a 16-year-old male soccer player on unmatched the team was a resident in a rural community, limited access to the medical services, present to the trauma, medical 6 days after the falling trauma, in terms of evolution of pain, swelling the left knee, and the inability to bear weight. The patient injuries occurred when he was playing soccer. His right knee was flexed in extension when he kicked a ball with his left foot. Subsequently, the patient experienced a severe pain in the left knee, fell directly onto the ground from a standing position, could not bear weight on the foot. He was immobilized and treated with the non-steroidal antibiotics like NSAIDs and physical medicine. However, when the symptoms persisted, the patient was transferred to IS center after the injury. This was the clinical image. The skin of the left knee was intact without abrasions or wounds, and the patient showed a diffuse increase in the soft tissue around the left knee, moderate joint effusions, and knee activity inflections. Can anyone point out what is the clinical image showing from finally? Both the there is an asymmetry of patella. He was unable to perform straight leg raises. Palpation of the tibial tuberosity are painful, unable to perform straight leg test due to pain. Lackman test was negative and no knee. This is the X-ray and MRI findings. This is a case of tibial tubercle avulsion. Seeing the patella tendon is retracted proximally. There is a distal avulsion of the patella and retracted proximally. Tibial tubercle avulsion fracture. It occurs in the most commonly adolescents of 12 to 16 years. Occurs in boys more often. Accounts for 1 to 3% of all facial injuries. In adults, it causes a tendon rupture. The main mechanism is push off or landing from a jump. Quadriceps contracts forcefully, and this will cause fracture. Examination is already explained. It's a spasm of hamstrings, not able to extend the knee against distance. There is a patient may feel a freely movable fragment of bone. It's X-ray MRI. Classification is Watson-Jones classification. Management, type 1B and 2 and 3 are managed with open reduction internal fixation. But tibial tubercle fractures can be fixed with 1 or 2 screws through a tibial tubercle in the proximal tibias. Post-op protocol is 4 weeks weight bearing fractures, 6 weeks strengthening exercise quadriceps passive flexion of 90 degrees, and active flexion extends mode up to 0 degrees. Weight bearing can be started. At 8 weeks, can construct full weight bearings. At 12 weeks, 130 degree flexion and 1 full extension. Dental sports activity at 5 months post-op. Case 4. 20-year-old man severe knee from a snowboard accident 5 days earlier after he slipped while jumping off the snowboard in the semi-flexion position. Immediately severe pain and swelling of the knee, which was still unable to bear weight with the initial treatment of long leg split. On examination, no impairment of skin integrity, moderate joint effusion, and widespread subcutaneous hematoma on the knee. The patient had a significant tenderness along the medial side of the knee. The patient showed a sign of positive tibial lag, a grade 3 Lagman, on anti-roid test. Soft tissue and find the grade 3 valgus testis. This is the X-ray MRI. The use of MCL. So femoral attachment of medial collateral ligaments. Medial collateral ligaments is a main stability structure on the medial side of the knee. It resists valgus stress. And when the posterior valgus once take place on the posterior flexor knee without rotation causes a medial collateral ligament avulsions. Most common MCT is a mid-body tears. Management is mostly disruption of fibers near femoral avulsion. Bone fragment near femoral avulsions causes is known as Pellegrini-Shedali syndrome. It's a chronic pain, knee pain. X-ray causes calcified formations. femoral, in case of femoral avulsion, it can be conservative management. If because you know, the grade 1 injury go for a without a brace, a hinge knee brace for grade 2 and grade 3. Range of motion exercise earlier weight bearing is tolerated. In case of tibial avulsion, so because you have to manage with it has to be fixed because pes and interposition between the tibia and the MCL is causes sternal type lesions. In case of acute, that's 3 weeks, go for MCL repairs, and chronic, greater than 6 weeks, we go for reconstruction. The method of fixation is screw fixation or fiber wire fiber tape. With substance here, we go for suture tape along with augmentation out done. So post-op protocols. Case 5. A 20-year-old man was a mountain biker and otherwise good health and without previous knee injury. Complained of lateral side right knee pain, sir, following high velocity crash. Mechanism also the inside of his right knee colliding with the tree trunk, generating a pure varus knee stress. He was unable to ambulate immediately following the event. Examination presented palpation of the lateral femoral epicondyle of the right knee. There was no principal knee effusion. It was anterior posterior test was negative. Active and passive range of motion are severely impaired. This is a X-ray, MRI, and this is a clinical image of the patients. What kind of avulsion? Let's say lateral collateral ligament avulsion and femoral attachment. This is a lateral collateral avulsion. It is in case it's also known as fibular ligament. It's a key stabilizer of lateral side. It would the part of the postlateral corner. This is a part of postlateral corner. There's a complete LCA test. Complete femoral insertion. There is a mid substance here account for 33%. The femoral insertion for 22.3%. So test account for LCL test. Management, non-operative and operative treatment. Non-operative treatment isolated grade 1 and grade 2 injuries with no instituted 0 degree. Non-weight bearing 1 week. In knee brace for 3 to 6 weeks. Sports and then sports activity 6 to 8 weeks. Operative treatment will go for grade 3 LCL tears with a significant repair. Isolated acute less than 2 weeks post injury. Femoral attachment also we have to fix with suture anchors. In case of surgical reconstruction, isolated grade 3 LCL tears. In subacute or chronic cases, it is greater than 2 weeks or acute complete missubstance here. We can go for acute avulsion with unachievable anatomical reduction. So with this condition, we go for surgical reconstruction. So last case was 40. Last. The 40. There is no issue of initiating trauma, sir. There is no episodes of locking, catching, and giving out knees. There is a popping sound arising from the chair or squatting. On examination, pain with full flexion, there is dominant tenderness. McMurray test is positive. There is no finding the X-rays. This is a MRI finding. Next, what is the MRI sign seen? There is a specific sign seen in this MRI. This is a ghost sign in the MRI. This indicates a posterior root of medial meniscus tears. It's a meniscus root avulsions. It concerns for knee joint, the meniscus avulsion, knee joint stability, congruence, and shock absorption. It's a radial tears. This is within 1 centimeter from the root. Root tear accounts for 7 to 9% of meniscal injuries, with 2/3 in the medial meniscus. Sir. The posterior medial meniscus root avulsion injury is an avulsion of the osseous attachment or complete relative with 9 mm of insertion. Because it increases contact pressure and leads to degenerative changes. Sir. It's the classification of meniscal tear. Management, if go for 3 kinds: non-operative, partial meniscectomy, and meniscal root repair. Sir. Non-operative, elderly are greater than grade 2 ONE. Partial meniscectomy go for symptomatic and greater than grade 2 ONE. The meniscal root repair for acute or chronic injuries and less than grade 2 ONE. How to the methods of fixation are suture anchor repair and pull out transtibial tunnel techniques. So post-op protocol, same as knee mobilizer or locked in extension for non-weight bearing for First week, initial knee flexion is up to 90 degrees, 46 strength increase. After 6 weeks, weight bearing is tolerated and flexion up to 120 degree achieved, sir. After 3 months, sports activity is done. Take home message. This is a prevention, knowledge of risk factors and mechanics, adapting techniques and training practices for athletes and athletes to avoid injuries. This yearly recognition, awareness of symptoms, prompt diagnosis and treatment, significant impact the recovery time. Optimal treatment, understanding severity and implication of the injury, conservative surgical. Rehabilitation insights. Long-term results, knowledge of potential consequences, chronic instability of arthritis. Performance maintenance. Athletes can better maintain their performance.
Home root tests are common. So, root tests are common.
Old age. Also, there is no physical complaints. Just when pain only from sitting and
Pausing practice around the knee. Good.
Next, we will welcome our Prabhakar Singh, sir. Thanks for accepting our request, sir. He will present about the rehabilitation after sports.
Yeah. Good afternoon, one and all. Respected Director and respected Professor Tulkapan, sir, and thanks for Professor Anthony Vimalraj, sir, Gopi, and my colleagues given me the opportunity to give the presentation. And thank you for the postgraduate staying in the post of lunch. And Karupusamy has been even for 10 years back. We've been at the Stanley Medical College, and our journey continues. So 10 days back, Gopi gave me a topic for this knee symposium. I told him I'm the only fellow available, so I cannot take the main topic. I will take the rehabilitation. That time, so I will come and participate. So sorry for the delay, sir. This is our statistics in our Department of Sports Injury and Arthroscopy in Omadura Multi-Specialty Hospital. On average, 1 year we receive 9,600 cases, and in that knee injury around 5,000 cases. ACL associated complications, 2,000 cases. Yearly we are doing around 350 cases ACL around, and PCL 15 to 20. And multi-ligament injury, only 5 cases per average a year. And the main aim is to return to sports. Most of the patients, there are sports persons. So in general, since ACL is more commonly we do surgeries, I'm just touch upon only the ACL rehabilitation. I'll just give the practical tips for the rehabilitation. The lengthy topic, I compressed from national, international, Ganga, and Clements are all who are the arthroscopic hospitals that are doing the rehabilitation, because each institution differs. Major things will be common, but according to the centers, tertiary care, small centers, you cannot expect the whole things of rehabilitation. So ACL injury or PCL or MCL, whatever the time was spending or reconstruction or doing, rehabilitation is same as that. Because I would say rehabilitation is a big thing which you have to concentrate on a patient. So you do a surgery, if he comes with a pain, you are under. If you have a sports person coming with a knee stiffness, you are not able to return to sports for any cricket or running or an athlete or a contact person, then you would be insured. So let's see so many cases in the court now. So don't think that arthroscopy, once you do ACL, we can get away with that. Till the patient goes to, after 9 months, go to the sports, he will be under your control. You have the rehabilitation continues for 1 year. After that, follow up every 6 months. So what we are doing is that once we do surgery, we discharge the patient on second post-operative day. We ask them to come for 5th day for dressing and 14th day for suture removal.
then every 15 days for 3 months, after that every month till 9 months. This is how we have been following the patients in Andhra Multi-Super Specialty Hospital. The importance of rehabilitation, it's an evidence-based. Everyone is having a Google. So whatever you give rehabilitation protocol, whatever you advise, the next moment you go out of the room, it's in the Google. So key reasons for evidence-based research is that main thing to restore the range of motion. He needs எனக்கு full movement வேணும் அவ்வளவுதான். நீ 10 degree lag கொடுக்குற எஃபெக்ட் கொடுக்குறனா he will not leave you. He will go to the second surgeon. So he need a full range of motion and graft healing and tissue remodeling. See, this is very, very important. You are giving an almost not the native ligament. Okay, you are giving an hamstring graft or bone tendon bone graft, or you are going to give an peroneus longus. So according to that, your rehabilitation should be tailored. If it is going to be bone tendon bone graft, you have a union around 6 months, it will be united, and you can put him on to 8 months in the return to sports. But if it is going to be peroneus longus or a hamstring graft or quadriceps graft, to take time. So your rehabilitation will be lengthened. So you have to educate him at the early stages of when you have to go for cycling, when you have to go for riding, when you have to go for running. And main thing is the neuromuscular control and proprioception in athletes. This is a very, very important, which needs to be concentrated after 3 months. And prevention of muscular atrophy imbalance starts from the day one. And functional and sports specific training, you have to give him psychologically, you have to treat not only the patient in and around his father, mother, his coach, everyone. And then the reduction of complications, secondary injuries, then optimal timing of return to sport. The moment he comes to the hospital, he will ask, when I will go back to the sports. So those answers, you should be ready with that. Common mistakes in rehabilitation. We all think that we do mistakes in post-rehabilitation, post-surgery. No. The rehabilitation starts in pre-op. ஒரு ஏசிஎல் பேஷண்ட் வர்றான், ஒரு பிசிஎல் பேஷண்ட் இன்ஜுரியில் வர்றான் அப்படின்னா எம்ஆர்ஐ பார்த்துட்டு ஏசிஎல் சர்ஜரி பண்ணவே கூடாது. எல்லா மிஸ்டேக்ஸுமே அங்கே நிறைய ஹாஸ்பிட்டல்லேருந்து கேசஸ் எங்களுக்கு வந்துட்டு எல்லாமே நம்ம ஆர்த்தோ தான் அனுப்புகிறாங்க. ஏசிஎல் எம்ஆர்ஐ பார்க்குறாங்க, சர்ஜரி கிடையாது. ப்ரீ ஆஃப் ரீஹாபிலிட்டேஷன். சும்மா கீழே விழுகிறான், சின்ன ஒரு டிஸ்ட் பிவட், ஏசிஎல் மட்டும் இன்ஜுரி இருக்கு, நோ போன் கன்ட்யூஷன், நோ எடிமா, டீம் ஆன் ரீஹாபிலிட்டேஷன் ஃபார் 3 weeks, டேக்கிங் ஃபார் ஏசிஎல் ரீஹாபிலிட்டேஷன். ட்ராமா, கான்டாக்ட் பர்சன், கபடியில் விழுகிறான், இல்லை ஒரு ஃபுட்பால் விளையாடும்போது விழுகிறான் அப்படின்னா, யூ ஜஸ்ட் எக்ஸாமின் ஹிம். ஹிஸ் ரேஞ்ச் ஆஃப் மூவ்மெண்ட் வில் பி 0 to 30 or 40 degree. வில் ஹேவ் ஸ்வெல்லிங். அவனுக்கு நீ எம்ஆர்ஐ பண்ணி பார்த்தனா நீ எஃபிஷியன்ட் இருக்கும், எம்சிஎல் ஸ்ட்ரெயின் இருக்கும், எல்சிஎல் ஸ்ட்ரெயின் இருக்கும், subchondral edema இருக்கும், subchondral fracture. In this stage, if you touch this patient, you will end up in stiffness. You will end up in arthropybrosis. So you have to give him time. You have to give him ice, basic things. First, ice compression, limb elevation, knee braces. Slowly, you have to wean the knee braces. You have to give him a contralateral limb line. உனக்கு quadriceps power இருக்கும், என்ன ரேஞ்ச் ஆஃப் மூவ்மெண்ட் இருக்கும், அட்லீஸ்ட் 85% நீ கொடுத்துட்டு தான் அவனை டச் பண்ணவே செய்யணும். அதுக்கு முன்னாடி நீ தொட்டுனா யூ வில் பர்ன் யுவர் ஃபிங்கர்ஸ். So common mistakes that lack of assessing patient's nature, duration of injury, lack of individualized treatment plan, lack of patient's education, gap between research and practice, regulations and limitations of the healthcare system. Tertiary care எல்லாமே இருக்கும், பெரிஃபெரியில் ஒன்றுமே இருக்காது. அதனால நீங்க வந்துட்டு நம்ம தான் அதுக்கு ஏற்ற மாதிரி ரெடி பண்ணிக்கணும். நம்மளே we have to learn the exercise. We should be turned into a therapist. நம்மளே ஸ்போர்ட்ஸ் தெரபிஸ்ட் ஆகணும், நம்மளே ட்ரெயினர் ஆகணும், நம்மளே எல்லாத்தையுமே டீச் பண்ணணும். ஸோ த ட்ரீட்மெண்ட் பிளான்ஸ் ஒவ்வொருத்தங்களும் வேரி ஆகும். கான்டாக்ட் பர்சன்ஸ், கபடி பிளேயர், ஃபுட்பால் பிளேயர்லாம் கான்டாக்ட் பர்சன், அவனுக்கு வேற மாதிரி இருக்கும். இதே இது வந்துட்டு ரன்னர், அத்லெட்டுக்கு அவனுக்கு வேற மாதிரி இருக்கும். எதுவுமே இல்லாமல் டென்னிஸ் பிளேயர் அவனுக்கு வேற மாதிரி இருக்கும். ஸோ ஒவ்வொருத்தனுக்குமே நீ ட்ரீட்மெண்ட் பிளான் டிஃபர் ஆகும். யுவர் ரீஹாபிலிட்டேஷன் டிஃபர்ஸ். இட்ஸ் பி டெய்லர்ட் அக்கார்டிங் டு த பேஷண்ட். மேலுக்கு வேற, ஃபீமேலுக்கு வேற. ஃபீமேலுக்கு வந்து வேல்கஸ் நீ இருக்கும், அவங்களுக்கு வந்து அவங்களுடைய டென்ஷன் ஸ்ட்ரென்த் பார்த்தோன்னா கம்மியாக இருக்கும். அவங்களுடைய ஹீலிங் இது வந்து ஹார்மோனல் சேஞ்சஸ், மென்சுரல் சைக்கிள்ஸ் எல்லாமே எவ்வளோ கூட்டிட்டு டேக் எல்லாத்தையும் கேட்கணும். எவ்ரி திங் அதுக்கு ஏற்ற மாதிரி தான் ஸ்லோவாக தான் அவங்களுக்கு ஹீல் ஆகும். ஸோ அவங்கள இவனை மாதிரியே நீ அவங்களே கூட ரன் பண்ணணும்னா ரீரப்சர் ரேட் இஸ் மோர், அது தனி சப்ஜெக்ட். அதனால ஒவ்வொரு பேஷண்ட்டுக்கு ஏற்ற மாதிரி, ஒவ்வொரு ஸ்போர்ட்ஸ் பர்சனுக்கு ஏற்ற மாதிரி கான்டாக்டா நான் கான்டாக்ட் இட் டிஃபர்ஸ். இன்சஃபிஷியன்ட் பேஷண்ட் எஜுகேஷன் நான் ஆல்ரெடி சொல்லிட்டேன். You have to give a counseling, not only with the patient, அவங்க கோச், அவங்க அப்பா அம்மா யார் இருக்காங்களோ அவங்கள்ட்ட உட்காந்து நம்ம டிஸ்கஸ் பண்ணோம். இது வந்து ஒரு லாங் ப்ராசஸ், எப்போ பண்ண போறோம், எவ்வளவு நாளைக்கு அப்புறம் நான் ரீஹாபிலிட் பண்ண, எப்பெல்லாம் நினைப்பான், எப்போ இது பண்ணான், 3 தான் கேட்பான். எப்போ பைக் ஓட்டுவான், எப்போ நான் அத்லெட்டிக் கோச்சிங் போகணும், எப்போ நான் திருப்பி ரன், எப்படி நான் காம்படிஷன், எப்போ நான் நேஷனல் போவேன், ஸ்டேட்டுக்கு போவேன், இந்த கொஸ்டினை கேட்டு தான் வரும். அதுக்கு நம்ம ஆன்சர் பண்ணிட்டு தான் சர்ஜரி பண்ணணும். சும்மா எம்ஆர்ஐ பார்த்தீங்கன்னா ஏசிஎல் வான் சர்ஜரி பண்ணிட்டேன்னா தட்ஸ் ஆல். Gap between the research and practice. Patient's preference, research, clinical experience. மூணுமே நீ correlate பண்ணி combine பண்ணி தான் you have to treat the patient. Preoperative phase. This is all everyone knows that management of pain and swelling, establish full passive range of movement. நாங்க என்ன சொல்றோம் first 2 weeksல first patient நாங்க surgery பண்ணி அதாவது pre-op phaseல இந்த மாதிரி வந்தானா ஐஸ் ஃபோமெண்டேஷன், compression bandage, knee brace கொடுத்துட்டு 2-3 நாள் 5 நாள் கழிச்சு ரிப்பீட் வர சொல்லிட்டு சொல்லிங்கெல்லாம் கொஞ்சம் ரெடி தானே நம்மளே குவார்டிசெப்ஸ், ஹாம்ஸ்ட்ரிங் எக்ஸசைஸ் டீச் பண்ணி ரேஞ்ச் ஆஃப் மூவ்மெண்ட்டை நம்ம எவ்ரி வீக் செக் பண்ணிட்டு ஒரு 3 வீக்ஸ்க்கு அப்புறம் ஸ்லோவாக அவனை பிரேசஸ்லாம் எடுத்துட்டு நல்லா ஒரு 85% கான்ட்ரலேட்டர் மாதிரி வந்ததுக்கு அப்புறம் தென் யூ ஹேவ் டு அட்வைஸ் இன் சர்ஜரி. Preoperative phase criteria is the minimal pain swelling, full passive extension. Extensionல காம்ப்ரமைஸே இருக்கக்கூடாது. Equal to contralateral limb, active and passive flexion, equal to contralateral limb, passive able to ambulance with a normal gait pattern using an assisted device, brace or as needed, and you should demonstrate good mechanics while performing partial squats if stability allows. So preoperative parameters, 80% unusual இருந்தா தான் நீ preoperative parameters. அப்பதான் நீ தொடவே செய்யணும் surgery. It's all proven research. So intraoperative நம்ம போகும்போது that is also நீ எந்த மாதிரி பேஷண்ட்டுக்கு தான் சொன்னல, எந்த பேஷண்ட் சர்ஜரி பண்ண போற அதுக்கு ஏற்ற மாதிரி ரீஹாபிலிட்டேஷன் டெய்லர் பண்ணிக்கணும். What type of grad? PTP-னா அவனுக்கு எவ்வளவு நாள் சீக்கிரமா ரிட்டர்ன் ஸ்போர்ட்ஸ். ஆட்டோகிராஃப்னா லேட் ஆகும். அது ஆட்டோகிராஃப்னா சீக்கிரம் ஆகும். அலோகிராஃப்னா லேட் இன்டகிரேஷன், லிகமெண்டேஷன், இன்டகிரேஷன், வாஸ்குலேஷன் தனி, அது ஒரு ப்ராசஸ். ஸோ அதனால எப்படி எந்த ஒரு கிராஃப்ட் எடுத்தாலும் 9 months to 1 year ஆகும். ஸோ அவன்கிட்ட சொல்லணும் இது வந்து நேச்சுரலா போய் நார்மல் லிகமெண்ட் மாதிரி வர்றதுக்கு 9 months ஆகும். அப்புறம் தான் நீ ஸ்போர்ட்ஸ்க்கே போக முடியும், அதை முடிக்க ரீஹாபிலிட்டேஷன் தான் அப்படின்னு சொல்லி அவன்கிட்ட சொல்லணும். அப்போ வாட் டைப் ஆஃப் சர்ஜரி, சிங்கிள் பண்டில், டபுள் பண்டில், எல்லாமே சிங்கிள் பண்டில் தான் பண்றாங்க. லாட் ஆஃப் கான்ட்ரா டைப் ஆஃப் இம்ப்ளான்ட் நான் யூஸ் பண்றேன், நீ வந்து ஸ்க்ரூ யூஸ் பண்றியா, இல்ல பைஆப்சபிள் ஸ்க்ரூ யூஸ் பண்றியா, இல்ல ரெண்டுமே ஸ்க்ரூ யூஸ் பண்ண போறேன், மேல வந்து பட்டன் யூஸ் பண்ண போறேன், எல்லாமே வாட் ஆர் தி இம்ப்ளான்ட்ஸ் யூ ஆர் கோயிங் டு யூஸ். இல்ல கூட வந்து நீங்க வந்து போஸ்ட் காணரி பண்ண முத்தனது ஒரு போஸ்ட் காணரி இன்ஜுரி பண்ணோம், 3 பைஆப்சபிள் ஸ்க்ரூ லேட்டரலா போட்டுருக்கோம், இந்த பக்கம் ஒரு ஏசிஎலுக்கு 1. அப்புறம் ஸோ இவ்வளவு பட்டன்ஸ் போடும் போது அவனை உடனே நீ ரீஹாபிலிட்டேட் பண்ணேன்னு வச்சுக்கோ, இவள் எண்ட் அப் பண்ணுது. போஸ்ட்லேட்டருக்கான இன்ஜுரிஸ்னா நீ பண்ணேன்னா 2 months 2 weeksக்கு வந்துட்டு நீ எக்ஸ்டென்ஷன் தான் வச்சிருப்பான். அவனை காலம் மடக்கவே சொல்லக்கூடாது. எவ்ரி 3rd week 4 week 20 டிகிரியா பண்ணி அதுக்கப்புறம் கண்டினியூ பேசிவ் மோஷன்ல போட்டு சிபிஎம் மிஷின் நம்ம இருக்கணும். அப்படி இல்லைன்னா இப்ப நான் கேட்கனருக்கு அனுப்புறேன், கேட்கன ரீஹாபிலிட்டேஷன் சென்டர்ல டைப் பண்ணிட்டு எந்தெந்த பேஷண்ட்டை முடியலோ அவங்கள, ஆனால் சிபிஎம்ல அவங்க வச்சிருப்பாங்க, அவங்க சார்ட் போட்டு ஒரு ஸ்டூடெண்ட் வச்சு ஃபுல்லா எழுதி அவனை அட்மிட் பண்ணி ஒரு 2 வாரத்துக்கு ஃபுல்லாவே இது பண்ணணும். அந்த மாதிரி கேசஸ் அவங்கள்ட்ட விட்டணும். நானே பண்ணுவேன் அப்படின்னா வில் it's a team approach, of course. And post-op, first 2 weeks is very important. Already சொன்னேன், first 2 weeksல பேஷண்ட் ஒருத்தவங்க வர்றாங்க அப்படின்னா சர்ஜரி பண்ணனே நீ வந்து அவனை வந்து சர்ஜரி பண்ண அப்பயே நீ பிரேஸ்ல போடணும், எக்ஸ்டென்ஷா நீ பிரேஸ்ல போடணும். எப்பயுமே நீ பிரேஸ்ல தான் இருக்கணும். நடக்கும்போது முதல்ல வந்து லேட்டா நடக்கலாம், நாங்க இப்ப பார்ஷியல் வெயிட் பேரிங் பண்ணலாம். யூ கேன் டூ 50% ஆஃப் பார்ஷியல் வெயிட் பேரிங் வித் நீ பிரேஸ். மற்ற நேரத்துல நீ பிரேஸை கழட்டி வச்சுட்டு அவனுக்கு ஸ்லோவா எவ்ரி டே 10 டிகிரி கணக்கு வச்சுக்கலாம். 7 daysனா 70 டிகிரி முடிக்க அலோவ் பண்ணலாம். 14th day அப்ப அட்லீஸ்ட் 90 டிகிரி நீ ஃபிளெக்ஷன் இருக்கணும். ஆனா டே 1ல இருந்து அதாவது எக்ஸ்டென்ஷன் நீ வந்து 0 டிகிரில மெயின்டைன் பண்ணணும். தட் இஸ் வெரி 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 இம்பார்ட்டன்ட். எக்ஸ்டென்ஷன் நீ விட்ட ஒரு 5 டிகிரி 10 டிகிரினா ஆஃப்டர் 2 weeks யூ ஒன்ட் கெட் இட். ஸோ எக்ஸ்டென்ஷன் தான் இம்பார்ட்டன்ட். ஃபர்ஸ்ட் 2 weeksல சூச்சர் மூவ் பண்றப்ப நீ திருப்பி வரும்போது அவன்கிட்ட அட்லீஸ்ட் 90 டிகிரி கண்டிப்பா வந்திருக்கணும்.
அதுக்கப்புறம் ஸ்லோவா கொஞ்சம் கொஞ்சமா அடுத்த 2 வாரம், ஃபர்ஸ்ட் 2 வாரம் நீ பிரேஸ் போடுறியா, அதுக்கு அடுத்த வாரம் நீ பிரேஸை போட்டு அவனை பார்ஷியல் வெயிட் பேரிங், அதாவது கொஞ்சம் 75% வெயிட் பேரிங். அதுக்கப்புறம் நைட்டு ஃபுல்லாவே போட சொல்லணும். அதுக்கப்புறம் வந்துட்டு ஃபுல் எக்ஸசைஸ் கண்டிப்பாக பண்ணணும். 4th வீக்ல ஸ்லோவா நீ வந்துட்டு அந்த நீ பிரேஸை எடுத்துட்டு அவனை டோ வெயிட் பேரிங், அப்புறம் பார்ஷியல் வெயிட் பேரிங், இல்லை சிங்கிள் கிரச்சஸ், ஸ்லோவா கொஞ்சம் கொஞ்சமா தான் கிராஜுவலா நம்ம இது பண்ணணும். அதே டைம்ல நம்ம மூவ்மெண்ட்டை இன்க்ரீஸ் பண்ணிட்டே இருக்கணும். ஸோ ஃபுல் ஃப்ளெக்ஷனை வந்துடணும், ஃபுல் எக்ஸ்டென்ஷன் வந்துடும். அதுக்கப்புறம் ஸ்லோவா ஸ்ட்ரென்தனிங், நியூரோமஸ்குலர் ட்ரைனிங், அதுக்கப்புறம் அஜிலேட்டிவ் எல்லாமே ப்ரொப்ரோசெப்ஷன், நியூரோமஸ்குலர் அடுத்தடுத்த ஸ்டேஜ் ஆஃப்டர் 3 months. அப்புறம் ஃபுல்லாக ஹெவி லோடு எல்லாமே இப்போ நம்ம ஹாப் அப் டெஸ்ட் அந்த வெயிட் கொடுத்து பண்ணுற எல்லாமே 4th month, 5th month, 6th month. ஸோ கிரைட்டீரியா வந்துட்டு ஃபர்ஸ்ட் வந்து யூ ஹாவ் நீ எக்ஸ்டென்ஷன் ரேஞ்ச் ஆஃப் 0 degree, cortical contraction with superior patella glide and full active extension. பெட்டலா தான் மெயின் இம்பார்ட்டன்ட், நம்ம அதை பார்க்கவே மாட்டோம். பெட்டலா கிளேடிங் இதை வந்து நம்ம பண்ண எக்ஸசைஸ் சொல்லி கொடுத்துட்டே இருக்கணும். அது வந்து ஃபுல் மூவ்மெண்ட்ஸ் வந்துருக்கணும் உங்களுக்கு. ஏபிள் டு பெர்ஃபார்ம் ஸ்ட்ரெயிட் லெக் ரைஸ் வித்தவுட் லெக். And next is the 3 to 5 weeks. It is intermediate post-op. Same thing, continue. Along with that, you have to give a range of forward brace, talk or establish, encourage the normal gait pattern, begin patellar mobilization, knee brace at night time, SLR without brace in the intermediate phase. Then establish and progress isometric cortical functions. Progressive dynamic closed kinetic chain exercise can be given. Criteria is the same thing. Along with that, normal walking at the end of 4 weeks. Then late, the 6 to 8 weeks. Previous one added with that, you have given prone, supine, SLR, hip abduction exercises, hamstring flexibility exercises, wean completely from crutches. In the வாரத்துல வந்து நீ crutch எடுத்துடலாம். நீ you can take crutches, you can ask him to mobilize slowly. Continue progress, return to activity program. Then you can start the proprioception, kinesthetic awareness, எல்லாமே sports related activitiesலாம் இப்போ நம்ம ஸ்டார்ட் பண்ண ஆரம்பிச்சிடலாம். This is the criteria. And then is the transitional phase, that is 9 to 12 weeks. Same thing with weight assisted 1 kg, then second time 1.5 kg, like that. Same proprioceptive kinesthetic awareness. Then lateral stability, lateral, your abductors, knee, lateral complex, ligament, knee joint, those things will be strengthened. This is the criteria. Then early return to sport, 3 to 5 months. Rehabilitation during the return to sports phase would be a criteria driven. Start with controlled activities, avoid uneven surfaces, contact situation, fatigue. மலையில போனேன், புளியில இது பண்ணேன், இன்னும் ட்விஸ்ட் போதும், பிவட் ஆச்சுன்னா முடிஞ்சு. அதெல்லாம் ரொம்ப இம்பார்ட்டன்ட். அதெல்லாம் அவன்கிட்ட சொல்லணும். மழை பெய்யும் போது எங்கெங்கெல்லாம் போகக்கூடாது, அதெல்லாம் நம்ம சொல்லணும். சர்ஜரி எவ்வளவு பண்றோமோ அவ்வளோ அவனை எஜுகேட் பண்ணணும். Then use sports specific drills to determine progress on unrestricted activities. These are the criteria. Return to sports. This is a very important one. And Mayor et al, he has given 4 stages of strength, which how an athlete could have an ACL reconstruction. You should have it. One is the dynamic stabilization and core strengthening. Next is the functional strengthening. Third, power development and sports performance inventory. These are the exercises, stabilization and core strengthening of the. This is the functional strengthening. The power development exercises. Then return to sports criteria. What are the criteria? Arthroscopic Association of North America has laid down some principles and they given some what are the things which should be cleared when return to sports athlete. Less than 10% of deficit strength of quadriceps, hamstring in isokinetic testing. Less than 15% deficit in lower limb asymmetry, and less than 3 mm of increased anterior posterior tibial displacement ligament test. Absence of effusion, full range of movement, normal patellar mobility, painless activities without folding. What are the mistakes in post-op rehabilitation? Go too rapid, very fast, neglecting neuromuscular training, re-injury risk factors, return to sport, poor communication with the surgeon, therapist, and patient. Then main thing is psychology of the patient. So if you're going too fast, what are the risks you have? Because graft healing and strength is very important. You need to achieve a good range of movement, muscle imbalance, neuromuscular control, and functional deficiency related to sports readiness. So they have done a lot of studies. It is proven in human also. So your ACL reconstruction, first 1 year will have 30 to 50% of the original ACL. So that is the time, if you have a poor rehabilitation, you can have a plastic deformity and lengthening of the graft. So neglecting neuromuscular testing. Any sports person, neuromuscular, he has to go for strategic phase, tactical phase, then reactive phase. These three phases should be achieved to go for the sports environment. Pre-injury risk factors, second ACL injury. If you are not concentrated on hip rotational control movement or any frontal plane, knee kinematics, knee flexor deficits, postural control, then you can have a re-rupture of the ACL. Same thing as the biomechanical factor, abnormal loading, limb length discrepancy, side-to-side differences, frontal plane displacement, reduced lower extremity flexor activation. These all can have a biomechanical impact. You have to be ready with all these questions. When should I have the knee brace to be removed? When can I go for car, bike? When can swim? When can I go for a job? You have to answer for that. So for the tip to the success, it will be a tailored surgical procedure. Neuromodulatory intervention should be there. Compensatory movements will be targeted. Rich rehabilitation environment. Psychological, social, contextual factors should be addressed. And ask him to avoid squatting in a toilet. Never allow him to inspect other surgeon for 6 months. Thank you. Any doubt, you can ask me.
Thanks for the elaborate presentation of the app. But so there is
ஆல்ரெடி நம்மகிட்ட வரும்போது அவனுடைய பவர் எல்லாமே கம்மியாயிரும். ஸோ இஸ் பவர் சார். இல்லை சார், என்ன ரிசர்ச் அவன் ஸ்டடிஸ் என்ன சொல்றாங்கன்னா, நம்ம போற ஏசியில் வந்து இப்போது 50% லெஸ் தென் தி நார்மல் பயாலஜிக்கல் ஏசிஎல் தான் சார். அதனால தான் அவன் லோடு கொடுக்கும்போது மோர் சான்ஸ் ஆஃப் பிளாஸ்டிக் டிஃபார்மிட்டி லென்த்னிங்ல இனிஷியலா அந்த கொஞ்சம் அந்த இன்ஃப்ளமேஷன் செட்டில் அந்த வெயிட் பேரிங்
அதுக்கெல்லாம் வந்து experience பார்த்து form the protocol for everything. See female, male. Experience wise would be taken. 2 to 5 months left. Return to sports if you are following support. Yeah, before that, after the protocol development.
Good afternoon, sir. The topic is
We request Dr. Anand sir to present topic on osteochondral injuries of knee joint.
Welcome, sir. My topic is osteochondral injuries of the knee joint. Articular cartilage can able to withstand tremendous forces over many cycles, but does not have the ability to heal even after a minor injury. In 18th century, John Hunter said that the ulcerated cartilage is a troublesome thing. Once destroyed, it is not repaired. Osteochondral injury most commonly occurs in knee joint, occurs in both young due to the trauma and in elderly population due to the degenerative changes. Clinically, the patient will have knee pain mostly on the weight bearing and swelling, locking, which spontaneously disappears, and the hearing of grating sounds, the joint movement, and sometimes patient may have the giving way. On examination, patient will have the joint line tenderness and effusion in the joint. Loose bodies are rarely felt by touch. In the osteochondral injury, there is a three classification. One is based on the configuration, and the other two are based on the severity. The based on configuration, Bayer and Jackson classification is available. Here is grade 1 is linear, grade 2 is stellate, grade 3 is flap, grade 4 is crater, grade 5 is fibrillation, grade 6 is degrading. Based on the severity, the outer bridge classification, grade 1 is softening and swelling, grade 2 is fragmentation and fissures, which is less than 0.5 inches in diameter, grade 3 is more than 0.5 inches in diameter, grade 4 is exposed to subchondral bone. Then another classification based on the severity is ICRS. So, grade 1 is superficial, the soft indentation or superficial fissures and the cracks. Grade 2 is less than half of the thickness of the articular cartilage involvement. Grade 3 is more than half of the thickness of cartilage involvement. Grade 4 is lesion extending to the subchondral bone. Investigation, mainly we are taking X-ray, CT scan and MRI. The X-ray, as usual, routinely we are taking anteroposterior view and the lateral view. Intercondylar knot view, it's taking in the osteochondritis dissecans because mostly it occurs in the lateral part of the medial femoral condyle. It sometimes it may not be visible on the anteroposterior view. So that we are taking the intercondylar knot view and the merchant view to look for the patella. The CT scan is taken for the location and size of the fragment, and the MRI was taken because sometimes in chondral injury, I mean in a cartilage injury, it may not be visible on the X-rays, but for that we are taking the MRI and to look for the soft tissue status and the viability of the fragment. The treatment. Conservative management can be done in the stable lesions and skeletally immature patients. Operative treatment can be done in the unstable lesions and adults. And depending on the age and the size of the lesion, the treatment may vary. A non-operative treatment, knee immobilization for initially first 3 weeks, then knee range of motion was started, and weight bearing is started as tolerated from 4 to 6 weeks, depending on the size of the fragment. And X-ray was taken after 3 months. If it reveals adequate healing, patients are allowed to gradually return to activities. If no changes observed, X-ray assessment is repeated in 3 months. But usually after 3 months, if there is no any progression, we go for the operative management. In operative management, the stable lesion, any stable lesion, if the failure of non-operative treatment for 3 months, in unstable lesions, in exposed subchondral bone defects and symptomatic lesions. The treatment methods available are arthroscopic debridement, fixation of the fragments, bone grafting, fragment removal, and chondral resurfacing like microfracture and port technique. The lesions that are massive, more than 3 centimeter in diameter, lesions that are inaccessible to arthroscopic technique are treated by open arthrotomy. Arthroscopic debridement, when debriding a lesion, rotate the cutting surface of arthroscope blade 90 degree and use only the blade edge in the tangential fashion. The microfracture, you mostly use drill and arthroscopic awl. the microfracture, we are drilling the subchondral bone. The holes should be placed at least 3 to 4 millimeter apart, and the fat emerging from marrow cavity indicates the appropriate depth. If the arthroscopic awl is used, there is no thermal damage to be expected to the bone as seen with the drills. When the blood flow from the bone marrow seems to be adequate in all areas of defect, after reducing the irrigation fluid, the procedure is terminated. The excision of loose bodies can be done in small fragments, which is less than 2 centimeter, in multiple fragments, and fragments that cannot be secured with internal fixation, and in chronic fragments like in non-union and avascular fragments. The fixation can be done in unstable lesions. The techniques we are mostly followed are headless screw fixation, cancellous screws with the countersink, and the bioabsorbable screws and bone grafting. The osteochondral autograft transplant. Initially, you have to look for the visualize the lesion. Then we have to measure the size of the lesion can be measured with an arthroscopic ruler. The defect is prepared until a healthy, stable tissue margin is reached. Proceed with the donor harvest before drilling the recipient site. Donor graft are harvested from an area of lower contact pressure like supralateral or supramedial femoral trochlea. The recipient site is then drilled to the same depth and diameter as that of the harvested plug. The graft should be inserted gently into the recipient site, avoiding too much pressure on graft. The final seating may be performed with a digital pressure. If multiple plugs are utilized, initially working at the periphery, then inserting the central plugs are lost. If multiple bone plugs are used, it's called a mosaicplasty. In autologous chondrocyte implantation, this procedure is indicated for the treatment of medium to large full thickness cartilage defect more than 3 centimeters square. The basic principle is using the patient's own chondrocytes to grow the new cartilage and to fill the defects. The benefits are use of the autologous cells, which are reducing the risk of immune rejection. It is a two-stage procedure. The first stage includes the arthroscopic evaluation of the chondral defects and an articular cartilage biopsy. The second stage is implantation of the cultured chondrocyte. The cartilage is usually harvested from the superior and the lateral aspect of the intercondylar notch. The curette is used to strip the cartilage, which measures approximately 5 millimeter wide and 10 to 15 millimeter long, 200 to 300 milligram weight, and we have to place that graft in the sterile transport medium for a shipment. We can store the graft for 5 years by using cryopreservation. In a standard graft preservation and standard cultivation technique, we can yield up to 4 vials of 2 million cells each contained in 0.4 ml of culture media. The cells are delivered the day before or day after procedure and usually expires within the 48 hours. Through a limited medial or lateral arthrotomy, we are opening the knee joint, and a defect is outlined with a fresh scalpel down to the subchondral plate, taking as much of surrounding cartilage to remove all unstable cartilage. The minor punctate bleeding is frequently encountered. The tourniquet should be released during defect preparation to visualize and address any potential bleeding. As shown in the image, cut the collagen membrane according to the template, and then porous side is seeded with the chondrocyte solution. After 5 minutes of chondrocyte, after 5 minutes, chondrocytes attached to the membrane. Then patch is placed in the defect. The patch is sutured tight enough to not sit on the bone, but rather be flush with the surrounding cartilage, creating a space underneath to inject the chondrocyte suspension. Reabsorbable 6-0 suture on cutting needle is used for suturing. In ACI, the 3 generations are there. First generation is periosteum covered ACI. Second generation is collagen covered ACI. Third generation is matrix induced ACI, where chondrocytes are grown on a scaffold for easier. This is the first generation. As mentioned here, first we are taking the damaged cartilage. Damaged cartilage is removed and biopsy is taken from the non-weight bearing portion. Then we are sending the graft for the cultivation and to grow the chondrocytes. Then the periosteal patch is harvested from the sutured, harvested from the proximal part of the tibia, mostly proximal part of the tibia. Then a suturing in the defect under the cultivated chondrocyte is injected under the patch. The complication of this procedure is periosteal hypertrophy, post-operative pain at the harvest site, and calcification, delamination, intra-articular adhesion. In second generation, instead of periosteum, we are using porcine collagen type 1 or 3 membrane. Then in the third generation, we also known as the Massey technique, matrix-induced autologous chondrocyte implantation. Here, the graft is taken from the non-weight bearing area, mostly in the intercondylar region, and after sending the graft for a culture and cultivation, after 6 weeks, 6 weeks of the procedure, we are the membrane is sized according to the template. Then we are debriding the defect area. Then fibrin glue is applied over the defect area. Then the patch is placed over the defect, and after a few days, the chondrocytes is seeding from the patch into the subchondral bone. Few days after that procedure, chondrocyte starts to grow from inside to outside. Immediately after the procedure, the knee is we have to check we have to check the flexion and extension after a procedure is 10 minutes of the procedure to check I mean the fixation of the graft. Then drains to be avoided to damage the patch. If used, it should be without suction. Here, I want to describe a few points about the first generation, second generation, third generation. The materials in first generation we used are periosteum. In second generation are the porcine collagen type 1 and 3. And the third generation we are using cell seeded scaffold. And first generation the main drawback and complications are periosteal hypertrophy, suturing to the surrounding cartilage, and calcification can occur, intra-articular adhesion can occur, delamination can occur. In type 2 second generation, the suturing to the surrounding tissue, we are doing the suturing to the surrounding tissue, but there is less calcification, intra-articular adhesion, delamination comparing to the first generation. In third generation, we are there is no need of suturing. We are mostly it's a adhesive, but at the same time it's a mini arthrotomy procedure. There is very less calcification, intra-articular adhesion, and delamination. Cost effectiveness wise, first generation is low cost effective. Second generation is high cost effective. Third generation is very high cost effective. And cell distribution wise, in first generation we are mostly expecting the hyaline like cartilage, but here the along with the hyaline cartilage, some fibrous cartilage is also there. And second generation also, along with the hyaline like cartilage, some fibrous cartilage is there. In third generation, almost all cells are hyaline cartilage only. So because of the fibrin cartilage, fibrous cartilage, in first generation and the second generation, it may lead to the yearly arthritic changes. In rehabilitation, long rehabilitation and slow post-operative recovery in the first generation, the yearly rehabilitation and the immediate post-operative recovery in the second and third generation. This is the algorithm. In osteochondral lesion, Here I want to describe a few points of the osteochondritis dissecans. Osteochondritis dissecans is a focal idiopathic alteration of the subchondral bone with a risk of instability and disruption of adjacent articular cartilage that may result in premature osteoarthritis. The subchondral bone becomes a necrotic fragment separate under the degenerative changes occurs in cartilage overlaying it. Most common source of it's the most common source of loose bodies in the knee joint. The exact prevalence of osteochondritis dissecans is unknown. It mostly occurs in the between the 15 and 30 per 1 lakh population. Male and female ratio is 2:1 to 4:1. Nowadays in female population, it's increasing because of increased sports related activities. And age-wise, OCD is seldom present before the age of 6 years. Most frequently presenting at 10 to 20 years. Lateral aspect of medial femoral condyle near the attachment of physical is the most common site, and it occurs bilateral in 20 to 30% of patients. And the medial condyle, it mostly occurs, and medial condyle mostly occurs in the 85% of the cases. Lateral condyle in 15% of the cases. The medial condyle and the medial, the lateral aspect, it occurs in the 69%, and the lateral condyle, lateral aspect with some medial part involvement, 6% of the cases. The inferior aspect occurs in the 10% of the cases. In lateral condyle, in the inferior aspect, 13% of the cases. Anterior aspect, 2% of the cases. Etiology, there is several theories explained about the etiology for the osteochondritis dissecans. Mostly ischemia, repetitive microtrauma, familial predisposition, endocrine imbalance, and epiphyseal abnormalities. But most of the authors think that the repetitive microtrauma is the most common cause for the osteochondritis dissecans. Because of the etiology, there is necrosis of the subchondral bone. The necrosis of cartilage overlaying the necrotic bone leads to a separation of the necrotic bone and cartilage. That leads to a loose body formation and finally ends in the degenerative arthritis. The clinical features are history of trauma to knee in 40 to 60% of the cases. Mostly in the history of overuse, that means repeated microtrauma patients. Almost similar classifications. In osteochondritis dissecans, we are using the burnt and hearty classification. The stage 1 is the subchondral bone compression. Stage 2 is the incomplete separation of the fragment. Stage 3 is a complete separation but no displacement. Stage 4 is a displaced fragment. And Dipola, Nelson, Colville staging system for osteochondritis dissecans by using the MRI. In stage 1, there is a thickening of articular cartilage and low signal changes. Stage 2, articular cartilage reached low signal rim behind the fragment, indicating the fibrous attachment. Stage 3, articular cartilage breached high signal changes behind the fragment, indicating the synovial fluid between the fragment and underlying subchondral bone. Stage 4 is a loose body. In a rock study group of OCD lesion classification based on the arthroscopic changes, there is a totally 6 types are available. Type 1 is the cue ball. There is no abnormality detected arthroscopically other than the bulge. Then type 2, there is a cartilage is intact and subtly demarcated. Type 3 is a wrinkle in the rug. Here the cartilage is demarcated with a fissure, buckle, or a wrinkle. In a type 4, locked door, the cartilage is fissuring at the periphery and unable to open the hinge. Type 5, it's a trap door. The cartilage fissuring at the periphery and able to hinge open. The type 6 is the crater. Here exposed the subchondral bone defect. The prognostic factors, age-wise, older patients have a poor prognosis, and duration of symptoms, longer the duration have the poor prognosis. Size, larger the lesion, poorer the prognosis. MRI, stage 1, stage 2, stage 3 has a good prognosis. Treatment is same as the osteochondral. Thank you.
Thank you, Ahmad, for the extensive presentation. So next we will invite Dr. Gogul Dev to present on orthobiologics in knee sports injury.
Good afternoon, everyone. The people in the back, pay some attention. I'll finish fast. So we'll start by identifying the person. Prabhakaran. You didn't see my presentation. Now, Prabhakaran. Stephen Perrin. So when you're talking about orthopedics and biology, it's a very prominent name by his paper on the biological fixation of fractures in the around 2 decades back. So here in today's presentation, we are taking it up a notch higher. So we are starting to understand what the cells are doing, and we are trying to learn more about the wound healing and its practical applications in orthobiologics. So anyone identify this character from Greek mythology called Prometheus? So he was banished and he was tied to a rock, and eagle was made to eat his liver daily for a large number of years, and every day when the eagle returned, his liver had grown back. So it's about the regenerative power of the liver, which the Greeks had known thousands of years back. So orthobiologics has this relation with this regeneration, where the regenerative medicine forms the basis for the orthobiologics. So according to Mayo Clinic, the regenerative medicine is defined as the process of replacing or regenerating human cells, tissues, or organs to restore their normal function. It can either replace the damaged tissues or stimulate the body's own repair mechanism. The initial damage may be due to either aging, degenerative process, or a disease or a defect. So orthobiologics is a part or a subset of the regenerative medicine, where it harnesses the potential of naturally occurring biological substances to bring about favorable outcomes in musculoskeletal pathologies. So it was it had started very early even in the 1940s itself, where bone marrow aspirate was used for non-union of fractures. So the products available in orthobiologics are culture expanded cells like chondrocytes, which Dr. Anandan sir had discussed. Mesenchymal stem cells are induced pluripotent stem cells, and cell isolates or concentrates like platelet concentrates and bone marrow aspirates or concentrates, which we more often use. So we'll start with the stem cells. So stem cells, you all know that they have the ability to divide and form tissues. And these are the various type of stem cells: totipotent, pluripotent, multi, oligo, and unipotency. So the mesenchymal stem cells, which is the basic stem cell for the entire musculoskeletal system, is a multipotent stem cell, which means it can form many different types of tissues, but not the tissues from all the three germ layers. So it is called the multipotency. So the mesenchymal stem cells are multipotent. These are the tissues that the mesenchymal stem cells can form. The entire musculoskeletal system, adipocytes, dermis, muscle connected to everything comes from the mesenchymal stem cell. So where can we find a mesenchymal stem cell in an adult? So these are the sources. It can be seen in blood, bone marrow, adipose tissue, placental, umbilical cord blood, dermis, and dental pulp. So as orthopedicians, we can access these two areas very easily: blood and the bone marrow. Since the concentration of the stem cells is very less in the blood, we prefer acquiring these stem cells from the bone marrow. So mesenchymal stem cells, meso means middle and chymo means infusion. So these stem cells are derived from the mesodome. Among the three germ layers, they derived from the mesodome.
and they kind of infuse through those two membranes and form all the tissues. And this specific ability to spread and migrate in early embryonic development between the ectodome and endodome. And even in the adulthood, when there is a wound or an injury, these cells tend to go there immediately and proliferate and form the specific tissue in need. So they respond to the local cues and differentiate accordingly to achieve regeneration. So as Dr. Anandan sir has discussed, we can use culture media to make these mesenchymal stem cells to form particular tissues like cartilage, depending on the cell density, how we are culturing it, what are the conditions we are culturing it in, and what are the chemical mediators we are putting in. We can make these stem cells into cartilage or whatever tissue we want, but it is highly costly and a lot of expertise, and the setup is very much high, what is needed, and it needs certain certifications to be allowed to do this procedure. So we take the easier path where we can acquire these stem cells from the bone marrow, which is the bone marrow aspirate, which is a rich source of the mesenchymal stem cells, cheap and less invasive. It is estimated that the 1 ml of iliac crest aspirate has around 40 million cells, out of which the 1500 are stem cells. So it can be injected as such, or it can be concentrated and injected. So at a time, around 50 to 60 ml of bone marrow can be aspirated. So where to aspirate in the iliac crest? There have been studies which have been done to identify the best area for aspiration. So they have taken the entire iliac crest, divided it into 6 parts from anterior to posterior, with the center and the acetabulum. So they have found that in the posterior aspect, in the zones 5 and 6, the thickness of the iliac crest is around 1 centimeter, the total thickness. And in the anterior part, it is around 0.5 to 0.6 centimeters. It is thinnest in the zone 4. So with accordance to the thickness of the crest, it is best to stay in the posterior aspect. So we can put the patient in the lateral or prone position and aspirate from the zone 5 and 6. And regarding the depth to which the trocar can be inserted inside, we can see that in the zone 5 and 6, if we go too much inside, we are going towards the greater sciatic notch, and there is risk of injury to the sciatic nerve and the superior gluteal vessels. So they recommend injecting the trocar up to 5 to 6 centimeters inside. And once if there is no aspirate coming, do not progress inside. You just withdraw the trocar and inject in a slightly different direction. Do not increase the depth of injection. So in the anterior part, we can go around 10 centimeters. The trocar can go in, but because of the thickness issues, it's best to stay in the posterior aspect. So the rule of 6 and 6, we can stay in the zone 5 and 6 and inject the trocar around 5 to 6 centimeters. So the applications of the bone marrow aspirate can be in sports in terms of overall application, most commonly used for a non-union or delayed union of fractures. In terms of sports injuries, this can be used for partial ligament tears, meniscal injuries, chondral defects, and augmentation during ligament repairs. Post when you are reconstructing an ACL or doing a meniscal repair, we can post the reconstruction, we can inject the bone marrow aspirate inside, and it has been shown that the when they have compared the isolated meniscal repairs and meniscal repairs with cruciate ligament reconstruction. It has been shown that those menisci which have been repaired along with the cruciate ligament reconstruction have showed better healing. It's because when you are drilling the tunnels for the cruciate ligaments, the content of the bone marrow tends to leak into the joint, and because of the biological factors in the marrow, it has shown better healing. So the other use is the chondral defects, where we can concentrate the bone marrow and use scaffolds like this, which are commercially available. These are hyaluronic acid based scaffolds. So we can use this and apply the bone marrow, concentrate on this, and we can clearly debride the chondral defect area, and we can apply this. So this is a commercially available scaffold, whereas this one is the fibrin clot, which we'll be discussing later. It can be prepared from our own blood. This can also be used as a scaffold. So here we can see that for a chondral defect, along with the drilling procedures, they have used the, after drilling, they have used the bone marrow aspirate concentrate along with the scaffold to fill up the area. So next coming to the platelet concentrates, these are the preparation of autologous human plasma with increased platelet concentration, which we get through series of centrifugation. It exerts chemoattractant, angiogenic, and proliferative effects. So why are we choosing platelets? There are a lot of cells in the blood. Why are we preferring platelets? Because platelets are one of the first cells to arrive at the site of injury to achieve the hemostasis. So they also have these granules, which we'll be seeing, which are rich in these growth factors, various growth factors. Around 30 growth factors have been identified. The important ones are shown here. So when we are concentrating the platelets, we are doing heightened delivery of this combination of growth factors in supraphysiological doses to the site of where the healing is needed. So this is the structure of a platelet, consists of this alpha and dense granules. Once it reaches the site of injury and on contraction, it releases all these growth factors into the area of where the healing is needed. And these are the functions of these various growth factors. There is no one exclusive function. There is always an overlap.
Growth factors are
alpha granules. These are the various functions. There is no exclusive function. There is always an overlap. Angiogenesis, cell replication, fibroblast proliferation. So all these factors in unison help in healing. So how was this platelet-rich plasma discovered? It was actually discovered for to manage these mandibular defects post mandibular resection for tumors. They found it difficult to achieve union by using simple bone grafts. So they use this platelet-rich plasma. So this is the histological image pre and post preparation of the platelet-rich plasma. We can see that even though we are concentrating only the platelets, we can see some WBCs and RBCs still in the. So this is the average platelet concentration, which was in the first published paper, around 3 times the concentration of the platelets which they have achieved. So how do we make the platelet-rich plasma? We take the blood along with the anticoagulant and we put it into the first cycle of centrifugation. It splits into these 3 parts: the platelet core plasma, the buffy coat containing the WBC and the platelets, and then the RBCs. From here, we can go in 2 ways. We can entirely discard the RBCs and the lower part of the buffy coat, and we can get what is called the pure platelet-rich plasma, which is like this. Or if we want the entire buffy coat, we have to take some part of the lower part of the RBCs as well. So it will contain a lot of leukocytes. This is called the leukocyte-rich and platelet-rich plasma. So since leukocytes have been found to have some toxic effects on the synovial cells, we are not regularly using this, and we are routinely using this. Okay. So we take the blood, anticoagulate, 2 cycles of centrifugation, and we get the platelet-rich plasma. So if we are not using any anticoagulant and we are doing a slow centrifugation, we get what is called the platelet-rich fibrin, which can be used as a scaffold, like we saw in the previous managing of the chondral defects. The pictorial representation: first is centrifugation, discard the RBCs. Second centrifugation, we the platelets settle at the bottom. We remove the upper part and we get the platelet-rich plasma. So this is the protocol followed at our institution. There is no standardized protocol. Each institution follow their own protocol, and the RPM and the duration varies with the institution. So can the PRP be stored? The usual lifespan of the platelets is 5 days. So we usually use it, prepare the platelets via PRP on a few hours before the procedure. We inject it immediately. It can be stored at room temperature with agitation for 5 days, like we store the normal platelets. There have been studies where they have stored the PRP at -80 degrees Celsius, and even at 1 year of after storage, they have found that the platelet count and the growth factor tend to remain stable, and they have told that it can be used if properly preserved. And how to deliver it, we can, in case of knee joints, we can directly inject it, and it can be done under ultrasound guidance as well, depending on the region. So these are phases of healing: inflammatory phase, proliferative phase, and the maturation phase. It is not exclusive, and there is always an overlap. So we can see the inflammatory phase, where there is inpouring of all the platelets and the inflammatory cells, and the proliferative phase, where the macrophages dominate and the fibroblast proliferation occurs. And in the remodeling phase, where the cellularity starts to decrease and the extracellular matrix gets trimmed down to whatever is needed. So we can see that all these growth factors playing a very important role. So this is where our PRP is used. So again, just to report growth factors. So applications of platelet concentrates, it is similar to the throat, not confined to the sports knee injuries. It can be used for rotator cuff injuries, Achilles tendinitis, plantar fasciitis, everything. In case of sports injuries of knee, it is similar to what the bone marrow aspirate indications. So for partial ligament tears, meniscal injuries, augmentation for reconstruction procedures, chondral defects. So this is one of the newly developed technique where this is called the BAR implant, which is the bridge assisted ACL repair. This is a scaffold which is consisting of bovine collagen and extracellular matrix. So even in case of complete tear, they are taking this implant and soaking it in human blood, the patient's own autologous blood, and they are keeping it as a bridge between the two ends of the ACL. And they have, in few cases, they have seen that they are finding it that the entire ACL gets regenerated. So limitations of PRP, we don't know the optimum platelet count. It depends on the patient's native platelet count. Patient factors affecting, no standardized protocol, and may require multiple injections. So since we are concentrating the growth factors, this has been not yet approved by the anti-doping agency or International Olympic Committee, and they are still considering this as a performance enhancing method. So on the amniotic, third on the amniotic membrane graft. So this is isolated from the placenta post-delivery. So we are separating the amnion from the chorion. We're taking the amnion layer, and we are using it as sheets. It is also available in powder forms. We have been recently notified by this being done at the King's Institute, Guindy. So these are the various properties of amniotic membrane graft. It provides a matrix. It has wound healing process. It is non-immunogenic. There is no HLA in that, and it reduces inflammation, reduces fibrosis. So the applications, opthal people are commonly using it for corneal injuries. It has been used in burns. In case of orthopedics, can be used for post tendon repair or nerve repair, where we found fibrosis around the structures. Can use it. In case of sports injuries, it is still not yet fully proven, but it can act as a scaffold for bone marrow derived stem cells, scaffold for delivering chondrocytes. So this is the last slide. So when you are considering the healing of bone, we see what it is. We know that osteoinduction, osteoconduction, and osteogenesis. So similarly, in tendon or ligament healing, which is pertinent to sports injuries, we can see that something has to induce the growth, which is in case of tendons and ligaments, which is the growth factors. And we have a product called platelet-rich plasma, which is rich in it. And something must act as a scaffold or a conduction. We have the amniotic membrane grafts and the fibrin clots, which can act as scaffold. And in case of something has to do the groundwork or the genesis, which are the mesenchymal stem cells that we have as a bone marrow aspirate. So we have to find which is deficient in the patient. We have to supplement it. So major takeaways: what are the scope and the products available?
Forward research oriented program for
A nice presentation by Gokuldev. You mentioned about that mesenchymal's stem cell harvesting. For particular cell, you can culture some method by some method and take that particular tissue, as you mentioned. But in the PRP, there are various factors in the PRP. So if you place the PRP in that any tendon or meniscus or any bone injury, how it select that particular stem cell?
Depending on the microenvironment in the native tissue. Multipotent.
Yes. What the other factors will happen? What are, see, for example, all the factors present in the PR is growth factors. If you put the growth factor in tendon, the ligamentization will occur. But other properties, what will happen for the other growth factors? கேட்க புரியுதா? போன்ல வச்சீங்கன்னா போன் இதாகுது, டெண்டான்ல வச்சா டெண்டான் ஹீல் ஆகுது. இப்போ போன்ல வைக்கும் போது மற்ற ஃபேக்டர்ஸ் என்ன ஆகும்? ஏன் எப்படி அது போன்ல வச்சுட்டா போன் மட்டும் தான் ஹீல் ஆகுதுன்னு எப்படி செலக்ட் பண்ணுது?
சார் அங்க லோக்கல் மைக்ரோ என்வரான்மெண்ட் அந்த கெமிக்கல் என்வரான்மெண்ட்க்கு ஏற்ற மாதிரி டிஃபரன்ஷியேட்.
இல்ல அது மாதிரி ஏதோ ஸ்டடி இருக்கா? இப்போ நீ சொன்ன எம்எஸ்சில இருந்து சில கல்ச்சர் மெத்தட்
இன்வைட்ரோ பண்ணும்போது
செலக்ட் பண்ணிக்கிறேன். இது எப்படி பாடியில எப்படி செலக்ட் பண்ணுதுன்னு எனக்கு எதுவும் ஸ்டடி பார்க்க.
Thank you.
You published 2 papers on this. எங்க இன்ஸ்டிடியூஷன்ல 2 papers பப்ளிஷ் ஆன் PRP. அதுல ஃபுல்லா நாங்க ஸ்டடி பண்ணதுல எப்படின்னா ஒரே சிட்டிங்ல 3400 15 மினிட்ஸ்ல நேட்டிவ் அவனுடைய பிளேட்லெட் எடுத்துட்டு அதுக்கப்புறம் அதை எடுத்து நம்ம பண்ணி பார்க்கும்போது இதுதான் ஹையஸ்ட் இதுங்கிறது. நிறைய பேப்பர்ஸ் போட்டு 2 பேப்பர் 2 ஒரே சிட்டிங்ல எடுக்குது. அதில் பார்த்தோன்னா பிளேட்லெட் நிறைய இருக்கா சார்.
Thank you. Thank you, Go. Next, we will have the presentation on petalloid instability by Dr. Uday Kumar.
Morning, sir. My topic is about petalloid instability. These are the topics going to discuss. Hello. These are the topics going to discuss. Introduction. The normally patella is largest sesamoid bone, forms a focal point of obtuse angle between the quadriceps and the patella tendon. The contraction of quadriceps tendon usually tends to displace the patella outwards. Because of the Q angle, quadriceps angle, the lateral force exerted by quadriceps on the patella, which is usually resisted by masses medialis and the medial capsule and the retainer. Biomechanics of patella that acts as a mechanical pulling to extend the knee. The normal function of the joint depends on the patella connecting with the trochanter and the smooth gliding of patella over the trochanter. Normally, first 20 degree of knee flexion mainly depends on the soft tissue such as like medial patellofemoral ligament and the massus medialis obliquus. After 30 degree of flexion, the patella centers over the bony contour of trochanter. So initially, the inferior border of 20 degree of flexion, the inferior border of patella is connected with the trochanter. And then at 45 degree of flexion, the mid part of patella is connected with the trochanter. At a 90 degree of flexion, the superior pole of patella is connected with the trochanter. At extreme flexion, like 135 degree, the medial lateral part of patella is connected with the trochanter. There are 2 types of stabilizers, static and dynamic stabilizer. There are static stabilizer or bony, like a trochanter. So the primary bony stabilizer and the shape of patella, and the main soft tissue stabilizer are medial patellofemoral ligament and the medial retainer capsule. There are dynamic stabilizer where quadriceps muscle versus medialis obliquus. What is medial patellofemoral ligament? Is a major medial soft tissue stabilizer of patella. It is a band of retinacular tissue within the layer 2 of medial side of knee. There are 3 layers of medial side of knee. One is the crurofacial, and the second is the medial patellofemoral ligament, and the superficial MCL, and the third layer is the DSMCL. Medial patellofemoral ligament lies in the second layer of retinacular tissue. It usually attaches to the there is a triangular configuration between the adductor tubercle and the quadriceps tubercle and gastrocnemius tubercle, and then medial femoral condyle, and attached to the medial femoral supramedial aspect of patella. Causes of patella instability: there are soft tissue and the bony abnormalities. Soft tissue abnormalities are medially like a medial patellofemoral like insufficiency and the basal medialis or pupillacea, or laterally there is a tightness of lateral capsule or iliotibial band contracture. Osseous abnormalities like patella alta, if there is a patella alta or a trochlear dysplasia or patella dysplasia, or any other lower limb element like increased femoral intorsion or external tibia torsion, which increases the Q angle, which leads to patellar subluxation or dislocation. Causes of patellar dislocation most commonly is due to the medial patellofemoral ligament injury. Direct injury is a rare cause. Indirect injury is the most common, usually seen in athletes with patient is keep in flexion with valgus and external rotation and sudden contraction of cortices, which leads to patellar subluxation or dislocation. There is a trochlear dysplasia. Already discussed. There is a cross section which is the trochlear sulcus is usually posterior to the anterior femoral cortex. If that is anterior to the trochlear sulcus is anterior to the anterior femoral cortex is crossing sign. Usually seen in trochlear dysplasia. There are 4 types. Type A, the trochlea is shallow, and type B, there is a flat trochlea, and type C, there is a medial facet hypoplasia, and the type 4, there is a medial facet hypoplasia, and the cliff pattern will be present. The shape of patella, based on the shape of patella, the Weber classifies as 3 types. Type 1, the convexity of both medial facet, lateral facet maintained. In type 2, there is a decrease in size of the lateral medial facet, and also the convexity is lost. In type 3, the medial facet is flat. Usually, the patient presents with anterior knee pain and the swelling of the knee, and patient complains of giving away with fall. Usually, differentiate from anterior cruciate ligament. Anterior cruciate ligament injury only the giving away present. In patellofemoral ligament insufficiency, there is a patellar dislocation, there is a giving away with fall, and also patient presents with a genuine valgum and torsional deformities like anterior femoral intorsion and external tibial torsion, and medial facet tenderness and lateral displacement of patella and atrophy of vastus medial esophagus. Clinical examination. Patelloclitis. These are the tests should be done in case of patellar dislocation and subluxation. The patella should be divided into 3 lines divided into 4 quadrants. And then if the patient is supine position with knee is flexed to 20 degree of flexion, and then you tend to displace the patella medially and laterally. There is any medial or lateral soft tissue insufficiency. It displaces more than 2 quadrants. If it displaces more than 2 quadrants, the patelloclitis will be positive. Patella horizontal tilts used to identify the lateral soft tissue tightness. In it should be examined supine position with the knee in extension. The patella will be the middle side of patella will be rotated internally, so that the outer border of patella will be it comes anterior to the medial facet. The nothing come anterior to the medial facet. It means that the lateral structures will be tight. Operation is also used for patellar dislocation subluxation, which the patient supine position with knee in extension they tend to displace the patella laterally, and examine the patient in 15 to 20 degree of flexion. During the flexion, the patient apprehenses pain is to patellar dislocation or subluxation. Already discussed patellar tracking is inverted J sign, usually seen in trochlear dysplasia versus medial esophagus and increased Q angle. Q angle, normally the Q angle is drawn from anterior iliac spine to center of patella and the tibial tuberosity to center of patella. It usually increases in genuine valgum, external tibial torsion and the femoral anterovial. Normal Q angle is male 10 to 14 degree, female 16 to 18 degree. The Baton score, total score 9. If the score more than 4 indicates general practice. Practice for femoral anterovial. Usually it should be done in prone position with the knee flexed to 90 degree, and we have to internally rotate the leg so that the most prominent part of greater knuckle should be palpated. From that point, it should be calculated normally 8 to 15 degree. 5-foot angle. You should measure for a tibial torsion. Patient in supine position with the knee flexed to 90 degree. You have two lines should be drawn, and one along the long axis of the thigh, and one along the second toe of foot. So normally 10 to 15 degree of external rotation should be present. There more than 30 degree, it is to external tibial torsion. We already discussed imaging. Normally, the intercontinental arch of sulcus is the lower border of patella, the Bluman's satellite. The Bluman's satellite, the patella is above the Bluman's satellite is patella alta. If it is below the Bluman's satellite is patella baga. We already discussed intersalvati ratio. The more than 1.2 is the patella alta, less than 0.28 is the patella baga. Backbone pell ratio, you should measure the article surface of patella along the tangent line along the tibial plateau. If they're more than 1.6, 1.06 patella alta and 0.5 is called patella baga. Cotton distance index is also the same. The article surface of patella and then most anterosuperior angle of tibia is measured. The more than 1.2 is the patella alta. Already discussed mentioned. The sulcus angle more than 1.50 degree trochlear dysplasia. Usually lateral patellofemoral angle it opens laterally. There is a medial opening which gives medial patellofemoral stability. Lawrence we already discussed. Normally, tibial tubercle trochlear distance will be less than 15 mm. If the 15 to 20 mm is considered borderline, and more than 20 mm is patellar instability. Normally measured in with a trochlear in CT scan with axial cut. The super portion of tibia. The deepest part of trochlea is considered as trochlear groove, and the most prominent part of tibial tubercle is considered tibial tubercle distance. So normally the distance should be less than 15 mm. More than 20 is to trochlear instability. Trochlear depth already discussed. Normal 4 mm, less than 3 mm is to trochlear dysplasia. MRI shows there is a normal medial patellofemoral limber and there is a patellofemoral. Also osteochondral fragment, the medial side of the treatment. Usually in acute patellar dislocation or subluxation, patient came with complaints of pain with sudden giving away with fall. So you have to reduce the patella by should be in flexion to relax the hamstrings, and then you tend to displace the patella medially to give the knee in extension. After that, the patient should be immobilized and weight bearing as much as tolerated, and the hemorrhagesis present aspiration should be done, and then quadriceps and straight leg resistance and quadriceps hamstring strengthening should be started. Indication for surgery, osteochondral injury and medial patellofemoral ligament injury, and a yearly failure of non-operative management with subsequent subluxation. These are the treatment protocol. These are going to be discussed. There is a proximal realignment of extensor mechanism and a distal realignment of extensor mechanism. In proximal realignment, there is a medial patellofemoral ligament reconstruction and a medial retinacular plication and a lateral retinacular vertices. Distal realignment like oblique osteotomy of tuberosity and the distillation of tibial tuberosity should be done. Medial patellofemoral ligament reconstruction, there are indications like skeletally mature patient and a Q angle should be normal and a trochlear groove and a tibial tuberosity distance is less than 20 mm and a low grade trochlear dysplasia should be normally the semitendinous gravis harvested from the medial side incision, and then you have to incise 2 incision along the along the medial side of patella, 3 centimeters, one along the adductor tubercle to medial femoral condyle. You have to take the incise the skin subcutaneous and along the you have to incise the first layer and the second layer of medial retinaculum should be inside. You have to insert the from second layer of retinaculum to the adductor tubercle. From that, we have to make 2 drill holes along the superior and middle third of patella. From that, the graft is taken along the superior and middle third. Once the graft is taken along the patella, you have to take it along the adductor tubercle. Once you take it along the adductor tubercle, we have to make a femoral tunnel from shortal spine. We will tell shortal spine later. And from shortal spine to superior direction. And then interference should be fixed. The patellar tunnel should be done at the upper 1/3 and middle third of supramiddle aspect of patella. This is a shortal spine. Shortal spine usually drawn along the posterior cortex line, and one along the posterior femoral condyle, and one along the Bluman's satellite, posterior aspect of Bluman's satellite. This is the total spine where we will the femoral tunnel will be created. This is the post-op protocol. Knee brace should be with immobilization for 3 days, full bearing after 3 weeks, and knee flexion should achieve 90 degree at the end of 3 weeks. Lateral release indication like a tight lateral structure preventing patellar censoring and can be done in skeletally immature patient. Lateral release include lateral retinaculum from a distal third of basal lateral release and the lateral patellofemoral ligament and the lateral patellotibial ligament. Distal realignment surgeries, there are indication increased Q angle and increased tibial tubercle and trochlear growth distance of more than 20 mm and a patella alta. There is normal patella glide. Contraindication are skeletally immature patient and incompetent medial patellofemoral ligament. So commonly used osteotomy, oblique osteotomy, tibial tuberosity is the purpose of osteotomy. It means the oblique osteotomy should be done. Oblique osteotomy should be done, and which the anterior translation of tibia should be the anterior and medial translation of tibia should be the osteotomy should be 30 degree of osteotomy, in which every 2 mm media of medialization there is 1 mm of anterior translation to be done, and then the anterior medial translation, and then fix it to cannulated cancellous screw. And the distillation of tibial tubercle is also done in patella alta. You have to measure the division part. If the patella height is 35 and patella tendon is 50 mm, there is a division 15 mm. You have to make 15 mm distillation of tibial tuberosity. So that we have to make a wedge osteotomy, and then we have to displace the patella 15 mm more and then fix with the cannulated cancellous screw. This is a management of trochlear dysplasia. All types are done medial patellofemoral, and only case of type B and type D, the surface deepening trochlear placia should be done. In which the deepest spot of trochlear surface should be measured, and then from medially and laterally 3 to 4 degree lateral entry was made, and then osteotomy should be done. Once osteotomy should be done, the subchondral part is removed and tends to fix with staples. The post-op protocol, immediate weight bearing should be started and no limitation on range of motion. One of the procedure done by Professor Buxi, base answering should be tied to inferior pole of patella and the patella tendon, so that the remedialization should be active by pull of base answering. So the treatment protocol. Thank
you. Okay, very good. Patella is a very, very important topic. Okay. Anyone knows what is the classification for trochlear dysplasia? What is the name? The classification. So next you will have the talk on chondromalacia patella by Dr. Sharma. So this is the last topic. With this,
Good evening, everyone. This is the last topic. I'll try to finish in 10 minutes. My topic of presentation is chondromalacia patella with other few topics, small topics. First of all, chondromalacia patella, it is stemmed from a Greek word, chondros meaning cartilage and malacia meaning softening. It really means softening of the patella cartilage. So, there are various causes for the chondromalacia patella. This miserable malalignment that we should be focusing on, it has a triad of excessive femoral anteversion, external tibial torsion, and foot pronation. All these conditions lead to increased Q angle. This is the picture depicting the excessive femoral anteversion, external tibial torsion, and foot pronation. All these will result in an excessive Q angle. The result of excessive Q angle is the patella tends to subluxate laterally. With the repeated lateral subluxation, there will be erosion in the lateral facet of the patella. This is the primary pathology for chondromalacia patella. Pathology, there are 4 stages in the development of chondromalacia patella. The first stage, it usually starts with the blister formation, and there will be loss of resiliency.
Second stage, there will be fissures extending to the subchondral bone. The third stage, there will be crab meat appearance in which there will be extensive fibrillation. The fourth stage, there will be complete loss of cartilage with the exposure of subchondral. This is the modified outer bridge grading, which was discussed in detail by Ranathan. This MRI image shows the first image. There is the normal thickness of the articular cartilage of the patella with abnormal intensities, which indicates the stage 1 of outer bridge grading. The second image, there is a partial thickness loss of cartilage, and the third image shows complete loss of articular cartilage with bony edema in the patella. Types of chondromalacia patella. There are 3 types: primary, secondary, and adult type. Primary without any pre-existing cause, it is self-limiting condition. Secondary, there usually results from trauma or some pre-existing condition. This usually leads to osteoarthritis. And third is adult type, which occurs in the second decade of life. Primary type, it is more predominantly seen in female, and they usually presents with the anterior knee pain, which worsens with the climbing stairs, squatting, and kneeling. There's a sign called cinema sign, which there will be prolonged sitting with the flexed knee causes result in knee pain, and which is relieved on knee extension. That is how we usually sit in a cinema theater. It's called cinema sign. On examination, all the passive movements, repeated flexion extension movements of the knee joint will be painful, and grating sensation can be felt, and Clapp's sign is positive. So what is Clapp's sign? With the patient's knee extended, using our first web space of the hand, we should give a downward posterior thrust on the superior pole of patella, and we should ask the patient to tighten or contract the quadriceps. This results in a sign which indicates chondromalacia patella. This is called the Clapp's sign or patella grinding test. Secondary chondromalacia patella, which is due to a direct blow or twisting injuries. It is associated with medial meniscus injury or pre-existing conditions like a repeated patella subluxation, genu valgum, and patella alta. With advancing age, this type will progressively lead to osteoarthritis. These patients usually pressure with the same anterior knee pain associated with buckling and instability. There will be a history of giving away sensation. On examination, there will be retropatellar tenderness and lateral displacement of patella. Investigations, the X-ray shows irregularity in the subchondral bone of the articular surface of the patella, and CT scan to rule out any abnormalities in the trochlear geometry, like trochlear dysplasias. MRI, this is the modality of choice for to look the articular surface pathology. That image shows articular irregularity with a central defect. Arthroscopy, this image shows the normal patella. The right one, it has a fragmented articular surface of the patella. Arthroscopy, this is the most efficient mode of diagnosing chondromalacia, and it helps to determine the exact location and size of the lesion. Treatment for chondromalacia patella, it is mostly conservative, and to put the patient on NS series. And this is McConnell taping. The primary pathology is recurrent lateral subluxation. Here we tend to medialize the patella and we put a tape. This will immediately relieve pain for the patient. And we can also put the patient on medially directed knee braces for a period of 6 to 12 weeks. Not recommended is patella cartilage excision, staving, drilling, proximal and distal realignment surgeries. And recurrent subluxation and patella alta has been discussed by the previous speaker. And physiotherapy, we should put the patient on closed chain kinetic chain exercises with the terminal degree of knee extension. Isometric quadriceps strengthening exercises can be advised. Isotonic exercises will lead to increased pain, and semi-squat exercises are proven to be more effective than straight leg raising exercises. And these are the exercises which the patients need to avoid. And moving on to the case scenario, this is the last case scenario. A 14-year-old boy who is a soccer player came with a right knee pain for 3 months. It's aggravated on squatting and kneeling. On examination, there is a visible lump present on the anterior aspect of the knee. It was tender, and assisted knee extension was painful. This is the X-ray of the patient. Anyone can tell them? This is the case of Osgood-Sackler disease. There are various synonyms for this
condition, osteochondrosis, osteochondritis of tibial tubercle, tibial apophysitis, rugby knee, tibial tubercle apophyseal traction injury. This was named after two physicians, Robert Osgood, Dr. Carl Shackler, in the year 1903. It is an irritation of the patellar ligament at the tibial tuberosity level. It is commonly seen in adolescent and young athletes. It is usually due to repeated microtraumas due to overuse. It is commonly seen in boys of the age to 12 to 15, and it is 30% bilateral. Commonly seen in basketball players, volleyball players, and who participate in gymnastics. This is the ossification of tibial tubercle. You can see by the age of 11 to 14, the tibial tubercle apophysis is formed, but it is not fused to the epiphysis of the proximal tibia. In this stage, due to repeated overuse, this condition develops. At the age of 18, the epiphysis, the tubercle fuses with the remaining portion of the proximal tibia. Pathology: repeated stress from contraction of quadriceps is transmitted to the patellar tendon to immature tibial tuberosity, which results in multiple subacute avulsion fractures, which leads to excessive bone growth in the tibial tuberosity. Recent studies shows that the athletes who, like 100-meter sprinters, they will have limited ankle dorsiflexion. This limited dorsiflexion is compensated by increased knee flexion, tibial inversion, and foot pronation in the stance phase of running. This leads to increased stress on the patellar tendon, which ultimately results in this condition. The patient usually presents with pain, which is mild in the early stages, with the severe pain in the later stages. A swelling can be seen, and a provocative test of resisted knee extension will be painful. Investigations: the X-ray shows irregularity and fragmentation of the tibial tubercle and thickening of the patellar tendon on the MRI. These are the differential diagnosis for the Osgood-Shackler disease: Sinding-Lawson-Johansson syndrome, which is the osteochondritis of the inferior pole of patella, patella subluxation, patellofemoral pain syndrome, jumper's knee, housemaid's knee, tibial tubercle fracture. The treatment of management is mostly conservative with analgesics and bracings. Surgical management is usually not advised. In case if it is needed, excision of the intratendon ossicles only after skeletal maturity and only for refractory cases. If we intervene the patient before skeletal maturity, we tend to fuse there will be premature fusion of the anterior epiphysis, which results in genu recurvatum deformity. Some of the prevention exercises: the athletes should perform regular stretching exercises before performing athletic events or gymnastics. These are some of the stretching exercises. So finally, this is the last slide. Can anyone? That's the case of Lawson-Johansson syndrome. This is the exact counterpart of Osgood-Shackler disease. In Osgood-Shackler, there will be patellar tendon distal pole will be involved. In this case, proximal pole, where it is attaching to the inferior pole of patella, it is involved. This is most commonly seen in adolescent boys. The cause is same as the Osgood-Shackler disease, repeated strain, and the management is also same as Osgood-Shackler disease, mostly conservative. Thank you.
Thank you, Sarno Sundaram. Thank you. Questions, sir? No, nothing. Okay, thank you for your patience. Ramesh, can you hear me?